पहले 25 मिनट में एक इंटीमेशन कर देना, थोड़ा सा टाइम रखिए।
Good morning, all of you. I, Dr. Naveen Sharma, welcome you all to the webinar on recent advances in ENT 2021. We all members of ENT fraternity are well aware that our specialty is one of the surgical branch that has evolved rapidly over past few decades and is continuously doing so. In view of this, in 2014, recent advances in ENT, a proposed annual event was started by our department to keep ourselves abreast with ever-changing scenarios in our specialty. It being the brainchild of our dynamic and energetic HOD, Dr. Uma Garg ma'am, it evolved in the form of one state conference, various live surgical workshops, CMEs, and other activities which are now a routine affair for the department of our ENT and HNS at our BPS Government Medical College for Women located in Kanpur Kala, Sonipat district in Haryana. As we all know, year 2020 had been difficult for us due to obvious reasons. But as we all have now decided to move forward with caution and precautions, we decided to resume our academic activities in form of a webinar. Without wasting much time, I again welcome all our distinguished speakers, moderators for the various sessions, and all the delegates. Our first session is on an interesting and challenging topic, that is thyroid. Talk will be delivered by Dr. Uma Garg, Professor and HOD, Department of ENT and Head and Neck Surgery at BPS GMC for Women, Kanpur Kala, Sonipat. She has been leading the department since its inception and has taken our department to new heights. She is an academician par excellence, has more than 50 international and national publications in journals of repute. She has been part of various examination and interview panels of prestigious universities all over India, and she is an active member of various professional bodies of concerned specialty like AOI, both national and state branch, FHNO, IOA, HNS, and IMA. She has keen interest in head and neck surgeries, and she is leading a plethora of researches being done in our department relating to head and neck malignancies. I invite Dr. Uma Garg ma'am to enlighten us on the topic of recent advances in thyroid relating to both pathologies and their management. I also invite my co-moderator for the session, Dr. Ashish Varghese from CMC Ludhiana, who is a well-known name amongst all the surgeons who have interest in thyroid. Welcome, Dr. Ashish, sir.
Thank you, Dr. Naveen.
Thank you, sir. Sir, now I invite you to take over the proceedings for the next session.
Dr. Uma, you can start your presentation and we can have discussion and all those things at the end of the talk.
Good morning, all. As Dr. Naveen has already told you about the webinar today, in the time of COVID, since physical conferences were not possible, so we planned this webinar named as Recent Advances in ENT 2021 to keep the residents and budding consultants abreast of the recent advancements in ENT. And the delegates, juniors, will be benefited with the knowledge and expertise of various esteemed speakers and invited faculty in this webinar from various institutes. The first talk today is on recent advances in thyroid diagnostics and treatment. Since thyroid is a vast subject, is a huge topic, so I will be presenting only an overview on thyroid. derangements in the structure and function of thyroid, they are very, very common. Meaning changes in anatomy and physiology are very, very common. And when there is a structural change, that is anatomical swelling, a goiter, or an incidentalloma, or detected otherwise, they are mostly benign. And very rarely they are malignant. And when there's a change in physiology or functioning of thyroid gland leading to hypothyroidism, which being overt or subclinical, or increased function, that is hyperthyroidism, they are also very commonly seen clinically. But in both the situations, most of the times, confusion remains whether treatment is needed or not, and if needed, then what. So now, next, we'll talk about hypothyroidism. Hypothyroidism is a very common clinical entity and needs concern particularly when it is subclinical. Should be optimally treated, never undertreated. So whenever hypothyroidism is there, we do a TSH estimation, which is raised. But that doesn't suffice, and an estimation of anti-thyroid peroxidase bodies is must. And this is must because the patient will require a specific treatment of autoimmune disorder, which is responsible for anti-TPO. Also, this estimation will be needed for screening or follow-up for a malignant change like Hashimoto's thyroiditis, which on long-term follow-up can lead to lymphoma. And therefore, in that follow-up, again, anti-TPO body come handy. When we are investigating a female for infertility and hyperthyroidism is there, that case also anti-TPO is must because we have to treat the patient for that specific condition, and that is why the role of also when we are investigating hypothyroidism, you must investigate the patient for diabetes as well as metabolic syndrome. The components of metabolic syndrome being high blood pressure, high blood sugar, hypercholesterolemia, and obesity. Because in these conditions, if this is along with hypothyroidism, along with metabolic syndrome or diabetes, these all taken together may lead to various cardiovascular complications and cerebrovascular accidents or stroke. Coming to diagnosis of hypothyroidism, TSH will be decreased and therefore will be estimating the levels of T3 and T4. But in this case also, anti-TPO levels are to be determined because an important disease, Graves' disease, that is an autoimmune disease, and that in that case, it will help us. The next important investigation required in hypothyroidism is thyroid scan, because thyroid scan will help us in determining the part of the thyroid nodule or thyroid gland which is functioning, hyperfunctioning, or isofunctioning. Now, after deciding about the function of thyroid gland, in case there is a thyroid swelling or a goiter, USG is considered. But a thing is to be remembered that USG is not to be used as a screening tool in general population. So it is indicated only when a nodule is palpable or thyroid is palpable. Now, ultrasonography tells us about the size of the nodule or thyroid gland, shape, echogenicity, vascularity, consistency, relation to the surrounding structures, calcifications, and much more. And by this also helps in deciding the most suitable area for cytological aspiration. Now, ultrasonography report by an expert ultrasonologist is of great help in further planning of the thyroid disease. Now, if you think about ultrasonography, then American College of Radiology has given the word a system for scoring of ultrasonological findings in thyroid, and that is TIRADS, Thyroid Imaging Reporting and Data System from 2018. This has classified thyroid swellings into various categories, thyroid 1 to thyroid 5, where a scoring is done depending on the ultrasonological findings, and then depending on the scoring, it is classified as benign with the probability of malignancy and what would be the proposed plan. Like in thyroid 1 with score 1, it is benign, score 0, it is benign 1, probability or chances of malignancy is only 0.3 and no FNA is required. Or if you come to thyroid 4, there the score is 4 to 6, moderately suspicious of malignancy, though chances are 9.1% only. In this case, if the size of the nodule is about or more than 1 centimeter, only follow-up is required. And if it is more than 1.5 centimeter, then FNA is required, but patient needs to be followed up for a period of in the first, second, third, and fifth years. No, alone USG was not sufficient. So the scientists or the radiologists, along with USG, they considered elastography and color Doppler. And combining all together, they developed a new algorithm or a new system, which is known as thyroid multimodal imaging for comprehensive risk stratification scoring, TMC RSS scoring system. And as I told you, this is based combined on USG color Doppler and elastography. It has got some positive predictive factors which will go in favor of malignancy and some negative predictive factors against malignancy, and a net score will be calculated. So positive predictive scores in all these three are elastography and pathologically altered lymph nodes, which are given a score of +3 each. Then +1 score is given to the score is given to the finding if the nodule is taller than wider, microcalcifications are there, there's a central plus peripheral vascularity, hypoechogenicity, a solid composition, and a blurred and poorly defined margin. And +0.5 score is given to an irregular halo or a diameter more than 1 centimeter. Well, negative predictive things which point towards benign, -3 or 3 points are subtracted if the nodule is purely cystic. 1 point is subtracted each for spongiform nodule or with a comet tail artifact. And 0.5 is subtracted if there's a complete halo or only peripheral vascularity. After calculating all this, the negative are subtracted from the positive ones, and the net score is used to calculate the percentage risk and risk of malignancy. If the score is less than 3, percentage risk is 2.4, and there's a low risk of malignancy. And if it is more than 6, then percentage risk is 79.6, and there's a high risk of malignancy. Then, besides this, radiological investigation is scan of the thyroid with radioactive iodine or technetium-99. And this is especially important in diagnosis when the patient is presenting with hyperthyroidism and also follow-up of thyroid malignancy after treatment. And these are the various scans showing where the uptake is less, that is known as cold nodule, many times malignant. And when the intake is less, that is, when the intake is more, that is hot nodule. And the comparison of the nodule and the surrounding thyroid tissue and thyroid activity is seen. After radiological investigation, next is important is aspiration cytology or FNAC, which is being done since decades, and this is proving to be a economical, easy, and a quick method for diagnosis of thyroid disorders. And since a decade or so, we are following Bethesda classification, which depending on the cytological characteristics that divides all the thyroid cases into 6 categories from non-diagnostic, benign, AUS, FLUS, third, follicular neoplasm, suspicious of malignancy or malignant. And like, for example, The category 2, where they're classified as benign, there are only 0 to 3% chances of malignancy. But problem in Bethesda is with indeterminate category. That is category 3 and 4, which is atypia of unknown significance or follicular neoplasms of unknown significance or neoplasm suspicious of follicular neoplasm. These patients, because it is an indeterminate category where it is difficult to decide accurately, so these patients are kept on follow-up, but ultimately they land into thyroidectomy for reaching the final diagnosis. But it is to be seen that sometimes from a study, only 8% out of 100, only 8% come out to be malignant and rest of them are benign. Though 8 to 56% is the rate of malignancy according to various studies. So to deal with this inaccuracy and to prevent unnecessary thyroid surgeries, here the role of molecular studies come. And this is the advancement in the thyroid diagnostics for cancer. These molecular diagnostic investigations are done to know the genetic alterations or mutations in the molecules by advanced techniques which are immunohistochemistry or microRNA studies to know expression of different proteinaceous or protein tumor markers which are more expressed in cancers of thyroid. So this may help in avoiding undue thyroid surgeries. And various molecular studies they are studying. This is BRAF, for example, RET-PTC1, RET-PTC3, HRAS, KRAS, NARS, PAX8, and TRK. And the scientists or the pathologists, they are considering a panel of 7 to 8 genes, which is important in this case. In addition to estrogen receptors, which are important to know because they are responsible for more thyroid diseases in females. Estrogen receptors are described both in neoplastic and non-neoplastic human thyroid tissue. By IHC studies, they are estimated. Both estrogen receptor alpha and estrogen receptor beta, they play a role in cell growth in proliferation, and beta plays a role in suppressive actions and apoptosis respectively. So ratio of the two could help in some cases. So when these genes or mutations are being expressed, they not only go towards accurately diagnosing a thyroid cancer case, but when these are being expressed, they also tell us that tumor may be more aggressive. The other genes are BRAF, which is seen in 66% of malignant melanomas, but 44% of this PTC, that is papillary thyroid carcinoma, but it is not seen in follicular thyroid carcinomas or adenomas. And this BRAF mutation was also seen in anaplastic cancers. Similarly, another mutation of RAS, which is a proto-oncogene, this also occurs or is seen in papillary thyroid carcinoma and follicular adenoma and carcinoma. Then RET is another mutated gene where alteration has occurred on chromosome 10, and this acts by tyrosine kinase, which regulates cell growth, survival, dedifferentiation, and migration in thyroid cancers. And this altered gene can initiate papillary thyroid carcinoma, and it's also expressed in papillary thyroid carcinoma. Therefore, sometimes, and it is seen sometimes that both RET, BRAF are expressed in papillary thyroid carcinoma. But again, the problem with molecular studies is that high cost, sometimes 40 to 50,000 rupees INR, that is the cost for a single molecular study or molecular test. And then it's not available in all the parts of India. Third problem comes that a single marker sometimes may not be accurately telling you, accurately guiding you to decide about the plan of treatment. So for diagnostics, now we can say that whatever recent advances we have come to know of, but fine needle aspiration cytology, along with USG or the score, combined score of elastography and color Doppler, and hormone estimation along with scan, these all combined together are taken, and these are the most important 3 investigation, which after doing which we'll be able to decide the further cause. So they have to be taken together or combined. They're complementary to each other. Not one test will tell you something. If you come to treatment, for hypothyroidism, it is just not sufficient to supplement thyroid hormones. You have to treat optimally. A combination of both T3 and T4 can be used. The thyroid hormones can be used intravenously, subcutaneously, or intramuscularly, like in myxedema crisis. There is a role of thyroid transplant also, which was started by Cocker himself, but it was not taken further. And there is also a lot of scope in stem cell studies and stem cell therapy in case of thyroid cancers. Hyperthyroidism, again, there's a great role of antibody estimation and radioiodine scan in diagnostics. Treatment-wise, antithyroid drugs are given, and also there is a role of radioactive iodine ablation. But recent advancement supports role of radiofrequency ablation of secreting thyroids or thyroid nodules. Now, most important point in thyroid is know about cancers. So most of the thyroid cancers are differentiating cancers, and they are papillary thyroid, follicular thyroid carcinomas, and medullary carcinomas, differentiated ones. And as were conventionally or traditionally doing, the surgical part consisted of a hemithyroidectomy or a completion thyroidectomy or a total thyroidectomy with or without neck dissection. And we had started with this, the classical coccus incision about 2 centimeters in the suprasternal area. And as we progressed to have less complication, a better cosmosis, it was reduced in size, but minimally or massively involved. Then surveillance is very, very important. Use of recombinant TSH and role of PET scan. The strategy in anaplastic remains different, and there's a role of tyrosine kinase inhibitors or targeted therapy, which are lenvatinib and a class of all these. But for this, molecular studies are must, and if mutations are absent, then lenvatinib can be given, and sometimes a combination of these tyrosine kinase inhibitors are given. These are the advancements in surgery. Robotic mini incision is just coccus incision done small, and then MIVAT or minimally invasive video assisted thyroid surgeries, which are truly endoscopic or endoscopic assisted. And this is a picture for a minimally invasive video assisted thyroidectomy started in 1999. And this is the axillary approach. And with the axillary approach, even bigger thyroids can be removed with the axillary approach. And then there's an anterior chest wall approach or BABA approach or bilateral axillary breast approach. And in robotic, we have 3 approaches: transaxillary approach, retroauricular approach, and latest is transoral approach or vestibular approach. And here we are showing you a picture of retroauricular approach. This is done by Da Vinci robotic system, and the procedure was initially described by Kang et al. In 2007. There are 3 steps: working space creation, docking, and console. This topic will be taken in detail by Dr. Surendra Dabas. Now, if you compare these new techniques, learning curve is less in minimally invasive video assisted as compared to robotic. Complications are comparable. Pain is less in minimally invasive, but cost considerations are very high, where in minimally invasive sometimes comes out to be maximally expensive. Then there's radio frequency ablation for some of the thyroid cancers as well as hyperthyroidism. And this is a new thing which has come up. The studies are going on. A single case report in Annals of Thyroid 2020 shows regression of papillary thyroid cancer using metformin. So alternative methods for dealing with. The take-home message is, though advancements will continue, but adequate comprehensive evaluation, not ignoring the conventional traditional methodologies, selecting the most suitable candidate for any new trial or methodology, and not forgetting the cost factor in settings is a must. It's very important to remember that thyroid cancer being indolent, aggression is not at all desirable, and more studies at centers with huge volumes are definitely needed. Thank you.
Thank you, Dr. Uma, for that excellent presentation. And summing up everything in the last slide, I would like to just, am I audible, Dr. Uma? Just lift your finger and show me. Is it, hello?
Yes, yes, we are listening.
Yeah. So the last slide is a very most important slide, I think, So one point I would like to touch from that slide as a comment for this talk is every thyroid nodule, a surgeon must have a sieve, okay, a sieve of CAP. C is for a clinical diagnosis, anatomical diagnosis, and pathological diagnosis, which should start from the time the patient is sitting in front of you. That is history taking, examination, and investigation. All three you can, get. So, and then you follow this up. Once you do a good history and examination, then only you go to investigation, and you will have a rough diagnosis. What is a clinical diagnosis? Whether this patient is a hypo, hyper, or a euthyroid. Second is anatomical diagnosis, whether this patient is having a solitary thyroid nodule, multinodular goiter, or a retrosternal goiter. And the third is a pathological diagnosis, whether it is malignant, benign, or suspicious or intermediate. So every nodule must have this diagnosis, and then only you proceed with the treatment. Okay, Dr. Uma had mentioned briefly about. Hello. Yes,
Yes.
she had mentioned about supplementation with T3 T4 for hypothyroidism. Usually that is it was in between people were using it, but now it's not. We give only plain T4 supplementation because T3 has its own problems. One is T3 has to be given 3 times a day because its half-life is 8 hours. You have to give 3 times. It's very unstable. It's active form, reserved only for mixed edema patients. And T4, in fact, you had mentioned about Cocker. Cocker was doing a complete thyroidectomy, in the sense total, without leaving any thyroid tissue behind. So all his patients were landing up with very bad hypothyroidism. So what he was doing is he was going to the butcher shop, getting the goat thyroid and giving the patient once a week goat thyroid extract. And his patients are improving on the hypothyroid symptoms. That's how in 1900, early 1907, 8, he was supplementing these patients with T4 and thyroid hormones. Okay, so that's an excellent talk, Dr. Uma. Any questions from anybody? Do we have an option of asking questions by the audience?
Yes, sir. We are having option of asking the question.
Yeah. So if anybody has any questions, we can. We have another 2 minutes or 3 minutes. They can ask.
So no questions for this session.
Okay, one more last thing, let me tell you. Thyroid scan needs to be reserved only for hyperthyroid patients. We don't use it to find out whether it's a cold nodule or a hot nodule, because it is replaced by ultrasound. A good ultrasound with a ThyroIds would tell you whether it's a clearly benign, or it's malignant, or it's an intermediate. And then accordingly, you take the next investigation, that is the FNS. Okay. So that's all I have, Dr. Naveen. Thank you.
Thank you, Dr. Ashish, for being with us.
Thank you, Dr.
Welcome,
Ashish. So our next session is on middle ear implants by Dr. P.P. Singh. For that session, I hand over the proceedings to Dr. Amit Sharma for moderating this session.
Good morning, everyone. Good morning, everyone. We invite everyone for this recent advances. We have a privilege of having P.P. Singh, sir, the senior consultant ENT and a cystoscopy surgeon, presently working at Fortis Hospital. I would like to give a brief intro for P.P. Singh, sir. So, sir, after obtaining his specialized training in ENT in AIMS, Delhi, and subsequently he had been heading the department of ENT as director professor at UCMS and GTB hospitals, Delhi. Sir is keenly involved in teaching and training the ENT residents, had conducted workshops, courses on middle ear surgeries and chalendoscopy. Sir has been invited as a speaker for more than 200 conferences in India and abroad. He establishes the first chalendoscopy center in India in 2005 at GTB Hospital. In the past, sir had been the president of NES and ISO. We welcome you, sir.
Yeah, thank you. Thank you.
And sir will be presenting a talk on the middle ear implants. And for this session, sir, we have Dr. SPS Yadav, sir, with us. And I would like to invite sir, who has been a teacher from and a former director, professor, and head of the department as PGIMS Rohtak. And it is an honor for us to have him with us for the moderation. We welcome you, Yadav, sir. Sir, PP Singh, sir, you can take this thing, sir. You can start your slides, sir.
Okay. Thank you, Dr. Yadav. And of course, the organizing team, Professor Uma Garg, Dr. Amit, and of course, all the faculty in the department. Now, I'll be talking on middle ear implants, and frankly speaking, I have not talked about any ear presentation for a couple of years because of involvement with chalendoscopy and its propagation and holding courses, etc. Anyhow, so it's a kind of coming back, and I'll be talking about middle ear implants. Upfront, I want to say that, of course, middle ear implants are divided into two. One are called active, and one are the passive one, which we usually refer to as prostheses. So we'll be limiting our talk to prostheses and not the active implants. And in next 25 minutes, we'll be talking about these implants. I thought a lot about it, and I decided that I'll be mainly discussing the concepts and not showing you mostly the pictures of these implants in situ or otherwise, because unless you understand the science behind it, I think most of these procedures will not be successful without this knowledge. So this panel shows you, there are three panels, and first, of course, is the ossicular chain. The ossicular chain is what we replace with middle ear implants or prostheses. And of course, before we replace anything in the body, we need to know how it functions if we want to recreate the same function. So we need to know how good or how bad it is, or how it really functions, so that it can be simulated. The second panel shows you the recent advances, as your webinar theme is, that this is one of the ways we investigate the middle ear now. This is called finite element modeling. What you can see is the picture of that. And you can see one implant being introduced in that ossicular chain to study its effectiveness. This all is computer-based and does not require any experimentation in that sense. The third panel, of course, is the in situ picture of a total ossicular replacement prosthesis. And the focus here is on stability of this implant, because total implants are very prone to displacements because of the pressure variations in the middle ear. And here I want to point out that you have something which is not used frequently. This is the cartilage shoe, which is being popularized by a lot of people from Western world. So this is called cartilage shoe, and in the cartilage shoe, which fits into the hole window niche, below this, of course, is a three-piece foot plate, which ought to be mobile. You have this hole, and into that is the lower end of the stem of the prosthesis, so that it remains stable. And as we go along, you will realize that stability is the key factor in the performance of any prosthesis. Because if this is not in place, then it really does not matter whether your prosthesis were expensive, whether it was laboratory bred frequency optimized prosthesis, etc., made of really noble matters or something. The prosthesis has to be in place to create a continuity between the tympanic membrane and the foot plate. Otherwise, it's of no use. Now, to be a good middle ear surgeon, or for that matter, to be, of course, good middle ear implant surgeon, as I told you that we need to know that how does the middle ear function. Now, as you would see in the left panel, that sound vibrations are vibrating the tympanic membrane, and through ossicular chain, this sound energy is being transformed into mechanical vibrations of the ossicles, and they are being conveyed to the inner ear, where it's translated and deciphered that what information has to be sent towards the brain. And I just want to point out, and this is, I think, very important for junior colleagues and, of course, budding pathologists or residents for that matter, that whenever we operate on the table, we are only thinking of static picture. Like when you're operating, you have middle ear open to you, you have done canal wall down mastectomy, you have stapes, let's say, in front of you. Then our soul aim in our mind, it just comes that we have to put something between this and the tympanic membrane or the graft at that time. But we usually don't think that how this will act, how this will function when the patient goes into real life. Because on the table, nothing is vibrating, but in the real life, everything will be vibrating, which will be going into the ear. Unless it's vibrating sound or, the vibrating structures, nothing you can hear. So you have to think the dynamicity of the middle ear, that how does it really function, the different amplitudes and frequencies of the sound. Is it a single way of, a single process by its functions, or there's a differential process which happens depending upon the amplitude and frequency? So I think we'll be touching upon it, some of it. And this is being propagated by an organization called MEMRO, which hold meetings every 3 years. And I have been a regular attendee of these conferences and have contributed much to the knowledge of middle ear implants, at least for me. Second is the cartilage, how to use cartilage. And you have the cartilage knife. Again, I think we'll be discussing it further down. Now, as I said, that we need to know that how does the middle ear function. And from various studies, which again we'll be discussing, whether it's finite element modeling or laser Doppler vibrometry or the earlier techniques which were used like Mossberg effect, etc. Now we know that middle ear is a masterpiece of engineering, and it achieves a lot of there are a lot of characteristics which it has. And we have realized that basically you need to have aeration of the middle ear, which is, of course, precisely maintained by the middle ear, which means that the atmospheric pressure should almost be equal to the pressure in the middle ear. And second is that the direction of transmission of the energy is perpendicular to the surface of the foot plate. And this has been found to be the most optimal way of transmitting energy from middle ear into the inner ear. And this is, of course, achieved by the middle ear, as you can see. This stapes, ultimately, the stapes, which is connected to inner ear, always goes in and out like a piston. So this movement is perpendicular to the surface of stapes. The third characteristic is that it has to be an intact chain. It's intuitive, quite intuitive, which means that there should be no gaps, no breaks. And we will, of course, discuss that how implants come into picture when there are gaps or absence of these ossicles. And it's stable. Everything is where it is supposed to be, and this is called the stability of the system. It basically also means that in the system in between the tympanic membrane and footplate of stapes is continuous and is not prone to displacement. Now, this is one way of, this comes in real recent advances, the laser Doppler vibrometry, which is kind of a workhorse of middle ear research for last 30 years, maybe across all the important middle ear laboratories in the world. This is a setup basically trying to show that in the external canal, we put the microphone, etc. And with laser Doppler, we measure the vibration of the stapes. And this, in short, is the laser Doppler vibrometry, the graphic presentation, that you have the microphone here, you have a scanning vibrometer, which is coupled to the computer, where the signal generation, signal acquisition, processing, and display is done. And you can, like when the sound given into the external canal is picked up by the laser Doppler vibrometer here, which is connected, which is focused on the footplate, and this is then translated back into sound in the computer. So that was a sound given, and then let us see what happened when it collected the data and processed. And when we open the computer, we can study that. What did we get? So you got the same thing. So this allows you to study the middle ear with its various variations, the variations which you can create, the middle ear implants you can place in between them. And this middle ear chain is prone to different kind of defects, which were classified by Austin Cartouche. As you can see, most of you must have come across this because this is given in most of the books. So depending upon the level of the defect, it's classified into A, B, C, D, and then 3 more categories were added by Dr. Cartouche. And so we can simulate these defects and then study the transmission of the sound by the setup I showed you, the laser Doppler vibrometry, and then know that how it works without implant, what gain you can acquire from the middle ear implant. You can study different implants in the same setting and know which one is the best, and many other parameters. Now, do we have any a model of ossiculoplasty which we can refer to when we are reconstructing the various defects? And one of the models, to my mind, is the stapes surgery. This is simplest yet the most successful ossiculoplasty. We are using a middle ear implant, although we don't classify it as that. This is taken as separate category. But of course, ultimately, this is middle ear implant. And we know that the success rate of stapedectomy is one of the highest in ossiculoplastic techniques. And there are basically 2 factors which contribute to this. That is one is the stability, what we were talking, that this remains stable here. And this stability is increased by having different designs of this prosthesis, which clamp onto the long process of the incus, and they stay. And second is the perpendicularity, that ultimately the shaft moves like a piston in and out and recreates the actual physiological conditions which are conducive to normal or almost normal hearing. So this is one model of the ossiculoplasty. The stapes model has certain features and which probably give rise to the normal hearing or almost normal hearing. These are listed here, and as I told you that these 2 are the most important ones. Then we can recreate these, as I told you, in the system only, and you have different kind of implants. I'll not go into detail. These are the hydroxylapatite, and these are the titanium. These are the 2 most commonly used materials for fabricating the implants. If you go through the various catalogs, especially the Coors one, the Medtronic, the Audio Technologies, and Grace Medical, you will probably get more than 100 designs of the prosthesis, so I think we will not go into details. As long as they fulfill the conditions which I'm going to show you, the stability, the perpendicularity, I think most of the implant would give you the same results. So many implants were created because everybody thought that let me attach my name to it with little variations. No doubt there have been innovation. But as I said, that the principles which guide the performance of the implant, they remain same. Now this is, as I told you, that when you remove incus, then what happens? So you can study this in the temporal bone laboratory, middle ear laboratory. You remove it, then you give sound, you record it, and you get the loss or depending upon. And then you can in the temporal bone itself. This is a graphic presentation. This is actually the setup. Actually relates to a temporal bone dissection and creating these middle ear defects as per the Bartusch classification. Then you have this pot which has been placed, and then you can start studying it. You can vary its position on the tympanic membrane. You can place it under the handle of malleus, and all these different conditions are recorded and then studied. And this is one such study. This is from Dr. Thomas Zahanard, University of Dresden, which has been kindly loaned to me. And then you see. That is the handle of malleus. That's the stapes, tensor tympani tendon. So as it touches the handle of malleus, you have a better transmission. So anyhow, this was a short clip just to demonstrate to you that you can recreate these situations and study them and decide you can fabricate the new designs, you can fabricate the shape, etc., weight, etc., to see which implant works best in those conditions. And then you come on to clinical trials rather than trying them directly, which was, of course, done a couple of decades back. So this shortens the process of introduction of newer prostheses. Now, this is a case where you only have stapes in which we are using this implant. This is hydroxylapatite. You can see we have made a notch which goes on to the stapedius tendon. And in this case, you will realize that you can see the implant lying here loose. And when I inquired from the patient, she gave the history of a slap by her husband, after which immediately she lost the hearing. So it seemed that pressure variation caused by that force resulted in the outward, or of course, the outward movement of the tympanic membrane, and this implant came. So this shows you the importance of the stability. That implant must stay where it was placed. This is the same picture with Valsalva. As you can see, the TM balloons out. So that was the reason that the implant came out. And then different designs have been created so that it clasps onto stapes so that it does not come out that easily, even when the TM gets lateral, is pushed outward. And this, of course, is again the live surgery. You can see the stapes, and I want you to, in fact, this slide I'm showing you from cartilage standpoint, that you have a cartilage which is roughly 3 millimeter thick. This is roughly 5 or 6 millimeter, or probably, yeah, I think so. And we are going to use the POP, which is POP with clip, and this cartilage, and I'd like to show you the importance of this cartilage. Now this prosthesis was developed, as I told you, the lower end you have this, which clasps onto, it has 6 prongs, and they just snap onto the head and neck by pressure. And when you press, it opens up, and then when it reaches the neck, it again closes down. And in this, the head plate has been designed with ball joints so that it can be placed in any position which conforms to the anatomy of the given middle ear, as we will show you. And this head plate now is being manipulated so that its tip touches and is under the edge is under the handle of the malleus, as you can see here. And then we place the thinner cartilage on the head plate. You can see that malleus, and it's a direct connect between these two. When we move malleus, everything moves. And then we show you the post-op picture of this after 6 months. You can see here, this is the cartilage which was 0.3 millimeter. This was roughly 6, 7, whatever, 0.7 millimeter. And you probably can see the shadow of the head plate of the prosthesis. This patient had 20 decibel ultimately after 6 months. The healing happened, and like trying to show you that how you can get good results. And the idea of cartilage, all the titanium prostheses which come in contact with tympanic membrane need to have cartilage interface, otherwise they might get extruded. And mostly we have seen, it has been my experience, that the cartilage placed on the lower ridge or on the canal wall is usually the tragus cartilage taken directly and placed and not thinned enough. And you can see here that in this situation, this is a posterior canal wall. This is a cartilage plate which is being placed on that, and then on the prosthesis. You have a thick one, you have a thin one. Does it make any difference? And this is the laser Doppler vibrometric studies of these variable thicknesses. This is a 0.3 millimeter cartilage. And you can see the entire tympanic membrane is vibrating. And then you have this which has 0.7 millimeter. And you can see the cartilage portion is vibrating minimally. And this has relevance because the prosthesis is being placed underneath here. Yeah. So if this is not vibrating well, obviously it will not be conducted nicely. The sounds will not be conducted into the inner ear. So it's very important that you place a cartilage, but place a cartilage which is thin enough, in this case 0.3. If you are placing it as a free, like not touching the canal wall or the lowered facial ridge, then it's fine. Then even 0.7 millimeter cartilage is okay, it will vibrate well. But if it's touching the bone, it gets fixated partially, and as I showed you with the evidence. So these recent advances have helped us modify our techniques for optimizing the results. And you can do same with the top. You can another issue, one issue is that the length of the prosthesis, how much length to use, because this is the at rest. Then you place a prosthesis which is just the distance between the foot plate and the TM. And when during Valsalva or during atmospheric pressure variations, this tympanic membrane moves, the lower end or lateral end or the medial end of prosthesis also can move and then fall down. But if you place a prosthesis which is long enough so that it really gets wedged in between these 2 points, this can cause a restriction of the tympanic membrane movements because it cannot go medially now. And this is the last slide showing you. This is again the experimental setup, laser Doppler vibrometry, in which a prosthesis has been placed between the handle of malleus and the stapes head. And this is thermoelastic metal nitinol. The laser will be shot here, and this will lengthen the prosthesis length. And we will see that how much does it make a difference. Does it really make a difference? You need to look here, it will lengthen here. Yeah, okay. So you could see that immediately the conduction of the sound decreases as the length of the prosthesis is increased, and it gets wedged in and causes restriction of the movement.
Yes, sir. Yes, sir.
So I think a couple of techniques were devised to place a prosthesis which is not lengthy, which is kind of freely vibrating and letting the stapes foot plate and tympanic membrane vibrate normally, optimally. And one of this was the cartilage shoe, as I told you. Then there are other techniques like when you have stapes, you can top with this elastic band. You have middle ear malleus replacement prosthesis, which has been popularized by Dr. Hansen. He has been coming here to India and demonstrating this technique. And there are so many other techniques. So another one is that omega connector is there, which you place on the stapes footlet, and then you have prosthesis, which it gives you the leeway for lengthening of the prosthesis. So in any case, I think since the time permits only that much, this is the Celastic band which I created from our usual Celastic sheet which we place in middle ear. Now, of course, they are available as preformed rings, in fact, attached to the prosthesis. So this is a torque, this is the stapes, we have placed it, put a Celastic band, and then so intuitively that this prosthesis cannot move. Even if the TM is lifted off the prosthesis, this is not going to move. And this was proven by the CT scan that in a case where the tympanic membrane has lateralized during the healing process, but celastic banding was done for top, and you can see that this is stable. The prosthesis itself is stable. Although there is discontinuity, patient had total conductive loss, but at least prosthesis is there. So we have come across various technique modifications, uh, devised, fabricated the newer designs of prosthesis. In the terms of material used, it is probably we have reached the limit and almost there. But of course, prostheses are being fabricated with the combination of the materials to get advantage of different materials like nitinol, etc. So I think the middle ear implants have progressed a lot in last, I would say, 30 years with bone cement, etc. Okay. These are the advances, these are the new techniques which are being tried. That is the osseointegration of the omega I showed you connector. You place it on the foot plate, and then you have certain factors you place which promote the osseointegration of this. And then you place your torque on this, as I told you. So this again will be a very stable kind of situation without the displacement of this is the histopath of that. You can see the osseointegration happening here, and a lot of other studies going on. The newer process is again with ball joint here, so that when there is negative pressure, rather than this extruding out, this bends. These are of course not being used clinically yet, but these are in the lab. And then you have a modular concept of prosthesis, that you have different parts, so that the different anatomies of the patient don't dictate the number of implants you have to keep in the OT. You have one set or two, whatever. You can assemble the implant, and you can. And the kind of innovations here, as you can see, that this is again in the lab. You have a clip which goes onto the handle of malleus, and this goes onto the stage head, and this allows you the conformation of this prosthesis in any middle ear, because this can be stretched or this can be bent to lessen the distance, etc. So I think I want you to remember two or three things. That one is that you need to practice the use of the cartilage. You should be able to make uniform thickness plates of cartilage. Of course, cartilage knives are available. Even our Indian knife is available. You have other knives from abroad. So this is very important because all the effort you make may be marred by the usage of a full thickness cartilage coming in touch with the bony wall or the ridge, etc. So you must have done good work, placed a good prosthesis, but your result is not optimal. And number two is the stability of the implant is foremost. If the implant is not in the place in which it has to be, it doesn't work. It gives rise to complete conductive loss again. And we have enough techniques to make these implants stable in the middle ear. You need training, of course, you need guidance. So nobody can really say that the results are not good in spite of our best efforts. That would be not a right statement. There are enough techniques available that you can get good results in most of the cases where you place middle ear implant. Thank you very much. And if there are any questions.
Yes, sir. Yes, sir. Sir, nothing excites an ENT surgeon when they see such beautiful otology work, sir. It was amazing to watch that, sir. Sir, Yadav, sir, if he can add
Hello.
something to the talk, sir.
Hello.
हाँ जी नमस्कार यादव साहब.
Hello. Namaskar. Can you listen? Hear me?
Yes, sir. हाँ सर आपकी आवाज आ रही है सर.
Okay. My association with Dr. P.P. Singh is running into 50th year. There are two, I want to say two words about him. He is alumnus of AIMS and he is the pioneer of middle ear implant in India.
Yes, sir.
You have, to everyone, it looks so simple, but it's a very complex thing. And in his words, it looks so simple because he is an experienced and
Absolutely, sir.
very good surgeon.
Yes, sir.
Dr. Yadav, I remember those days in AIMS hostel. And of course, then we were young and, the whole world was young, in fact. And I must say that Dr. Yadav, of course, we were together in Rohtak also for graduation. And he supported me in AIMS where I was totally new. I have thanked him earlier also. I thank Dr. Yadav on this forum also.
Sir,
For all your support
it's our pleasure to have both doyens of the otology with us here. Sir, there is a question from Dr. V.S. Rawal.
Yeah.
So how many years after the implantation these middle ear implants work? For how long? Years?
Yeah, that is that's a question which anyhow they are supposed to last a lifetime, and long follow-ups have been seen, especially with the hydroxylapatite, and of course even more than 20 years with titanium implants. And in some of the cases where revision had been because of displacements, etc., the implant per se, they were not damaged. They were not damaged. But yes, like is the experience in some cases that if let us say in stapedectomy, you have a clip piston. So in some rare cases, you might get necrosis at that area, and which of course also happens with the other this thing also. What do we call polyfluoro thing,
Yes,
So
sir.
I think the titanium
So basically, it goes for a lifelong. The way it has been developed,
yeah,
if one implant is
they have been manufactured with this idea that they have to last a long time.
Sir, there is another question, sir. If given a choice, what would be your choices? It would be a Teflon or it would be a titanium?
Teflon never, except for stapes, never.
Sir.
And you might say why?
Yes, sir.
Well, frankly speaking, I have had the experience early in my career and I didn't have good experience. Maybe the Teflon was not medical grade or not optimal, but I have had such bad experience that I never used it again. So after 1990 or 95, I think I have never used Teflon for middle ear implants.
Implants.
And for that matter, I have used Teflon stapes implant in maybe 2% of cases, even in the last 1,000 cases that I did. It was a very rare thing that I used.
And regarding titanium, sir, you must be using the Kurz ones.
Almost exclusively, but I have used Medtronic also with the titanium loop. I have used Grace also. I mean, I have used almost every, but 95% were Kurz.
Sir, it's so enriching to listen to you. Sir, there's a last question for the session, sir.
Yeah.
So if you have a choice to put a implant or put a ossicoplasty, you would use a incus or malleus or the cartilage. The patient does not afford implant from the titanium, like they don't financial issues. So what would you replace it with?
My philosophy is different. Number one, I have realized that when you explain to the patient that the hearing they are going to get is for their lifetime, they usually will manage to get the implant. Number two, I worked in GTB hospital, any government hospital for that matter. It's very difficult to procure implants for the free distribution, but we were able to get them in, I would say we could get enough implants. So I think if you work hard, you can get it. Number three, in the practice, private practice. I don't know. I don't use ossicles. I don't use cartilage for implant.
Okay.
Okay. Except for incudostapedial joint separation, where I use. Otherwise, I have never used cartilage. And the reason is very simple.
Sir.
That it's very difficult to sculpt them in a way that we can apply the stabilizing techniques.
Okay.
You need to have very thin implants for the stabilizing techniques to be practiced. So that is my reason. But
Sir,
then anybody who comes up with the nice technique to use that, well, they are welcome.
Sir, it was so enriching. It was so fantastic to listening to you, sir. And thank you to Yadav sir also. Sir, we would be now going on to the next session. Uma ma'am will be dealing with it. Thank you, sir. Thank you, sir. It was great listening to you, sir. Thank you.
So now, moving to the next session of the day, and the topic is robotic surgery. I hope Dr. Dabas and Colonel D.K. Gupta have already joined us.
Yes, ma'am. Dr. Gupta this side. Yeah.
Okay, good morning, sir.
Good morning, ma'am.
And Dr. Surinder Dabas has also joined.
Yes, ma'am, I'm there.
Good morning, Dr. Sir.
Good morning, ma'am.
Welcome, Dr. Dabas, to the webinar.
Thank you so much. ma'am,
And
for
we are
calling.
really thankful to you for accepting our request to be a part of this event today. Now, Dr. Surinder Dabas is a graduate from Maulana Azad and a postgraduate from Lady Harding. He is also a DNB in surgical oncology and has got a vast experience in head and neck malignancies. Presently, he is working as a senior director of surgical oncology and chief of robotic services in BL Kapoor Super Specialty Hospital at Delhi. He has performed about more than 500 transoral robotic surgeries successfully all over the country and is a pioneer of transoral robotic surgeries in India. And it's a real visual treat to watch Dr. Dabas working on robot. He's got a number of national and international publications, and he is also an advisor board for SSI robotic systems. Now, for this talk on robotic surgery, my co-moderator, Lieutenant Colonel Dr. D.K. Gupta, who is a professor in ENT and head and neck surgeries at Army Hospital, Delhi. He done his MBBS from AFMC in 2003 and MS from Army Hospital in 2010 and MCH head and neck surgery from Tata Hospital, Mumbai. He has got various publications in national and international journals, including a new technique for reconstruction of neopharynx after total laryngectomy. And this technique goes by his name, D.K. Gupta technique. So I'd like to invite him for being a co-moderator in this session. And I would request Colonel Gupta to continue this session after Dr. Abbas. Thank you.
Thank you, ma'am.
Can we start, ma'am? Hello?
Yes, Dr. Dabbas, I think you can start.
Yeah, you can hear me, na?
Yes, we can.
So I'm sharing my screen. Can you see the screen now?
We can. Yes, we can see the screen.
That's fine. Just a second. So the topic selected for me was transoral robotic surgery for throat cancers. And I will not say it is a new topic, it's an old topic now, and it was started in 2009 in US and now approved. It was approved by FDA in 2009. And now if you see the maximum number of surgeries done for throat cancers is by robotic technology in US. They are doing for benign conditions and they're doing for malignancies also. And why we need TORS and what are the advantages of this and how we do it, we will go step by step. So the first thing is, what is TORS? It is in surgery which is performed with the help of the robotic arms, where we remove the cancers from the hard to reach areas of mouth and throat with the help of a 3D camera, which gives us a three-dimensional image. And then a surgeons do the surgery with the guided tools at the end of robotic arms to remove the cancer. So it is remote access surgery where the surgeon is sitting away from the patient and doing surgery with the help of the technology, where surgeon is sitting distantly and removing the cancer with the help of robotic arms. And these arms have advantage of many things. And the best thing is you don't have any tremors and there is a good dexterity. So FDA cleared TORS in 2009, but the robotic technology came into picture. It was in 1999. So after 10 years, when the robot came, it was stated that it is not acceptable for head neck surgery. It was for gynae, urology, thoracic surgeries, or GI surgeries. But everybody said we cannot take this technology into head neck. But with the help of great works from team at UPenn, in 2009, FDA approved TORS as surgery for oropharyngeal cancers, basically for T1 and T2 oropharyngeal cancers. So now if we look at the treatment paradigms for oropharyngeal cancers, we always think about chemo plus radiation. It always comes into mind, this is not a surgical domain, let's send the patient for chemo plus radiation. But when you talk about treatment of oropharynx, in past, maybe 30 years back, the treatment was surgery, but it was an open surgery by either pharyngotomy approach or by mandibulotomy approach. Sometimes we can do a classical transoral approach when you have a small tumor in the tonsil. Then we move ahead for laser surgeries for supraglottic tumors and laser cortectomies. Now with the help of a technology where we can reach deeper and deeper and we can see three-dimensional image, we are coming into robotic technology. So we know that oropharyngeal cancers, at least in Asian population and India, it is rising very fast, maybe because of the smoking habits. And initially we were treating with mandibulotomy approach, which was, I will say, maximal invasive approach, needing mandibular release, pharyngotomies, and leading to a lot of complications. The complication rate was from 10 to 60%. Many of the patients required tracheostomy or or gastrostomies. So this technology, the open surgery was replaced by chemo radiation very fast without doing any studies. There was no randomized trial, there were no studies, and we as a surgeon left this open surgery to radiation technology, thinking in view that it will give a better cure rate and better functional outcomes. And we have seen that the loco-regional control and survival rates between open surgery and chemoradiation were similar. So why we left doing surgery was for organ preservation. So one thing was overlooked by all of us was long-term complications. We always think about short terms, but the long-term complications were overlooked. And when we see the complications of chemoradiation, the most easily negligible complication was dysphagia. And we always think about the short-term complications like mucositis and fibrosis, or sometimes neutropenia, but long-term complications overlooked. Now, if you have a robot, and what are the advantages? Improved visualizations, no tremors, and intuitive motions with robotic arms. It is giving us an advantage to go deeper and deeper and take up the tumor with negative margins. So we want a good functional and oncological outcomes, and that we have proven with this technology, which I will prove now with a lot of data and papers. So now one more thing, which was, I will say, a paradigm shift in management of head and neck cancer, basically in oropharynx, was detection of HPV in causing oropharyngeal cancers. And this was proved by a radiation oncologist from MD Anderson Cancer Center. And in 2012, he took out an original article about human papilloma virus in oropharyngeal cancers. And these all patients were treated with chemoradiation. And what he found out was very surprising. He divided oropharynx into three categories: low risk, intermediate risk, and high risk, based on three factors. One was HPV status, second was smoking history, and third was nodal disease. And what we find out, only the HPV positive cancers are coming into low risk category, and HPV negative cancers are mainly in high risk category. And if you see the survival difference between HPV positive and HPV negative, when all patients were treated with the same treatment protocol, there was chemo plus radiation, same dose of chemo, same dose of radiation therapy. The 3-year survival in HPV positive was 93%, and same was 46% for HPV negative. A huge difference when you treat all these patients with chemoradiation. So now there was a thought about that. Are we over treating HPV positive tumors, or are we under treating HPV negative tumors? So now we have to focus on these two cancers separately. We have to think about treatment for HPV positive should be de-intensified, and treatment for HPV negative should be intensified, so that we can have better cure rates for both of the tumors with good functional outcomes. So now what are the advantages of robotic technology in oropharynx? One is 3D vision. Second is improved dexterity in confined spaces because of the robotic arms. We have 7 degrees of freedom. Improved reach and sense of operating from inside the oral cavity. Reduce operative time. If you compare the operative time between open surgery and robotic surgery, is a huge difference. And magnified view, 10 times magnified view inside the oropharyngeal cavity when you do robotic surgery. So now why we want to do TORS? We need a maximum exposure with minimizing the surgical morbidity. This is the motto for everyone, for all of us, when you are treating a patient with head and neck cancers. And if you select our patient very wisely, and if you avoid tracheostomy or pharyngotomy, we can have excellent functional and oncological outcomes. So the basic part is the selection of the patient should be good. And we can provide an option of treatment intensification with adding TORS without increasing toxicity as compared to chemoradiation. So now if you see this slide is made from 3 papers from 2010, 2002, and what we have shown in that open surgery versus chemoradiation versus TORS. So we have compared 3 things. One is the duration of treatment, another is complications. So if you see the open surgery, the duration of treatment was 8 days. Patient was staying in the hospital for 8 days. When you talk about chemoradiation, patient is going to the hospital for around 50 days. And when you talk about TORS, patient is staying in the hospital only for 3 days. But the most important part was not the stay, it was the complications basically. And what we have seen, the complication rate between open surgery and chemoradiation is almost similar. But if you see the complication rate in TORS is almost negligible. And you can see how we do. I will just go on videos after some time, but we can see how we do robotic surgery. So now it was selected, basically FDA approval for T1 and T2 oropharyngeal cancers. And once you are more experienced, and when the patient have a good mouth opening and good exposure, you can go for selected T3 and T4 tumors, but you need an experience and you need a good exposure of the oral cavity. And I will say that T stage alone is not sufficient. Sometimes we have a T1 tumors, but fixed to the lateral pterygoid fascias, and then you can say the T1 tumor, then it is not a good candidate for TORS. You should have a mobility over the medial pterygoid muscle so that you can take out the tumor with good margins. So the most important is location of the tumor and the extension of the tumor. So now this is my criteria for selecting the patient for TORS. For tonsil, you can go easily with surgery for T1 and T2 tumors and exophatic T3 and T4 tumors. For base of tongue, you can go for T1 and T2 and exophatic T3 and minimal infiltrative T4 tumors with more experience and more exposure. Supraglottic T1 and T2 and hypopharynx, I always say go only for T1 tumors, not for T2 tumors. So this is the part of robotic system, how we do that. Now we are going on that part. So we have 3-dimensional cameras. Then we have robotic arms, we have patient cart, we have vision cart, we have surgeon console. So the patient card is on the patient side. Vision card is used by the surgeon, by the assistant to see what the surgeon is doing and to help him assisting. And then we sit on a console and start doing surgery. Now robotic technology has dual console. We have 2 consoles where you can train your juniors, your fellows, your partners, so that teaching is much easier than laser technology. And you can have all control of the robotic system, and you are not harming the patient when you are teaching them. They are the Endoris instruments with 7 degrees of freedom moving in all directions. And this is a slide about exposure, how we expose the oral cavity, how we dock the robot. Then a surgeon sits on a console and start doing surgery with the help of robotic technology, and the inside view of the oral cavity, how we do as doing surgery in these patients. So this is a small video I want to show you how we place the patient on the table, then how we expose the oral cavity with the help of retractor, then how we dock the robot, and then how we start operating. The patient is supine on the table with the neck extended. Then we need to expose the oral cavity with the help of retractors. You can use simple retractor like what we used Dingman or Crow Davis, or we can use the specialized retractor, we say FK retractor. And this is the exposing the oral cavity. So once you expose the oral cavity, you can always put an endoscope to see or visualize the tumor, and you can see your reach of the camera to that side. There is a chest piece attached to the retractor now, and we have exposed the oral cavity, and the exposure should be at least 2.5 centimeter. But if you want to go for supraglottic surgeries, you should be having an exposure at least around 3 centimeter. So now this is the docking of the robot. This is the latest robot. What we have is XI system. And this is what we say the targeting of the robot on the patient. And then we dock the robot. And initially the docking was an very big thing for the people who start doing robotic surgery, that the docking takes a lot of time. But actually speaking, docking takes not more than 2 or 3 minutes once you are experienced with that. So once we dock the robot, then the surgeon sits on the console and start doing surgery, and the assistant sits on the patient side and assists you in doing the surgery. So I always say robotic surgery is a 6-hand surgery. The 4 hands means the surgeon uses hands and foot for surgery, and assistant is using 2 suctions to give you more arms doing surgery. So this is how we are doing surgery inside the oral cavity, and you can see the movement of the surgeons, how he's moving the instrument of the robotic system inside the oral cavity. And what the surgeon is looking is at the 3-dimensional view inside the camera. You can see how nicely we can do without there no much bleeding inside, and you can see each and every structure very nicely. So this is how the surgeon controls the robotic arm sitting away from the patients. This is a small video of a radical tonsillectomy of left side. So when we do a tonsillectomy, you always make a plane at the pterygomandibular raphe, and then your plane is between the medial pterygoid muscle and the superior constrictor muscle. And this is the avascular plane where the vessels are traversing from lateral to medial part and supplying the tonsillar area. So you always see smaller and smaller vessels. Either you bipolarize them or you put some clips. So the benefit of this new system XI is that you have a bipolar system with you. You can bipolarize the smaller vessels. So now about margins, we always try to take 1 centimeter margin grossly, but microscopically they should be at least 5 mm away from your tumor. So this is the base tongue we are cutting right now. This is the styloglossus muscle. We are cutting at the base tongue. This is glossopharyngeal nerve. You can see a whitish structure. So we go all around the tumor with a cuff of superior constrictor muscle all around the tonsillar fossa. And posteriorly, we should go up to the prevertebral fascia to take out a good cuff of superior constrictor muscle so that you can have good margins, mucosal margins and deep margins. So we say if your superior constrictor muscle is free of tumor, your deep margin is free. There are a lot of issues about should we save the glossopharyngeal nerve or should we not. So what we say, if you can save it, and it is better because the aspiration chances will be less if you save the nerve. Aspiration chances will be more if you cut that part and the sensation is not there on the base tongue. So this is the specimen, then you orient the specimen, and what I advise all budding surgeons, you should go to the pathologist by yourself because the pathologists have least experience with the oropharyngeal specimens. They are good enough with oral cavity specimens. They are good enough with cordectomy specimens. But if you ask them about base tongue resections, they have least experience about this because this surgery is not performed at many other centers. So you always go to them, orient the specimen, tell them about the margins, and you can learn from them, and you can teach them also. Because final pathology matters a lot because there are a lot of conflict between the radiation oncologists and the surgeons post-operatively that your margin are very, very close. So now the last part, which is always in mind, it is a cost-effective alternative or it is very costly affair. And when anybody want to start a robotic program, the cost comes in between. So my first line for this is that when you talk about a treatment option which gives you a good functional and oncological outcomes, I always say that then cost should not come in between. But yes, we should discuss the cost also. Now we have to compare the cost between robotic technology versus radiation technology. So we should not talk about the cost what the patient is giving to the hospital. We should compare the cost what the patient spent on the treatment from the day in the OPD till 30 days of discharge. So what we have seen that there are a lot of papers now which says that the cost of surgery is much cheaper than chemo radiation. Why? Because the patient for surgery is staying in the hospital for 3 or 4 days. But for chemo radiation, the patient is going to the hospital for 50 days. He is not going to join his job for at least 3 months post radiation. So when you compare the loss of man hours and the cost of that, the surgery becomes much cheaper than chemo radiation. And there are a lot of papers about cost effectiveness, and everybody has proved that if you compare surgery, only surgery versus chemo radiation, surgery is much cheaper than that. So this was about how we do TORS. Is it cost effective or not? When we should do TORS? This has become a very big topic now. Which are the ideal patients? What are the advantages? But I'm basically telling you about why we need TORS, and the most benefited patients are the patients who are HPV negative, where the results of chemo radiation are very poor. So we have to select our patient very wisely. I will say that we should select early cancers, T1 and T2, when you are starting your program. Once you are more experienced, then you can go for early oropharyngeal cancers with nodal disease. And then if you want to go more forward, then you can select T3, T4 tumors, but always think about doing a plastic surgery or a free flap reconstruction in these patients if you want to have good functional outcomes. So this is step-by-step process how you learn robotic surgery into oropharynx. But first thing is you learn about doing a radical tonsillectomy first. Then you go to base tongue, then you go to supraglottic surgery, then you go to T3, T4 tumors, and you should go by step. about neck dissection in oropharynx. You always do the neck dissection at the same time when you do the primary part. And we always do level 1 to 4 in early oropharyngeal cancers when we don't have a neck node clinically. But when you have clinical node, we always do level 5, 1 to 5. And it should be done simultaneously. There are a lot of conception about the communication between oral and cervical area. But if you save the submandibular gland, I have never seen any communication post-surgery, post-radiation. I've never seen that. So there are few things which we should keep in mind when you are planning your robotic program into head neck. So now I'm okay with any of the questions asked by the panelists or by the people who are attending the conference. And in the end, I would like to thank you, Dr. Uma and Deepak and Amit, for asking me to be here with all of you. Thus, about speaking about TORS in oropharyngeal cancers. Thank you so much.
So thank you very much, Dr. Dabas. It was a lucid presentation and it was a visual treat as usual. Thank you very much for the talk. Any questions from the audience?
Surinder.
Sir, good morning, sir.
Ishwar here.
I know your voice.
So you can recognize me. Nice talk. What are the how do you save the submandibular gland? Because in classical neck dissection, we always remove the submandibular gland. If you are doing a surgery in the oropharynx, then what about the nodes which are left there around the submandibular gland if you don't remove it?
So the chance of lymph node spread at level 1 in oropharynx is 4 to 5%. So now what we have divided the lymph nodes at level 1B. Basically, we are not talking about level 1A. Level 1B, we are divided into prevascular and postvascular. Postvascular are more prone to get metastasis as compared to prevascular. And what we go over the fascia of the submandibular gland and take out the lymph nodes. We never leave the lymph nodes there. We take out the lymph nodes. The only part which is left is posterior to the gland. So we never divide the fascia where the digastric muscle is
medial to the gland or posterior to the gland? Medial to the gland.
Medial to the gland toward the oropharynx, sir. So if you divide the fascia or the digastric and make a plane between the submandibular gland and the digastric muscle, you always get a communication. So lymph nodes are basically prevascular and postvascular. We take out all the lymph nodes and never seen a fistula. The fistula chances are more in radical tonsillectomy as compared to base tongue. So we should be very sure not cutting the digastric muscle and the fascia over it. Otherwise, you will get a communication.
What about the repair or when you do the base of the tongue? How do you repair? Do you put a skin graft or do you allow it to heal by secondary intention?
Sir, if it is T1, T2 tumors, we go for secondary intentions. Graft is not a good option for that because you have a lot of salivation there in that area and it's very difficult to attach to that.
Hold it there.
Recipient area. But when you're doing a bigger surgery, like you're doing a tonsillectomy along with the base tongue resection, we always go for flap reconstruction rather than graft. And in that case, we take out the submandibular gland, make a tunnel between the oral cavity and the neck, and that's deliver your flap through that and then insert it. You can insert by
flap is harvested by the plastic people and reset as usual by what is done in the open case. Is it that way or it is done robotic?
So some part is inserting is done by us because deeper towards the epiglottic side is very difficult to reach from oral cavity, from the neck area. But many times you can have a good exposure. You can do an inserting, as usual inserting can be done by the plastic surgeon. But sometimes we need to insert with the robotic technology. Many times you can do it with open technology.
Before you take up the base of tongue's resection, do you clip the lingual artery?
So now it is in almost in all cases, we do ligation of lingual artery inside and outside both. When you're doing a base tongue, when you're doing a tonsil, we always ligate the branches of facial artery going to the tonsil. It's always mandatory now. And we have seen a significant difference when you don't ligate and you ligate. There's a significant difference between the hemorrhage with ligation or no ligation. So ligation is always mandatory.
The biggest advantage, I think, is 360 rotation, which you just referred in passing reference, because the hand of the person can't rotate 360, whereas the arm of a robot can. And do you have experience in nasopharyngectomy? Because that is another area which is inaccessible and people do with the help of endoscope. What is your experience in nasopharyngectomy post radiotherapy?
Now, if you if already added up the post radiotherapy, so now we should know the indication of doing surgery in nasopharynx.
Recurrence, that is always recurrence after radiotherapy, failure of radiotherapy, though it's
So-
not the topic of today.
I'm telling
I'm
you
just
the fact
asking,
that
by the way.
nasopharyngeal surgery by robotic technology post radiation are one of the most complicated surgery. Why? Because when you are doing a lateral nasopharyngectomy by this either technology, you are exposing the bone naked, and then you're trying to put some flaps there, grafts there, and you always obstructing your airway. So only few surgeons in the world are doing nasopharyngectomy by robot, but with a lot of complications. Then again, you should select your patient based on pre-chemoradiation volumes. If you have a nasopharyngeal tumor which is localized laterally, yes, we can do it by palatal drop technology, or we can do by palatal pick technology where we just pick up the soft palate with the help of sutures and then poke the robot. We can do it, but we should always keep in mind with a lot of complications, and which is carotid exposure and bleeding is always there, and the chance of carotid exposure and bleeding is at least 5 to 10%.
Chalo, thank you, Surinder. All the best.
Thank you so much, sir.
Thank you, Dr. Abbas. Now I'd like to request Dr. Gupta for his concluding remarks on this wonderful topic.
Thank you, Dr. Abbas. As usual, it was a visual treat. Just wanted to ask your comments on the recurrent oropharyngeal cancers, recurrent oblique residual oropharyngeal cancers post radiation, your experience and the choice of patients. And the second comment is about the treatment de-intensification, especially in HPV negative population, which you brought out in your slides, in Indian population, and role of the robotics there.
Dr. Gupta, the first thing is about salvage surgery.
Yeah.
Can you hear me?
Yes, we can.
So the first thing is about salvage surgery. Yes, we have a role of salvage surgery by this technology, and I will say that in your personal experience, salvage surgery for tonsil is easier and with a good survival. But when you talk about salvage surgery for base tongue, you should always have pre-chemoradiation volumes, and I would always say we should have our own institutional MRI to see that. And if it was operable before chemoradiation, I would like to do salvage surgery in these patients. But a T4 tumor which responded to radiation very well, and now it is T1, I will not advise surgery in these patients because the recurrence rate is very high, and you always do some flap reconstruction when you do surgery in salvage patients. So for tonsil, I'm yes. For base tongue, T1, T2 pre-chemo radiation, yes. But T3, T4 tumors responded well to radiation therapy. I will say no to surgery because they recur very fast.
Right.
And second, you are saying about HPV negative. Now we have seen that the difference between HPV negative and positive is always there. So when you treat HPV negative with chemo radiation, there's a huge difference in survival when you treat with surgery. And we have brought papers from European populations and American populations now, though they have less HPV negative. We have brought our own data also where we have seen that HPV negative responded very well to TORS as compared to chemo radiation. But we need to bring and study which should be from multiple institutions rather than from a single institutions. And that way we can work together to bring more and more data on HPV negative.
Right. So treatment de-intensification, can we utilize that concept using robotics in HPV negative population?
Absolutely.
Yeah. Thank you. Thank you very much. Thank you. Thank you, ma'am. Thank you, ma'am.
Please.
I think we can conclude the session now, ma'am. Uma, ma'am.
Ma'am is mute. Ma'am mute.
Ma'am, you are mute.
Thank you, everybody.
Change is the only constant. Man is the best creation in the world as he can adapt to changes in his environment. We have reached a long way today, from our forefathers who invented the wheel to landing on the Mars, from scheduled conferences to webinars. Man could accomplish this unbelievable feat only because he adapted to change. Gone are the days when otolaryngology was considered an end branch. Now it is looked upon as a first step to future paradigms. Keeping up to date with a rapidly developing and changing specialty remains a challenge for all physicians. Within our field, the pace of change has accelerated during the recent years with the development of new imaging modalities and therapeutic interventions. On behalf of the organizing committee, I take great pleasure in welcoming our learned speakers, Honorable Director Sir, and distinguished faculty members to foster the progress in the field by contributing with their expertise to what promises to be a very comprehensive and exciting meeting. I request Dr. Neha Salaria Madam to felicitate our Honorable Director Sir, Dr. APS Batra Sir. Dr. Anju, kindly felicitate Uma Madam. We now formally begin our webinar with the lighting of the lamp. I request Dr. APS Batra Sir, Dr. Uma Garg Ma'am, our senior faculty members, Dr. Mahendru Sir, Dr. M.K. Garg Sir, Dr. Swaran Kaur Ma'am, Dr. Usha Kataria Madam, and the entire ENT team to kindly come forward and light the lamp. Seven seconds के बाद
चल गई क्या
7 seconds
यहाँ
के
पे
बाद
इसको शेयर स्क्रीन करके ना साउंड शेयर करना पड़ेगा साथ में
7 seconds में ऐड आते हैं 7 seconds के बाद चलाने हैं
तो पहले प्ले कर लो ना इसको
चलो ऐड नहीं आना चाहिए आप
सेकंड के बाद
या कुन्देन्दु तुषारहार धवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युत शङ्कर प्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा शुक्लां ब्रह्मविचारसार परमाम् आद्यां जगद्व्यापिनीं वीणापुस्तकधारिणीम् अभयदाम् जाड्यान्धकारापहाम् हस्ते स्फाटिकमालिकां विदधतीं पद्मासने संस्थितां वन्दे तां परमेश्वरीं भगवतीं बुद्धिमतां बुद्धिप्रदां शारदाम्
May I request our Honorable Director, Dr. APS Batra sir, to kindly address the meeting.
Good morning, ladies and gentlemen. First of all, I congratulate Dr. Uma Garg, Professor and Head ENT Department, and her team for holding this webinar, Recent Advances in ENT 2021, at the time of pandemic. ENT is a rapidly evolving branch, and surgeons as such have to keep themselves updated with the recent advancements. Keeping up with this tradition of BPS, Department of ENT is hence conducting a webinar on recent advances in ENT 2021. This topic is of relevance not only to residents but also to consultants. To grace this occasion, we have esteemed dignitaries from all over India as speaker and moderators. We have Dr. Alok Thakur, Professor and Head ENT from AIMS New Delhi, Dr. Anand Mathur, Director, Lady Harding Medical College, Dr. P.P. Singh, Senior Consultant, Fortis Delhi, and Dr. K.K. Handa from Vedanta Hospital. My best wishes to this webinar and hope it lives to its name and enhances your knowledge. Thank you.
Thank you, sir, for your enlightening words. I request Dr. Uma Garg ma'am to kindly grace the meeting with her address.
Director, Dr. APS Batra, Dr. Amit Sharma, Associate Professor, Dr. Naveen Sharma, all my senior faculty colleagues, all esteemed speakers from all over the country, and invited faculty and residents from ENT department, and all the delegates who have joined us, a very good morning to all. Welcome to this virtual conference today on 9th January 2021 on recent advances in ENT 2021. This is being organized, as you know, by Department of ENT and Head and Neck Surgery at BPS GMC Kanpur. In this era of COVID, where people are still not free from clutches of coronavirus, physical conference is almost an impossible proposition. So to continue the learning process, this webinar was planned. This is aimed at refreshing the knowledge of residents and budding consultants, for keeping them abreast and updated about latest advancements in the field of ENT and head and neck surgery. And this is done with the help of our senior experts, doyens of knowledge, and teachers from institutes of repute from the country. I welcome them all. Heartiest greetings. Friends, I would take pride in sharing with you with immense happiness that in this webinar, we also have got a number of international registrations for this online conference. And therefore, the department has left no stone unturned in making this event a great success. So with the grace of God and with best wishes from all of you, we've already started with the academic program at 9:30 in the morning, and we hope to continue it till late afternoon. Hope all who are a part of this clinical virtual meet to be truly benefited by this event. Thank you. Welcoming again and thanking again. I wish that this turns out to be a big event. Thank you.
Thank you, ma'am. I request Dr. Amit Sharma, sir, to kindly present the memento to Dr. APS Batra, sir. Thank you, sir. I request Dr. Naveen Sharma, sir, to kindly present the memento to Dr. Uma Garg, ma'am. To conclude this inauguration ceremony, may I request Dr. Naveen Sharma, sir, to deliver the vote of thanks.
Good morning, all of you. As Dr. Uma briefed us, we have already started with our academic sessions and we are middle of that. But as per the tradition is, I, Dr. Naveen Sharma, on behalf of Department of ENT and HNS at BPS GMC, Kanpur Kala Sonipat, extend my sincere thanks to first of all, our worthy director, Dr. APS Batra sir, who spared time from his busy schedule to grace the occasion. I thank all the esteemed speakers from all over the nation for being a part of our program and sharing with us their valuable knowledge. Thanks to all the moderators, both in-house and external moderators, for moderating the session so beautifully. A big thanks to our HOD ma'am, Dr. Uma Garg ma'am, for being the guiding force as always. Thanks to all my seniors and juniors in the department for guiding and cooperating in making this event a success. I would thank all my faculty members, my friends from other departments for all their cooperation in attending today's function. Last but not the least, I would thank all my staff members, support staff, technical staff for all their efforts in making this endeavor a success. Thank you all again. I would now invite all of you for a cup of tea and snacks. Thank you all.
स्क्रीन शेयर करें
Hello, Dr. Kapil.
हाय डॉक्टर नवीन, क्या हाल है? गुड मॉर्निंग।
बढ़िया डॉक्टर साहब।
और कैसे हो आप?
I am fine, Dr. Kapil. We are live now.
Okay.
Okay, it's being shared. So we have taken you as an internal moderator, sort of. For
I
us.
know. I have talked to Dr. Umaga, ma'am.
Okay. So it's good to see you again.
Yeah,
And to see you
same
as a
here.
part of sort of organizing committee.
Of course, I am.
Okay. So thank you again for being a part of this webinar. So I request Dr. Kapil to take over the proceedings. And for the next session, our speaker is Dr. Ishwar Singh. I would like Dr. Kapil to.
Speaker is Jayanti.
Speaker is Dr. Jayanti Bakshi.
Yeah. Thank
So
you, Dr.
Dr.
Naveen.
Kapil, kindly give a brief introduction of
Yes,
Dr.
yes.
Ishwar and Dr. Jayanti.
Thank you, Dr. Naveen.
Okay, thank you, Dr.
I have worked with all of you, and it still feels that I am a part of the BPS Kanpur. It's such a wonderful place. And regarding Dr. Jayanti Bakshi, she's a professor and unit head at PGI Chandigarh. I have met her a couple of times, and at our workshops and PG examination, I have found her to be a very humble lady and soft-spoken, and she's a gem actually. But she has a lot of research projects under her belt in the field of head and neck cancers, and there are World Health Organization projects in the field of deafness and mucormycosis. She has a lot of rewards and honors in her name. Because if I start counting, it will be more than half an hour. So I will just say she has a lot of awards and honors in her name. She has more than 100 publications in reputed national and international journals, and especially in the field of head and neck. And she has more than 6 chapters in the field of ENT in the national and international books. So with this, I will pass the baton to Dr. Jayanti Bakshi for her enlightenment on recent advances in ENT. Ma'am. Dr. Jayanti, ma'am. Dr. Jayanti, ma'am, are you there? I think Dr. Ishwar, sir, good morning.
Yeah. Good morning.
Sir.
Good morning, Kapil. How are you?
I'm fine, sir. I think ma'am is there, sir. I think she is live.
But her slides are not visible.
Yes.
Good morning, Jayanti. Am I audible to you? I know Jayanti when she was a first year resident. I was there as a pool officer in PGI, and she joined as a first year. She is a very dedicated hard worker right from her starting. So I know her since then.
Okay, it's been a old time. It's been long time.
94, 95.
Okay. Ma'am was a part of our workshop in head and neck, and she's a regular examination for our postgraduate students. Yeah, ma'am is live now. Good morning, ma'am. Ma'am, you are not audible.
Slides are not there. Jamanti, you are not audible. No.
Hello.
Hello.
Hello, sir. I think there is some technical glitch at the ma'am end.
मैम आपने ऑडियो ज्वाइन किया है वहां से?
So we had just talked with ma'am. She is sharing soon.
Are you able to hear me now? I cannot hear you, madam.
Yes, yes, ma'am.
I can hear. हाँ. मैडम
Ma'am,
आप
please.
I
Ma'am, please log in with some other device.
डॉक्टर कपिल आप सिर्फ मुझे बता दीजिए, आर यू एबल टू हियर मी?
यस.
ओके. तो मैं एक ये मैडम का लेक्चर है क्या अभी?
हाँ हाँ.
अभी मैम का लेक्चर है.
ओके ओके ठीक है. चलिए तो मेरा कनेक्शन तो ठीक है. एम आई ज्वाइंड एज ए पैनलिस्ट और एज ए
स्पीकर डॉक्टर साहब?
एज ए स्पीकर. ठीक है सर. तो मुझे शेयर स्क्रीन तो मिल जाएगा ना टाइम पर?
हाँ हाँ.
ठीक है सर. ठीक है, नो प्रॉब्लम. मैं अभी अपने आप को फिलहाल म्यूट कर रहा हूँ, जस्ट चेकिंग कि आई एम ऑल गुड ना.
Or you can go to the next speaker if there is some problem.
Actually, sir, we can wait for some time because of issue of moderator also. If we can go for next speaker, we have to
Yeah,
arrange
there
the
is no
moderator.
problem. We can join. Ask Dr. Vikas. He's already ready, so we can wait, and she can, in the meanwhile, rectify the issue.
Okay, okay, sir. Just wait for it 2 minutes. We will resolve.
In-
Okay.
डॉक्टर विकास का ऑनलाइन पार्टिसिपेंट्स में देखो दिखा रहे हैं उनका नाम. ठीक है वो वेट.
So this is prolonged inauguration. Continuation of inauguration. Break.
मैडम से एक बार पूछ लो डॉक्टर निशिका का, डॉक्टर निशिका डॉक्टर विकास का.
निशी ने वो कर रखा है, लॉगिन तो कर रखा है।
Dr.
Sir, I can hear you and I can see you.
बस आप जो है आप सामने से एक दूसरे के साथ कैसे आप बात कर रहे हैं?
Good morning, Nishi.
हाँ, आ गया.
Good morning, sir.
Yes, sir.
This
We
is-
can start talk of sir, Dr. Vikas Agarwal.
Okay, okay. We'll start the talk of Dr. Vikas Agarwal. Sir, are you comfortable with it? Are you ready?
Yes, I'm absolutely ready.
Oh, okay. Good afternoon, everyone. I, Dr. Neha Salaria, welcome you all to the session post inauguration on obstructive sleep apnea. Obstructive sleep apnea. Obstructive sleep apnea is a perplexing disease, not only because of the complexity in its presentation, but also the various treatment options available and implications of the disease and the treatment itself. Moreover, it is a rapidly emerging and evolving field, especially over the last few years, making it an apt topic for today's conference on recent advances. To enlighten us in this field, hence, I welcome Dr. Vikas Agarwal from Mumbai, a well-renowned personality and a master in this field. And I would also extend a warm welcome to Dr. Nishi Gupta, Associate Medical Director and Head ENT at Dr. Shroff's Eye Hospital, Delhi, to moderate and commence the session. Dr. Nishi, ma'am.
Yeah, I'm there. Thank you, Neha. And thank you, Professor Uma Garg, for giving me this opportunity to introduce the eminent speaker, Dr. Vikas Agarwal. As we all know, he's got special interest in snoring and obstructive sleep apnea. And he has been the past president of Indian Association of Surgeons for Sleep. I think I'm audible. Can you hear me?
Yes, ma'am, you're audible, very well audible.
Okay. So Dr. Vikas Agarwal has been the past president of Indian Association of Surgeons for Sleep Apnea. And he's been the chairman of Committee for Sleep Disorders. He's the director of Specialty ENT Hospital at Mumbai and also a robotics sleep apnea surgeon at Asian Heart Institute, Mumbai. He's also a visiting ENT consultant at Seven Hills Hospital. He's pioneered some of the interesting things that I can see here in his CV. He's released the first Indian guidelines for sleep apnea surgery as president of ISA, and he performed the first surgery for OSA in India. He also propagated the role of salpingopharyngeal folds in OSA. And he's been a speaker, eminent speaker at various national and international forums. And I would like to thank him for giving us the time and being here with us. Over to you, Dr. Vikas.
Thank you, ma'am. It was an extensive introduction. At the outset, my sincere thanks to Dr. Garg and the whole team of AOI Haryana to have me over for this small talk. In the next 30 minutes or so that are given to me, I'll try to cover most of the basics important, though the topic is recent advances. But as I understand, in Haryana, not too many surgeries are being done. So I'll definitely cover some basics before taking on the advanced things. So let me just share my presentation. And see my presentation, ma'am?
Yes, sir.
Okay. So I hope you are able to see it in the full screen now.
Yeah, yes, sir. It's clear.
Yes, we can see that.
Okay. So basically, when we take the history of any patient which is having sleepiness, which we think is because of the obstructive sleep apnea, there are two important things that we have to understand: whether the patient is really sleepy in the daytime, which is the cause of most of the roadside accidents. That we can know by Epworth sleepiness scale. Because a lot of people keep on asking questions that what we should ask, what we should take in the history. So if you have basic questions of Epworth sleepiness scale, it will tell you whether the patient is sleepy during the day or not. It will not tell you whether the patient is having sleep apnea or not. For the patient to have to understand the chances of having OSA, you have to use the stop bang questionnaire. So if you have these two things, Epworth sleepiness scale and stop bang questionnaire, that is more than enough in the history to understand whether your patient is sleepy, whether your patient is having possibility of obstructive sleep apnea. So this is a stop bang questionnaire. You can get it on the internet, so I'm not going to the detail of that. But stop bang questionnaire tell you the possibility of obstructive sleep apnea. So if you have a score more than say 3, then we understand that the patient is having possibility of sleep apnea. And most important of these 8, criteria is the observed apnea. If the patient's relative is telling you, or the spouse or the bed partner is telling that he has seen the patient is getting choked, that is observed apnea. That is the most important, uh, criteria by which you can decide whether this patient is having apnea or not. So snoring, tiredness, observed apneas, blood pressure, body mass index, more than 50 years of age, neck size, and male gender. These are the 8 things in stop bang questionnaire. Out of that, the most important is the observed apnea, as you can see here. Now this patient, we are performing DICE, and when this patient is sleeping, you can see he has stopped breathing now. So he's completely choked. Are you able to hear the sound of the computer? So he has stopped breathing, though his chest is moving. So this is observed apnea. And this is what people see in the night when they see their near and dear ones getting blocked. Now coming to the examination, though you perform a general examination, you perform a complete ENT examination, and you also do the examination for comorbidities like diabetes, blood pressure, and chest. But the most important is not Friedman staging. The most important is not nasal endoscopy. The most important is the fiber optic exam of the nasopharynx and the hypopharynx, because that is what is going to tell you what is actually obstructing. And if you perform a nasal endoscopy, as a fiber optic endoscopy, and you see the whole nasopharynx, the oropharynx, and the laryngopharynx, now this is a huge tonsil actually blocking. So many times you see the tonsils blocking the oral airway, but the upper part of the tonsils actually can block from the up. So once you've performed a basic examination in your OP, you have taken a history, you perform a polysomnography. Polysomnography will tell you how much is the problem. It will not tell you where is the problem. It will tell you how much is the problem. So in polysomnography, what kind of polysomnography can we do? Level 1, in which you do EEG, EOG, EMG, ECG, everything, respiratory parameters, or you perform the same at home, which is called level 2. When you perform all the parameters at home, it's called level 2. And when you only do a limited study at home or a hospital, which is only giving you the respiratory parameters, then it's called level 3 study. So in which situation you do what? Because sleep study you can do, you can do from level 1 to level 3, but level 1 is costly, though it's more informative, but it's costly. It's difficult because the patient has to wear so many wires. So which has to be advised when? If we are not sure that the patient is having a sleep related breathing disorder or not. So if we are not sure if the patient is having sleep, walking, sleep talking, or, restless leg syndrome and all, then we perform a level 1 polysomnography, because then we have to know the sleep patterns. We have to know about parasomnias. We have to know about narcolepsy, restless leg syndrome, blah, blah, blah. But if we are very sure that the patient is having a sleep related breathing disorder, then in most of our patients, if by history and Epworth sleepiness scale and stop bang, if you are very sure that the patient is having a high possibility of having OSA, then you can go away with a level 3. And this in our country is a very, very common thing because it's not costly. It is a very small machine. You can do it at home. You can do it in the clinic. There's no attendant required. So it's a very easy thing. So limitation of level 3 is only that it gives you all the respiratory parameters, but it does not give you the brain waves. So it can underdiagnose. It can never overdiagnose. It can only underdiagnose. So if the patient has not slept, then you'll get a negative report. But in a level 1 PSG, you'll get a report which will tell you that the patient has not slept. Here, because you are not recording the brain waves, you'll not know that the patient has not slept. So this is the only limitation. If you understand that, then there's nothing else. So in the report at a glance, you look for the AHI, you look for RERAs, you look for BMI, minimum oxygen saturation, and blah, blah, blah. I'll not go into the detail. Once you have done the sleep study, now you want to see where is the problem. So there are 2 types of obstruction. Static obstruction. Obviously, static obstruction is in the nose, because if the nose is blocked, the patient will have obstructive sleep apnea more. This is a static obstruction. So CTPNS is the best thing. So you do a CT-PNS whenever you suspect a nasal obstruction. You do a CT-PNS, which will tell you all the details right from the anterior nostril to the nasopharynx. Everything will be known in the CT-PNS, and that will give you a detailed idea how airflow is happening through the nose, because the nasal airflow is well defined. This is a normal human being breathing, and by test methods you are seeing how the nasopharynx, as you can see, is the most important area which you have to understand, and therefore a CT-PNS will give you all the detail. And if adult, many times we see adenoids in the adults. An adult with an adenoid is the worst obstructive sleep apnea candidate because his total nasopharynx is closed. So you look at for adenoids, you look for turbinate hypertrophy, you look for septal deviation, you look for mucosal thickening in the sinuses, and that's when you will understand what is there in the nose. So static obstruction always have to be treated, because whatever even if you put a CPAP, if the nose is blocked, CPAP will not work. So static obstruction always has to be treated. Coming to dynamic obstruction only happens when the patient is sleeping and is snoring in the sleep. So how you can assess? You can assess with a flexible fiber optic in a awake patient with Mueller maneuver. You can perform a drug-induced sleep endoscopy. You can perform a dynamic MRI, and then you can have apnea graph. So flexible fiber optic awake with Mueller maneuver. In awake situation, the patient muscle tone is controlled by the patient. So it's not a great thing to diagnose what is happening during sleep. So drug-induced sleep endoscopy tells you what is exactly happening during the sleep, because the patient's muscle tone is reduced. And you do in a controlled manner so that you do not over-sedate the patient. You do not give muscle relaxation to the patient. So DICE is the best way as of now today to understand what is happening during sleep. Now you can have dynamic MRI is also good, but there's a big gantry. The patient has to sleep inside that. There's a lot of noise, and you find difficulty to resuscitate the patient. So DICE is actually in today's date a more preferred investigation. Apnea graph is not so commonly used, so I'll not go into details of that. So this is how in drug-induced sleep endoscopy you see which area of the airway anatomy is actually collapsing. So you see all the areas of the airway in great detail, and what you see on the screen is a score. Right now it's 8. Called BIS monitor, bispectral index monitoring. So with bispectral index monitoring, you can actually decide how much sedation is given to the patient. So now you see the patient is now going into sleep. You put the endoscope inside, you put a strip on the patient's nose, on the forehead, and that will tell you how much is their sedation. And then you see inside, and then you look at the position
what you
of
see
the jaw.
here, the patient is used to mouth breathing in spite of his nose being wide open, still his mouth breathing.
Now this is
now
one
we'll
thing
observe
that,
what happens when you close the mouth. This is his palate completely collapsing with the mouth open. Now I'll keep the mouth closed and see what happens. His apnea converts to snoring immediately. His breathing becomes better. So whatever you do on the soft palate is still not going to completely improve him if you do not improve his mouth breathing. And even if he just uses a chin strap now, he'll be able to sleep a little better. Now I'm leaving his mouth open again and see what happens. Starts choking again. Again choke. Show the mouth. Show the mouth by the external camera.
So basically, you're seeing that his mouth is
Now,
and he's choking.
I'm closing his mouth and see what happens immediately inside. Okay, I'm leaving his mouth open and see what happens inside again.
So this is a very, very important thing to understand, that what happens when you close the mouth and open the mouth. Now this is a patient with a body mass index of 32, AHI of only 8, and he's only having hypopnea. So this drug-induced sleep endoscopy is the most important thing to understand.
So here we present.
So on the other hand, this patient is having a BMI of 22, only 22, AHI of 8, and he's having a collapse of the base tongue and the epiglottis.
Open now.
So BMI and AHI are not the most important predictors of what is happening inside. You have to do a drug-induced sleep endoscopy to understand what is happening inside and then take a call. Now, CPAP, as they say, is the golden standard. Now, we have to see how CPAP actually works on the airway. Now, this is the first video on this planet Earth. This was uploaded around 7-8 years back. This has got some 7 million views till now.
Switch on the CPAP.
This is how the CPAP will actually open up the airway.
The CPAP air. Switching the fan. Keeping the palate open. Switch off the CPAP.
So this is how the CPAP works. CPAP pushes the soft palate open so that the air can go inside. So the actual mechanism of CPAP is mostly never seen by the people who prescribe CPAP. So they keep on trying to give CPAP to everybody. Actually, CPAP works best on the soft palate. It does not work when the problem is in the nose or when the problem is in the tongue base, because the tongue base cannot be lifted with air. CPAP trial should be given to whom? To everybody? Yes. Why not? Give it to everybody. There's no harm. But how long? You can't give it for 1 year. You give it for a few nights, 3 nights, 6 nights. See how the patient is able to use the CPAP. If the patient is able to tolerate the CPAP, then let the patient be on CPAP. When you do not want to do a CPAP trial, if somebody has an adenoid like this, if somebody has an absolutely blocked nose, how the air will go inside? And even if the air goes inside little bit with the CPAP, because as I showed earlier, the nose is, if the mouth is open, the tongue is going to collapse, the palate is going to collapse. So CPAP is not going to be useful if the nose is not open. So as ENT surgeon, all of you at least open up the nose. All of you know how to do a septoplasty, tubinoplasty, adenoidectomy. Open up the nose. Then give a chin strap, make the patient use his nose, because as I showed earlier, in spite of a nasal surgery, the patient was keeping the mouth open. So first do that, and then your CPAP will work, your oral surgery will work. Now, as I showed earlier, predictors of difficult airway, definitely we think if the AHI is high, the airway will be difficult. If the BMI is more, the airway will be difficult. Mallampati score is more, the airway will be difficult. But as I showed here, so I will not go through that. Only I'll show this one, that a BMI of 73, one sec. Now this patient is having a AHI of...
Here we present to you drug-induced sleep endoscopy of an adult male with a BMI of 30.3, AHI of 57, which are...
So case of high AHI and high BMI. Now just look into a sleep endoscopy.
If we look into the palate, lower part of the soft palate,
he has no tongue-based obstruction. So high BMI does not mean that there will be a tongue-based obstruction. It's still only soft palate. So we should not get fooled by high AHI, high BMI.
You can see his base tongue and epiglottis is not big. You can see the vallecular well. This is the tonsil. This is the lower pole of the tonsil. And that's the upper pole of the tonsil. This is the base of the uvula. The tip of the uvula is here.
So high AHI, high BMI does not mean that every time you'll get a tongue-based obstruction. So never get fooled by that. On the other hand, this is a patient with a AHI of BMI of 22 and AHI of 10, which I showed earlier. And in his case, I already showed that the obstruction was there. So BMI and AHI do not matter at all for intubation, because in intubation, you have to see what is happening inside, which segment is involved. So high AHI and high BMI patients will require oxygen supplement for a few hours after surgery. So during extubation, that matters, because if the upper segment is at a problem, upper segment is nose and the nasopharynx, lower segment is the base of the tongue and the epiglottis. So if the problem is in the lower segment, if is in the upper segment, you can just bypass it by putting an oral airway and then intubate this patient like this. But if the problem is in the lower segment, then anterior part of the lower segment is known by Mallampatti, and the posterior part of the tongue is known by, the posterior part of the tongue is responsible for intubation, extubation. And when you look inside, you look straight away. Therefore, if the tongue is large, it's difficult to view because you're going to view it like this. If the tongue is large, you cannot view it straight. So if you have a 45-degree turned true view scope, any tongue you can intubate. So it's not a problem. You can just have a look inside and intubate. So if the large tongue malampati is not a problem for ventilation and intubation extubation, it's the posterior 1/3 of the tongue which is the problem. So this is how you intubate. And then you put the tube inside like this. So, and in sleep apnea, it's very, very important to have a smooth intubation, because if you create a bleeding at that point of time and you cannot put the tube in, then your patient will have a very difficult time. So setup, what kind of setup? Is ICU must for every case? Which case can be done in daycare, in nursing home settings, and when to do tracheostomy? So if you're doing a large base tongue and removing a large chunk of the muscular base tongue, then definitely you have to have an ICU, you have to have a tracheostomy, you have to have a very emergency team ready with re-intubation and all. But if you're doing just
like this. Now I am ablating this.
if you're just having a small, lingual tonsil, then you definitely do not require an ICU. You can do a lingual tonsillectomy as a daycare and send the patient home by the evening. I will just fast forward this.
You can ablate tissues.
You can simply ablate this and send this patient home by the evening. You can do, ablation of the lymphoid tissue like that. Multi-level surgery with a blocked nose and large tongue base should always be staged. Nose should be done first, followed by the palate and tongue base, because then you have the nose to breathe. You can put a nasal tube into the patient. But if the tongue base is not large, then you can do the nose and palate surgery in a single go, because that's the commonest setting that you are patient that you're going to operate. Large tongue base can cause apnea with packed nose even when not operated. This has to be kept in mind. Coblation is the best tool because it produces a good amount of hemostasis at a low temperature. So we must have coblation in our tool armamentarium, and we should be used to operating on the tonsils and the adenoids regularly before jumping onto the base tongue surgery with coblation. Now, uvula preservation, should it be preserved every time? Should it not be preserved at a time? Is a debate. Many times, if the uvula is large, you do not want to preserve the uvula, but then there's a problem of the patient complaining of some irritation in the throat for some time. So now world is going towards uvula preservation, but I have no hesitation in removing the uvula if the uvula is really large and is a cause of snoring and sleep apnea. Now, in next 5 minutes, I'll show you some animation. What you see from the front is not what is happening from the back. So these structures which you see on the examination from the front, how they are from the back, because you are seeing now these structures from the back. So when snoring is happening, the tonsils are moving in 3 directions. Tonsil is a 3D structure. It is moving medially, it is moving superiorly, and it's also going posteriorly. So I'll try to show that in this animation. The tonsil is moving medially and superiorly, you can see from here. And it's also going posteriorly, you can see from here. So this is how the tonsils will actually behave. Tonsil has got only 3 sides, not 2. So when we say that tonsil are grade 1, 2, 3, 4, we are only looking at one dimension, how far they are coming medially, but we are not looking at the other dimensions. So tonsil is a 3D structure, and the tonsil can be fat like this on the left hand side, where you grade it grade 3, but the tonsil could be endophytic and could be hidden behind the pillars. That is called endophytic tonsils, and that you can miss. You think that tonsil is not the cause, but actually the upper pole of the tonsil can be a cause of if the shoulders are broad and the head is broad, then it can cause sleep apnea at the upper pole like this. If the tonsil is large, the upper pole will actually push the posterior pillar behind, and that's what causes sleep apnea. So this is the latest thing. This is not in any textbook, any journal. This is my original work, and I presented in the world forums already. So when you perform a tonsillectomy, the posterior pillar is also pulled in the front, and there's a lot of space created at the back. So there are 4 or 5 muscles in the soft palate. I do not think I have enough time, but I will just go through saying that the levator palati, the tensor palati will tense the palate. It will help the sleep apnea. So there's no business operating on the tensor palati. The levator palati is the most important muscle for swallowing, but that does not correspond to sleep apnea. So there's no business operating on the levator palati. So once you save these 2 muscles, you can actually operate on the anterior pillar of the tonsil is also pulling the soft palate forward, so it's good for sleep apnea. It's only the posterior pillar which is the culprit. So when you remove the tonsil and you do some surgery on the posterior pillar, then you get a very, very good control of obstructive sleep apnea. and you never go higher than this because these are the levels of the levator and the tensor palatii. We call this Lakshman Rekha, because that is the area where swallowing happens and the snoring is happening in the lower part. So there's no point operating on the upper part of the soft palate because it's not responsible for sleep apnea, it's responsible for swallowing. So if you operate on the upper part, your patient will have a VPI and your snoring will not be benefited from that. If you only operate on the lower part, snoring will be taken care of and swallowing will not be affected. This is what I wanted to show you. So we have, we'll give you the details of this DICE reporting system that we have made. Right now, we do not have enough time. Only thing is that if the problem is in the lower part of the soft palate, you do a surgery, you'll get wonderful result. If the problem is in the upper part of the soft palate, you do whatever surgery, you will not get a wonderful result. So we have to understand which is a vertical palate or a funnel palate or a tubular palate or a tunnel palate. So a tunnel palate, which is uniformly collapsing, will not give you a good result. I will not show everything. This is salpingopharyngeal fold, again, our discovery. So there's a classification system which is there in the Indian journal. So this structure was never identified before 2012. In 2012, I presented in the World Congress. And please go through this paper so that you can understand the importance of salpingopharyngeal fold. So I'll not go into the detail of that because my time is limited. So I'll again pass through all that. Unfortunately, this was kept in my presentation. I'll just pass through. How I'm doing with the time, ma'am? How much time you have for me?
Sir, we have time. You can. We
Sorry,
have
come again?
minutes. Yes, sir. Yes, sir.
So, how much time do I have?
10 minutes we have, sir.
We still have 10 minutes. Okay,
Yes, sir.
then I'll explain. Okay, so then let me go back. Let me go back to the slide. So basically, if we want to tackle both AP and lateral collapse in one, then this is the technique. Because see, if you look into this soft palate from the top, now this is the uvula, this is the tonsil, this is the tonsil, this is the palatopharyngeus muscle. What you're seeing here, this is the palatopharyngeus muscle and the base of the uvula. So now, this is the situation. And what you do, you perform a tonsillectomy. First, you remove the tonsils. Then you remove the palatopharyngeus muscle from the, this is the tonsillectomy happening. Then you remove the palatopharyngeus from the part and take it forward and laterally. Now you see how much of space is suddenly created. So this is what about my surgery. It's called suspension bridge pharyngoplasty, in which we rotate the palatopharyngeus. Most of the surgeries are based on palatopharyngeus. And I hitch it onto the pterygomandibular raphe like a suspension bridge. So in this case, suppose if the, sorry, so we hitch it like a suspension bridge, like a hammock. So if now this bridge cannot fall, but it can always move up and down. So this is the concept that this bridge can move in one direction. So we hitch the palatopharyngeus after removing the tonsils and the uvula onto the pterygomandibular raphe, take through and through from one side to the other side. So it works like a hammock. So therefore you can tackle both AP and the lateral collapse in one surgery. And therefore your results become phenomenal. In single surgery, you are able to tackle AP and lateral both collapses. So this is how you take care of the lateral collapse. That's how you take care of the anterior collapse. The steps are that you intubate, you remove the tonsils, and then you cut the palatopharyngeus muscle at the upper part so that you can open up this area really nice and wide. You preserve all the mucosa, you simply cut. We use coblation so that there's minimal thermal damage. I'll fast forward. You cut this till the lateral pharyngeal wall. Now you see that it's the lateral pharyngeal wall is already seen, it's well open. Then you transpose the posterior pillar like this. You remove the uvula if required. We use a Covidian VLOC 180 barbed suture. You take the barbed
From
suture
the pterygomandibular raphe inside the tonsillar pillar. See, I'm taking the whole bulk of the palatopharyngeus muscle into this barbed suture. Of this whole thing.
Take it back. And then
come back to the same point of pterygomandibular raphe as you went in from. So this is the.
See, it's already pulled laterally and anteriorly.
So from the same point, I come again.
Now this is the anterior leg. This is the most important
and along
suspension
the
bridge.
free border of the soft palate, almost along the free border of the soft palate, they come out. Now, what this will do, it will not let the soft palate fall posteriorly. So I take another bite. This will not let the whole soft palate fall posteriorly where I had come out. And then take
Then
one
go to the
suture
other
here.
side.
And go to the pterygomandibular raphe. From here again, I'll pass through the pterygomandibular raphe. Okay, quite lateral. Lateral pull, which is this. So that's the lateral pull. Pharyngeus muscle. And come back from here and come till the pterygomandibular raphe.
So this is giving a lateral pull and anterior pull both. Now the whole raw area is actually covered.
Now
so
you
there
see
will be no fibrosis.
This lateral pull remains like that.
Then you come back to the other side, the first
Soft
side.
palate and do a little more for the anterior pull. And come back on the other side and just cut off the suture over there. And that will be the end of the surgery. For that, I may need to change the tube again. Okay, so this will keep it.
So this works like a suspension bridge. The bridge cannot fall down, but it can move sideways. So when the patient is swallowing, the palate can move up, but it cannot fall to create sleep apnea. It can move like this. So that was the surgery. I think my time is over, and I'll stop sharing my screen. And I'll be happy to take any questions if there's any time left.
Thank you, Dr. Agarwal. I think that was an excellent talk. And I don't see many questions in the chat box, but I would like to ask a few questions from you.
Yes, ma'am.
As we would say, a comprehensive ENT surgeon sitting in our OPD, not many of us are specialized in sleep apnea. So if there is, I would say, a single take-home message for people who are, like in my OPD, I see a patient, and patient generally complains of severe snoring. So that's how we get to convince them that you could be having obstructive sleep apnea. So normally what we do is, after doing an endoscopy, throat examination, if there is no obvious tonsillar hypertrophy or adenoid or DNS, then we send them for sleep study. So, but then what is the level of sleep study? Because there are parameters that you study. What are the minimum parameters that you would suggest for us to advise to people?
So if the patient is having a severe sleep apnea, AHI more than 30, then definitely he's at risk. He must be advised to go further tests because his life is at stake. Many of the patients in our country will have AHI of 60, 70, and they're moving around without doing anything. See, either they take a CPAP if there's no blockage and the patient's weight is more, then let them use a CPAP. If it's really fat, send them for a bariatric. But most of the patients are not really obese and they still have, sleep apnea. So there, at least open up the nose, ma'am. What I'm saying is, even if you're not specialized into sleep apnea surgery, which I do not expect everybody to be, and pharyngeal surgery is pretty risky, at least open up the nose. That will do some good to the patient. Open up the nose and give a chin strap. Let him use it.
Okay, what do we mean by opening up the nose? I mean, to my understanding, if there is no DNS, if there are no adenoids, and if there is no turbinate hypertrophy, Do we still need to do anything?
Then the nose is already open. If there's nothing in the nose, then you cannot. Then check whether he is using his nose for breathing or not. Many people are mouth breathers since childhood. Just giving them a chin strap. Ask for a history of mouth breathing. But I sincerely suggest that everybody should know, all ENT surgeons should know how to do a sleep endoscopy, because you all have flexible scopes. So start doing sleep endoscopy. That's very simple. Even
So
if you
preferable, a sleep study or a sleep
both,
endoscopy?
both.
In
See, sleep
what
study is
order?
like an audiogram. Sleep study is like an audiogram. Sleep endoscopy is like an impedance. So audiogram plus impedance will tell you what is happening, how much is conductive and what is the reason of the conductive hearing loss. So sleep study will tell you how much is obstructive sleep apnea, how much is central sleep apnea, and sleep endoscopy will tell you for the obstructive sleep apnea, where is the obstruction.
Okay.
So I'm trying to present it in a very simple way so that.
Yeah, no, I think it was very important message was that at least open up the nose.
Yeah, and do a sleep endoscopy. There's no harm in doing so. So you know what is the problem, and then uh, whoever is the nearest sleep surgeon, I mean, you refer the patient, you go to that, you can have it operated by him. But CPAP is a very difficult thing to use for a long term. So,
Dr. Vikas,
Sir.
I got a question.
Sir, please.
There is sure again. What is the role of rhinomanometry? Because what you talked about CT scan was that would give a anatomical defect or obstruction. But what is the role of rhinomanometry that in the functional to assess the function of the nose?
Sir,
We all know. So, do you advise rhinomanometry also?
Sir, honestly not, because first of all, rhinomanometry is not very common in our country. After rhinomanometry, we still do not know what is obstructing. So we still have to do a CT scan. The patient can afford both, there's no harm. But if I have to advise one, I will advise a CT scan.
Because that will give a more definitive answer to where the
Because
obstruction
we know
is.
what to do, na? In rhinomanometry is like middle-ear pressure.
But that will give you the, yes, how much is the obstruction? Is it really there or not there?
Sir, understand, but if you're seeing a gross deviated septum, if you're seeing turbinate hypertrophy, if you're seeing adenoid, then
That
you know
you can make out gross thing, so you can make out even on your clinical examination or nasal endoscopy.
Absolutely correct, sir. You can even do nasal endoscopy. So if on nasal endoscopy you do not see anything, there's no need to do a CT scan, obviously.
How frequently you come across adenoid in adults? We do come across, but what is, since I am not a sleep surgeon and I don't work, but how common is this entity in adults?
Very common. Why? Because sleep apnea patients are smokers, most of them. Why do they smoke? Because they are sleepy. When they are sleepy, they smoke, and they're smoking since a long time. The adenoids are lymphoid tissue. They respond and they grow. Very common. So I would say in my practice, almost 25 to 30% of sleep apnea patients, I see some degree of adenoid have, not gross ones. Gross ones are maybe 5 to 10%. जो बचपन से बड़े हुए हैं, since childhood. But due to smoking, little bit of adenoid hypertrophy, turbinate hypertrophy, everything, because the patient is smoking. Patient is smoking why? Because he's sleep deprived. He's trying to remain awake throughout the day.
And those who are staying in a city like Delhi, the pollution is already giving good amount of this thing.
Absolutely, sir.
How is the role of hyoid suspension or tightening the hyoid in this if there is anterior fall, base of the tongue fall?
Correct. So hyoid is very good to pull the epiglottis forward. Right. Lower part of the base tongue, the higher part of the base tongue cannot be taken care of the hyoid. So how much is the distance between the thyroid cartilage and the hyoid? It is 5 millimeter. So maximum you can tighten is 5 millimeter. Maximum you can pull the epiglottis forward is 5 millimeter. For that you have to take an incision. You can supplement this surgery along with other surgery, but alone this surgery does not work. So more than 5 millimeter, you can just go inside and touch the, the hyoepiglottic ligament, the glossoepiglottic ligament from inside. You just shrink it, you'll get at least 7, 8, 10 millimeter. So I prefer to do it from inside because there's no external incision. It takes me 5 minutes. This will take me 45 minutes. There is an external incision. From inside, it's a very, very simple thing to just coagulate the glossoepiglottic ligament, median glossoepiglottic ligament.
And another question: what you told about the posterior-pharyngeal, this posterior, this thing, what you call pillar, that palatopharyngeus muscle.
Right.
If it is done excess, will it not lead to nasal escape or nasal twang? How much is the voice change following this?
Absolutely zero. No, voice change will be there, but there will be no nasal twang, no, because velopharyngeal sufficiency is defined by levator palatii and tensor palatii. I could not explain the action of all the muscles. I have made good animations, but tensor palatii and levator palatii will lift the palate. Posterior palate will only pull the palate down. So if you cut it, the palate will not come down at the most. It will never be stopped from going up. So there will be no VPI at all. If you use a cautery on the posterior palate, then it will form a scar, and then it will not let the palate go up.
So that's what we traditional teach to the students. So don't touch the posterior pillar when you are doing the tonsil.
Cut it very clearly if the patient will be relieved of sleep apnea also. But do not damage and leave it. Then it will become fibrosed.
Thank you.
Thank you, sir.
Dr. Vikas?
Yes, Dr.
Nice lecture, very nice lecture. Just one question. How often do you find turbinate as a cause of obstructive sleep apnea?
90 out of 100 times. As a contributor, not as a
contributor.
cause.
And how do you make the diagnosis of turbinate hypertrophy, especially inferior turbinate hypertrophy? Because it keeps on changing the size as you know, nasal cycle. So how do you make the diagnosis?
So therefore, I said is the role of CT scan. I have a whole lecture on the inferior turbinate.
But one thing,
I divide the inferior turbinate into 6 parts. Anterior 1/3, posterior 1/3, middle 1/3, all divided by superior inferior. Naturally, if I start talking, it will take another 45 minutes. So when you do a CT scan, do not decongest the nose. Do it in a normal way. In fact, I perform the CT scan on the first visit of the patient in all cases, because the patients have to wait for months to see me. They have already taken various treatment. Maximum medical therapy is over. So when they come to me, I want to know the status of the ethmoids. Even ethmoid status is important for sleep apnea, because if there's a postnasal drip, the nasopharynx will keep on collapsing, surface tension. So therefore, CT scan tells you how much of the inferior turbinate is the bone, how much is the flesh, which part is polypoidal, which part is serous. You can see from the nasal endoscope. So you get a complete idea with nasal endoscopy, and nasal endoscopy we anyway do. CT scan gives us the complete idea of what we are dealing with. So there is a great depth in dealing with the inferior turbinate. We can have a talk on the inferior turbinate someday.
But nasal cycle, does it change the size of the turbinate? Maybe
Not very significantly. Nasal cycle will not, your nose drops will. Nasal cycle will have 5 to 10%. It will not greatly, it will not become, from 100, it will not become 50. It will become 80. Simple.
Thank you.
I think there are no more questions. Dr. Neha, can we proceed to the other talk?
I thank you. I thank you all once again for inviting me to your state UI. Thank you very much.
Thank you for the wonderful talk.
Thank you for the enriching talk, and thank you all panelists for the discussions. For the next session now, I'll hand over the baton to Dr. Surender, my colleague. Thank you, everyone.
So we are starting talk of Dr. Kulvinder, and we will unable to do the talk of Dr. Jayanti Bakshi due to shortage of time and limited schedule of the Zoom meeting. Thank you.
ये दिख रहा है बस। हाँ।
Good afternoon, everyone. Myself, Dr. Surinder Kumar. Welcome you all for the next session. I feel privileged to introduce a very humble person, our expert radiologist, Dr. Kulvinder Singh. Sir has worked as an associate professor and head of department at BPS GMC Kanpur. And currently he is working as senior consultant in health map diagnostics. He has more than 13 years of experience in conventional radiology, and he has keen interest in diagnostic angiographies and aims to excel in diagnostic and functional musculoskeletal and sports radiology. He has more than 25 national and international publications and 9 awards in his name, and he has been guest faculty in various national and international conferences. Welcome, sir. Today we have one more guest with us, Dr. Shalini Saraswat. She was associate professor and head of department in BPS GMC. Presently, she is working as a senior consultant at Indigo Diagnostic Center, Gurugram. She observes keen interest in functional MRI and thyroids. A warm welcome to both our guests. Dr. Kulvinder will be talking about recent trends in diagnostic in head and neck tumors. Dr. Shalini is there? Ma'am, can you hear me?
Yeah, I can hear you. Thank you so much. Thank you for your kind words. Yeah, thanks for
welcome,
inviting
ma'am.
us. Yeah, thank you so much. Yeah.
Kulvinder sir, over to you.
Thank you, Dr. Surinder, for the kind introduction. And I'm really thankful to the Dr. Uma and the team of ENT department at BPS GMC for organizing this conference. And I'm really honored to be a part of this. And let's start. I've been told to speak about the imaging advances in ENT, but since it's a very lengthy topic in itself, so I have restricted myself to the tumor part of it because it is the area where most of the development is happening. So it's better to talk about that, and I'll make you familiar with briefly about the various imaging modalities which are coming up or which are at the research stage at this point of time. So let's start. So as we all know that imaging plays an important role in diagnosing a disease, be it infection or malignancy. In malignancy, the role of imaging starts with the staging of the tumor, be it a local staging or lymph nodal staging or distant usually graded as ENM, local tumor staging T, and nodal N, and the metastasis is M. So this is more or the most important part of the imaging in day-to-day practice. And nowadays, the functional assessment is also done in various oncological diseases, wherein we have utilized the MRI, PET-CT, and CT to an extent that we can actually looking at the what is happening inside. Maybe it's the chemical component of the tumor, or it's the kind of enhancement, or if the tumor is having hypoxia inside. So everything matters when it comes to the treatment. So these are very important aspect of the imaging, which is usually done in a dedicated oncological setup and also at the research institutes. And imaging also plays an important role in post-treatment and follow-up of the tumor patients. Like the patient has undergone chemotherapy or radiotherapy, and then patient comes back for re-evaluation whether the tumor persists or it's just the inflammation of the treatment. And then last but not the least is the role of AI. AI is going to play a very important role, and I'll make you familiar with the various
technical aspects of AI and how it's going to help in the tumor analysis. So the imaging of the primary tumor is usually starts with the clinical examination. This is one thing which we cannot just ignore it. So clinical examination, history, previous interventions, and comorbidities all are very important factors before starting the any investigations. So we should be aware if previous intervention has been done, because it is going to change the appearance on CT and MRI. Because of the intervention, there might be some hemorrhage. So we have to be very careful if that hemorrhage is because of the tumor or it's because of the interventions. So it is very important. The comorbidities are also very important, because if the patient is having some renal diseases, then we have to think again about administering the contrast, right? So apart from that, in heart diseases, if the patient is having pacemaker and we are thinking of doing MRI, then we have to think again. So these things really matter a lot. So we have to be very careful, and we should know about these details before going ahead with the investigation. So the investigation usually starts with either CT, USG, MRI, and PET. And anatomy is the key. If we know the anatomy, we know what is there, what is at, and whether this thing is at its normal place or it is displaced. So anatomy is very important aspect of radiology, and we must know the anatomy. If we know the anatomy, then only we'll be able to say if the anatomy is distorted because of the tumor. So it is again a very important parameter. As I said, that investigation is any tumor investigation usually starts with ultrasonography, and ultrasonography plays an important role in neck lesions, particularly if we are dealing with thyroid lesions, salivary gland lesions, or a lymph node, whether this lymph node is infective or metastatic. So there are set parameters on ultrasonography. We are utilizing those parameters and telling whether that node is metastatic lymph node or that is infective, depending upon the replacement of central fatty hyla, presence of necrosis, presence of calcification, conglomeration, then the vascularity pattern on Doppler. So these are very important, and we are doing it in routine practice. So I have not covered that because my topic would be the advances. So I have included this. We recently published, it's not recently, but in 2017, we published a study to see whether we can see vallecula or piriform sinuses on ultrasonography. And we did a systematic evaluation of the neck and floor of mouth to see if we can evaluate these structures on ultrasonography, and we could do it. This is how we performed it. We divided the steps in 7. First is hyoid, and next 3 would be suprahyoid, and below that would be infrahyoid. So we could evaluate all these structures, including the muscles, mylohyoid, genohyoid, and the tongue. The tongue is also very important to identify. We could identify the tongue in its whole extent in the ultrasonography, then vallecula and the piriform fossa as well. So this is how the step 3, where this is a CT representation of the same, not the same patient, but at the same level, just to compare it. We can see that the tongue in its entirety in the CT, and similarly on ultrasonography also we could see the tongue. This is the part of the base of the tongue, and this is the palate. Over here we can see this hyper echoic line representing the palate. And this is the part of the base of the tongue, and this is hyoid. So we can see any lesion if there is on the tongue, and definitely the evaluation of tongue can be done on ultrasonography as well. And apart from that, as I said, that vallecula, these are the vallecula which we could identify on ultrasonography, and this is the CT representation of the same image. These are air-filled structures, right? Because of their foci which contain air, so it's difficult to identify air-filled structures on ultrasonography, but we could see the outline of it. This is the outline, and we can see some air inside, which is causing some shadowing over here also. So yes, we can, at least we could identify the vallicula. If there is a big lesion, smaller lesion, yes, we can miss it. But if there's a big lesion which arising from the vallicula or arising from the nearby structures and displacing the vallicular air, we can easily identify it on ultrasonography as well. Similarly, on piriform fossa as well, these are the piriform fossa on either side. And this is the CT image, and this is the area which is covered on the ultrasonography on the right side and the left side, this one. And this is the thyroid cartilage, and this is the air mucosal interface, and it is the air-filled piriform fossa on the either side. So this was also identified. As I said, that we may tend to miss smaller lesions, but if there is a gross distortion of the anatomy, we can identify on ultrasonography as well. Then after that ultrasonography, the evaluation usually goes to the cross-sectional imaging like MDCT and standard MRI. The single slice CT have almost been replaced by the MDCT, and then the standard MRI is used. The MDCT is the most commonly performed investigation in the tumors of the oropharyngeal or the head and neck area. And MRI is also one of the very important. Where MRI is available, MRI should also be done. Apart from the conventional CT and MRI, we have evolved to certain new modalities or the new indications like CT angiography. Similarly, we have MR angiography and MR spectroscopy as well. And we can evaluate the lesions in a better way by using these. So if we talk about the comparison between CT and MRI, by anatomical regions, mostly if we are dealing with trauma, we start the investigation by CT, because it's easier to identify the bone. It's easier to identify if there's a break or displacement or the any fracture. Everything is visualized better on CT. So if we are dealing with trauma or acute or mild early infection, CT is better, whether it is orbit, skull base, paranasal sinuses, or deep spaces infections. And lymphadenopathy, both CT and MRI are complementary. While masses, if we are dealing with masses, intracranial involvement of the mass, or there is involvement of the nerve tissue, or if there is neurogenic spread of the infection, all these things, MRI is the modality of choice. And as I said, lymphadenopathy, both are complementary. Both modalities are equally good in picking up the lymphadenopathy. Now, if we look at the advantages of MRI over disadvantages, because MRI is one investigation which has an excellent soft tissue resolution. So we can differentiate between various anatomical structures. Presence of hemorrhage can be identified. Even the stages of hemorrhage can also be identified, whether it is hyperacute, acute, subacute, chronic hemorrhage. And all these things are not really possible with CT. So MRI has an excellent soft tissue resolution. So the advantages of the MRI over CT are, as I said, that if there is perineural tumor spread or involvement of the cavernous sinuses or the dura, then MRI is better. Delineation of tumor and the inflammatory disease in sinonasal areas. Bone and cartilage is one. If there is frank bone erosions, then sometimes CT is better. Otherwise, if we are looking at the marrow involvement of the bone, then MRI is better. Again, the muscles and facial planes are better delineated with the MRI. Nodes, both are equally good, but MRI has a little upper hand over it. The vessels, again, is MRI better. The calcification is one thing where CT has a better role than MRI. So now let's start with the functional assessment, which is the really important and very interesting topic of today's talk. In the functional assessment, the CT perfusion is one modification of MDCT, where we can assess the kind of CT perfusion. So is there a question? Okay, all right. So CT perfusion is, as I said, it's a modified modification of MDCT, wherein we can see the kind of enhancement, and on that kind of enhancement, we can have an idea whether we are dealing with a benign lesion or infective lesion, early malignant, or a frank malignant lesion. We can draw the graphs according to the enhancement. There can be three types of enhancement, more or less. The type 1 is benign kind of enhancement, wherein the contrast is taken up by the tumor tissue at a more or less smoother pattern, wherein the contrast it's taking up the contrast and gradually increasing in the density of that contrast. This is a benign pattern. Then we have type 2 pattern, wherein there's a contrast enhancement early in the lesion with a plateau in the later phase. So this is a kind of enhancement which is usually shown by the inflammatory or a few of the malignant. Now, if we are dealing with some kind of enhancement wherein there is sharp early enhancement and then there is washout, this is a pattern of a typical malignant lesion. Why? Because what happens in malignant tumor is there is angiogenesis and neovascularization. So there is a lot of vascularity. So it attracts a lot of contrast into it in the early phase because of the arterial supply. There's a lot of contrast going into the tumor, and because of the arteriovenous shunting as well, because the capillaries are not developed and the arteries, they are putting up the contrast directly into the venous system, so there will be early washout. So this is a type of pattern which is seen in the frankly malignant lesions. And also in the CT perfusion, we get to it's a quantitative investigation wherein we can see there are certain parameters like how much is the blood volume that is going into the tumor, how much is the blood flow, and what is the permeability index. So these are the things which we can assess. Now there's this is an example. This is the conventional MDCT. There's a lesion in the retromolar trigone with the infiltration of the surrounding soft tissue. We have done the MR perfusion in this case, and we have drawn some the region of interest, and similarly the same is replicated on the other side. So what we could identify, we can generate few maps in the CT perfusion, like this is blood flow map, this is blood volume map, and this is permeability index, and color coding can be given. On by looking at these, we can see that there's an increased blood volume as well as blood flow, and the permeability is also much more on the left side. So that gives us a fair idea that there is infiltration of the surrounding tissue, which we are not very sure on this CT. By looking at this CT image, we are not very sure, but by doing this perfusion, CT perfusion, we are certain that there's a lot of vascularity over here, and a lot of blood is going into this area, and the permeability is also very high. So that is the advantage of performing the CT perfusion. It also helps in picking up the lesions while after completion of one part of the radiotherapy or second part. So post-treatment follow-up can also be done by using this CT perfusion. The next is the MR spectroscopy. So what is MR spectroscopy? Over here, it's a modified software basically. So it can be done on 1.3 and 3 Tesla MRI. So what we do, it's kind of chemical shift imaging, wherein we pick up the chemical composition of the tumor. So what kind of chemicals it is containing. Most of the times we do proton MR spectroscopy because our body is water, so we have plenty of protons, so we utilize that, and we can identify various chemicals inside that tumor. The most common tumor marker is presence of choline. If we pick up the choline in the tumor by doing the MR spectroscopy, then we are mostly certain that we are dealing with malignancy. But it has got some challenges in MR spectroscopy, because what we need in MR spectroscopy is very homogeneous magnetic field, and presence of susceptibility artifacts because of the paranasal air in the paranasal sinuses and bone adjacent. The magnetic field is inhomogeneous, so it is a drawback. and then pulsation artifacts, because as I said, we need a very homogeneous magnetic field, and it should not be disturbed by the presence of air, bone, pulsation, anything like that. So pulsation artifacts, again, causing hindrance in the picking up of the signals of MR spectroscopy. Then the large amount of fat is also a drawback, though we have dedicated softwares to ignore the presence of fatty chemical in the signals, but still, if we have large amount of fat, then it masks the presence of smaller markers, and lack of sufficient spatial resolutions, because we need at least 1 centimeter of area to put this MR spectroscopy region of interest on the image. So we need at least 1 centimeter of the area, and as we know that these are the oropharyngeal lesions are mucosal lesions, so it's not really possible at times to have 1 centimeter of area to pick up the lesion. This is the kind of graph we get. There's a lipid, as I said, there's a lot of fat around it, so lipid peak is there, and everything is fixed. So if we get the lipid at around 1.3, 1.4. It is the ppm parts per millimeter. So this is the graph. It's going to remain the same. It's not that lipid will come to this side and appear at 3. No, it's not like that. It is the place of that chemical which is going to help us what kind of chemical we are dealing with. Like this is a choline. Choline will always be 3.3, 3.2. So if the presence of choline is there, then as I said, that it's almost certain that we are dealing with the malignancy lesions. So this is a MR spectroscopy has been done on a nodal lesion. And as I said, that we need at least 1 centimeter of RI. Look at the size of ROI. And there is a presence of choline inside, and this is the post treatment, and look at the resolution of the choline, and this is the normal fatty peak. So it should have been at this place, but there is no choline. So we can certainly say that the tumor has been resolved after 6 weeks of the treatment. Then we have diffusion weighted imaging. In this imaging, it's more or less a part of the normal MR imaging of the of any tumor imaging. So what happens in diffusion is we pick up the movement of water in it. So if the lesion is packed of multiple cells tightly packed together, so there will be very little movement of the water molecules inside the cell and the tissue. So this is how we utilize this physiology to pick up the signals. So if there's a lot of water movement in the tumor or in a pathology, then mostly it is not tumor. So what we get on diffusion is 2 types of images we get, DWI and ADC. DWI will be bright if there is a diffusion restriction or there is a restriction to the movement of water molecules. DWI would be bright and ADC would be black or hypo intense, we call it. Hyper is bright and hypo is black. So diffusion would be bright and ADC would be black. That means we are dealing with something which is showing a tightly packed cells, and there is very little movement of water molecules in that. Look at this example. We have this lymph node over here, and there's the post contrast, there's enhancement, but on the ADC map, it is appearing black, and we can actually measure it also. So there is ADC measurement we can do, and the same patient after 2 weeks of treatment, we can still see that see the lymph node on the contrast imaging. But if we put the ADC, there is definite reduction in the size as well as increase in ADC value. Increase in ADC value means that there is a water movement is there, right? So more the ADC value, less chances of the lesion to be malignant. So this is how ADC is, the diffusion MRI is helping us in picking up or the better evaluation of the oncological imaging. Then we have something called BOLD and TOLD. BOLD, these are all MR applications. BOLD is blood oxygen level dependent imaging, and TOLD is tumor oxygen level dependent. So what happens in, as you know, that MRI is all about picking up the paramagnetic effects of molecules in the tissue, right? So if we oxygenate that part, there will be a lot of oxygen. Because of the oxygenation, there will be less of deoxyhemoglobin in the blood. If I talk about the blood, because bold is blood oxygen, it started from blood in evaluation of the stroke patients, but later on it evolved into the tumor evaluation as well. So the name was given, and it's tumor oxygen level dependent. So we oxygenate the tumor tissue while doing the MRI. So while oxygenation, there's a lot of oxygen that is going into the tumor tissue. There will be reduction in the deoxyhemoglobin or the oxygen within the cells. So that will alter the MRI signal, because deoxyhemoglobin is the reduction in deoxyhemoglobin will produce reduction in paramagnetic effect, so that will increase the signal. So this is all about MRI physics. So the important thing is that oxygen plays a very important role in imaging or the appearance on MRI. So this is how we do it, and we will talk about this board in detail in the later part of my talk, because we have hypoxia imaging, which is a very important component of tumor research these days. So wherein this told plays a very important role. So this is how we get the signal. We take the normal T2 images, and we can see that the signals are like this. And start of the oxygenation, on the same time we oxygenate the patient by giving 100% oxygen. At that time there is reduction in deoxyhemoglobin and the paramagnetic effect, and leading to the increased signals. So this is a bold imaging performed on the lymph node, and we can see that this red is color given to that. So that means that there is hypoxia inside, and that hypoxia is because of the tumor. Then we have dual energy CT. In most of the CT scans we have is empty CT, but single source and single detector. So what happens in dual energy CT is we either have two sources and two receivers. Like in this case, we have two sources, 1 and 2, and there are two receivers opposite to that. So we give two different energies same time. Isometric scanning of the patient is done, and we get the data set of two energy sequences, and because of those we can get certain data because of the two energies, like VMEs, virtual monoenergetic effect imaging, electron density map, and iodine maps. We can if we get the two data sets, and we can eliminate the bones, we can selectively eliminate the iodine or the contrast enhancement, or we can selectively pick up the iodine. So a lot of things can be done by dual energy CT. And in India there are many places where dual energy CT has been installed and playing a very good role. So this is how dual energy CT is performed. One CT is taken at the KeV, kilo electron volt of the 65, the other one is 40, and we get this image. There was a lesion at the lateral margin of the tongue. We can see there is subtle lesion, enhancing lesion is seen on the 65 keV, which is quite better on 40. But when we get the iodine map, we have eliminated most of the things, but what we got the signal of the iodine, because contrast is iodine basically. So we get the signal of iodine, and it is very well seen on the dual energy CT, right? So this is how the clinical application is used. Another example wherein there's a lesion of the vocal cord with anterior commissure involvement. This is three energy sets we have got, 40, 65, and 140. All these are contrast images, but look at the contrast is very less apparent on the high keV, which is part of the physics. So I'm not going into the detail. There is erosions of the thyroid as well, but what we get in iodine map is very beautiful enhancement or the iodine lesion over here, and we are pretty sure that it is malignancy, and it's beautifully picked up the lesions. Then we have hybrid images. We combined the PET and CT, because PET is very good in it has got very good sensitivity. But when we combine the PET and CT or PET and MRI, we superimpose the findings of PET on the images that is we get on CT and MRI. So there are two simultaneous single gantry with two simultaneous tubes, and we scan the patient first CT and followed by the PET, and we fuse those images and we get images of the lesion like this. This is the plain CT, right? Over here we can see something is abnormal, which is some bulkiness is there, but as such there is no lesion appreciable on plain CT. Then we did the PET, and we could see that differential enhancement of the right uh, tonsil. And when we superimpose these images, look at this, uh, bulb like enhancement or the is seen on the CT, so we get to know what kind of structure we are dealing with. So this is the advantage of the PET CT. Similarly, another advantage of PET CT is like in this case, there is a lesion over here which is not apparent because of the artifacts, because of the metallic implant in the teeth. So there's a lot of artifacts. It's really difficult to say anything about the CT if there is a lesion or not. But when we combine the PET and CT, there is we can see that there is definitely a lesion over here. So this is the advantage of PET CT. And similarly, PET MRI can also be done. Now, very important part of the today's talk is hypoxia images. So what is hypoxia imaging? So what happens is whenever the tissue or the tumor tissue is irradiated by radiation, in two ways it can kill the cell. One, it directly damages the DNA, which is a very less percentage of cases it happens. And the other way is it acts it that radiation goes on the water molecules. These are the protons of that water molecule. It produces free radicals, and that free radical in turn damages the DNA. So this is the main way by which radiotherapy acts on the tumor or the tissue and kills the cell. So what happens is there is in the tumor, because of the more demand than supply, there's a lot of hypoxia, and all the hypoxic tumors are resistant to chemotherapy as well as radiotherapy. Look at this tumor. We have central part of it which is low in oxygen, or the hypoxic. So this is the part of the tumor which is resistant to chemotherapy as well as radiotherapy, because there is less of supply and less oxygen. There is less free radical formation and less tissue damage on radiotherapy. So what we do is we irradiate this tumor, and initially the part which is in the irradiating area of that radiation, this part will be killed or the damaged. In the second cycle, that is why we do multiple cycles on radiotherapy, because in one cycle there's some part of the tissue is damaged, and again some vascularity develops, and again there is oxygen, and then the second cycle comes and kills the other cells. So this is why the multiple cycles are required to generate more free radicals and more oxygen. So this is the part which is resistant, and it is basically the cause of concern, because it is this part from where the recurrence is also happening. So it is very important to identify if the tumor is hypoxic, and how do we do that. So as I said, that hypoxic cells have poor blood supply and low oxygen levels. Now the radiation is only half as effective in these areas as opposed to well oxygenated part of the tumor. So these are the areas which are really important as far as recurrence is concerned. Right. So to detect the tumor hypoxia, there are certain invasive measurements which are out of scope of the radiology, but these non-invasive methods are PET and MRI. As I said, bold and told, bold is all about oxygen, right? So if the tumor is hypoxic, we can detect it on bold. There are certain parameters, certain reagents which we using, like instead of giving 100% oxygen, we give 95% of the oxygen and 5% carbon dioxide. So that reduces the vasoconstriction, and tissue will be more exposed to oxygen. So the bold signals will be much more in this case. And similarly on PET also, there are hypoxic tracers which we incorporate with the FDG, and they go inside that tumor and give a different signal, so we can pick up the hypoxia within the tumor. The last part of my talk is artificial intelligence. So before I think we have time. Okay. So the artificial intelligence is very important and promising role in tumor imaging. Before we jump into the artificial imaging, intelligence imaging, there are certain things which we should know. One is learning versus programming. Programming is it's like Excel. We give certain data set, we give some inbuilt commands to the computer. Okay, you have to multiply this versus this. Some input is given, it is processed in a similar way, and an output is given. So this is programming. There cannot be any cognitive function in that. So 2 into 4 would be 8 every time we do it, right? So this is programming. There is no thinking, there is nothing. But learning is a part of an AI wherein there are certain ways to make the computer learn certain things. So what happens in learning is we give some commands, the computer processes it in a variety of ways, add some variables depending upon what kind of feedback has been given to that computer, and it comes up with a output. So that output could be different every time it processes till the time it reaches the ground truth. Ground truth is a final conclusion. Like if I give you an example, like I give a data set of images of T2 images of to the computer about the neck, and I want to segment the parotid gland out of it. So I will feed the data. Okay, this is the area of parotid gland in these images. So computer will process it accordingly. So that data which I have given to the computer, that this is parotid gland, that is ground truth. That is where computer has to reach. So it will process it in a different ways, variety of ways, which is basically a software programmer helps in wherein. So computer goes through that process and reach to that ground truth to give me the segmentation of parotid gland, right? So this is how the computer learns. Then there is something called algorithm. Algorithm is step-by-step approach. Like if we have to reach the terrace, we have to reach first step, then second step, the third step. It's like that. So computer will do one thing, then two other thing, then three. So everything is planned, and that is called algorithm. Then there are certain things, deep learning, machine learning, and artificial intelligence, wherein the algorithms, as I said, these algorithms are step-by-step instructions. These instructions can be supervised, unsupervised, or reinforcement. Supervised is where we know what is happening and it's obvious that computer would perform these kind of things. But unsupervised is wherein computer has evolved to that level that computer will find itself that by learning again and again that I will do this and this and this, and reinforcement is both these together. Some part is supervised and some part is unsupervised. Then modified variables or weights are the things which each step computer is making some changes. I know it's a bit complicated, but at least we can try to understand what is happening. So these are the three types of things which are happening. Deep learning, machine learning, and artificial intelligence is the last and the ultimate thing. Deep learning is initial part. It's a part of the machine learning. Machine learning is a part of the artificial intelligence, and artificial intelligence is the final thing wherein the computer can do all the cognitive functions as well. So what is machine learning? Machine learning, like I have given the data set to the machine that, okay, this is abnormal. That has been, the computer has learned this thing that, okay, this thing is abnormal. Now, various inputs the computer will accept, like whether there is cortical involvement, what kind of signal it is, whether it is hypointense, hyperintense, or it has got calcification, hemorrhage. All these things computer will pick up and enter the calculate with various other factors and give the output. So the computer will decide whether the tumor is an oligodendroglioma or the astrocytoma. So output layer will depend upon so many factors which we have already given and computer has learned over the course of time. Then deep learning, as I said, is a bigger part of the machine learning, wherein many neuronal structures come and play a role. The input is given, each input is again has some weights over it, make the calculation and pass it on to the other node. Over here also again some variables are added and pass it on to the, it's like neurons, like we have in neurons in our brains. Each neuron is connected to many more neurons and they transmit signal. It is according to that only, it is almost the replicating of that thing on the deep learning. So this is the final how the data is assessed. First of all, we decide the modality. Like if it's a raw scanner data we are presenting to the computer, or it's a radiological image. The computer which compare it with the ground truth and decide whether it is a phantom or it's a real data. So once the computer is sure that it's a real data, then depending upon whatever feedback has been given to give the answer, the computer will generate a report. And it is very important that AI is not only playing in role in diagnosing, it is actually playing a major role in management also, because it will compare it with the pathology report and it will plan treatment as well, and therapy response as well will be judged, and the final outcome is given to the ultimately this final outcome is given. Look at these examples. There are published data wherein the deep learning applications have shown early promise in segmentation. Now this is all about segmentation. It's not about, it's about head and neck segmentation only, wherein we want to see glands separately, we want to see the lymph nodes separately, we want to see the oropharyngeal pharynx separately. So segmentation is important. In this segmentation only, the deep learning has shown a very good promising results in segmentation of the tumor volumes in nasopharyngeal carcinoma, detecting head and neck nodal metastasis and identifying extranodal extension of the tumor. All this is published data. And in the now there's term called radiomix. So radiomix is the application of certain imaging quantification data which is invisible to human perception. As I said that I cannot see hypoxia, tumor hypoxia, I cannot see if the tumor has choline in it, but computer can see. So all these quantifying data, the artificial intelligence assess on its own and comes back with the final report. Okay, this tumor is having hypoxia and this tumor is having this much choline. So the chances of radiation, the successful radiation therapies are more or less. So it's going to happening. It will happen sooner or later. In few years, it's going to happen. So there are published work with the wherein we have fed the 525 radiomix features from the MRI imaging. So nasopharyngeal carcinoma was assessed by using these 525 radiomix features with 5 clinical features, and the machine learning model accurately predict 3-year disease progression. I'm not talking about diagnosis here. It's about disease progression. So the computer will tell us whether the disease will progress or it will respond to the treatment, and how much it's gonna respond, and what are the chances that it will progress and how much it will progress. So this is very important, and these things are happening. Another study wherein the radiomic features of oropharyngeal carcinoma was found, it was found that the machine learning generated signature was better and predicting recurrence after radiotherapy than clinical features such as human papilloma status, smoking, and age. So all these things together, they are poor prognostic features, but the computer could give us a much better results on calculating the certain other radiomics. So with this, I think I have try to do justice to what the topic was given to me. So the take home points are, not me is the key. If we want to read, if we want to investigate radiological investigation, then not me is the key. The morphological and functional imaging are very important part of the tumor management, because nowadays the things are shifting from morphological to functional imaging, wherein the answer lies why the tumor recur and why it is not responding to the treatment, or what would be the tumor progression, like that. And the concept of AI is definitely it's going to come very soon and in a very elaborate way. Thank you.
Thank you, sir. You have explained, it was a wonderful talk. You explained very hi-fi things in a very simplified manner.
Thank you.
Now I would like to invite audiences for any query or any questions, if there is.
Dr. Surendra, Dr. Ishwar here.
Yes, sir. Yes, sir. Sir, please.
I have a small query. You said that blood and flow can be used to diagnose or see the extent of tumor. Will it not interfere? Suppose it is inflammatory. Even in that case, what you showed, that blood, red and blue imaging in the pterygopalatine area or retromolar trigone area. So will not the inflammatory process also affect the this vascularity? Then it will be difficult to make out whether it is because of tumor or because of inflammation.
Yes, sir, you are right. But as I said that there are graph pattern which help us in deciding whether we are dealing with a benign lesion, infective lesion, or malignant lesion. There are three types of graphs. The one is where is there is contrast enhancement, and there is a static gradual enhancement, which is a feature of benign lesion. So there will be enhancement in that benign lesion as well. But depending upon that graph, we will say this is a benign lesion. Now, if there is an enhancement, early
I'm
enhancement.
talking of inflammation, say abscess, parapharyngeal abscess, or that
Yes,
way.
this is I'm coming to that only. So the type 2 graph is for inflammatory lesions, wherein there is enhancement and there will be a plateau after that. But malignant lesions, there will be enhancement and there will be washout. This is one thing. This is the graph pattern which decides what kind of lesion we are dealing with. Secondary, I have shown you the imaging where we have put the color red, blue, and like that. But we can actually quantify it also, which I have not shown. Like I mentioned that we can measure the blood flow, blood volume, and permeability index. So all these things are taken into account before saying that we are dealing with a malignant lesion. So I have shown you just one part of it, and there is a lot of calculation which is at the backstage where we get the data from it, and there are set parameters like this much blood flow is there, this much blood volume is there, and this much permeability index is there, then it's a malignant lesion. So there are so many things which we take into account before saying that the lesion is malignant or inflammatory.
Another thing which you said was this artificial intelligence or that boost RT. So will not vascularity be affected because of radiotherapy and fibrosis subsequently when the tumors is we evaluate the patient or the lesion after radiotherapy 6 weeks we do the PET or so will not it be affecting the vascularity of the patient so that hypoxia and everything what you are talking about will be affected?
Yes, sir. That will be there. That will be there. But there are certain set parameters because there are values which I have not shown you. I'm not
That
included
may
in
be
the
detailed.
because that will be very physics, and a lot of physics will be there, and that makes the lecture boring. So I just wanted to introduce things to the ENT fellows so that they should have that what is coming, and how we do it, that is a different thing, and how we present is that is different. So there's a lot of data set behind before deciding what kind of lesion we are dealing with.
That iodine thing which you talked about in the carcinoma tongue, subsequently that plain CT, then with contrast, and then that greenish thing you showed. Again, will it replace PET? Or is there any advantage of iodine or the PET, or PET is already established?
I'm sorry, will you repeat the question, please?
You showed in one slide there was a carcinoma tongue lateral border which is near to the tonsil, and then it was better seen on the iodine scan. If you recollect your slides.
Right.
So that's something similar we see on the PET also.
Yes. See,
but PET we use as a follow-up or for recurrence or residual thing. We do PET after 6 weeks or so. Will this replace this iodine thing? Will replace the PET, or is it a diagnostic tool?
See, most of these things are complementary to each other. It's not like that it's going to replace it, because all these things, there are multiple modalities to reach a final and At times, we are not sure about the PET as well. And at times, we are not sure about the CT perfusion reports as well. So we have to collaborate these things. And if required, we may go to the other modality or other investigation as well. At times, yeah, both the things, all these are functional imaging. The CT perfusion as well, as you said about the iodine map. So what happens is in iodine map is we from these two data sets or KEV images, we take the data which is of the iodine only, right? So iodine is basically the contrast. So that part which is there on the lesion, the enhancing the component is beautifully shown on that. That doesn't mean that it's not there. It's better shown on iodine map, right? Similarly, on PET CT as well, the part of the lesion picks up the FDG, and that is bright, right? So this is how we see on various things, and most of these things are complementary to each other, and they are evolving. Nothing is
Kulwinder sir,
perfect.
thank you,
Otherwise,
doctor.
we would have said that this is the investigation that will be.
Do a better work than what a human brain or human thinking can do. Yes. So I think that AI is going to take over.
AI is going to play a major role in the coming years. So, because my talk was about the tumor lesions, so I right that it is going to play a very important role in coming years. About the lot of calculations it can do in seconds, which we may not be able to perform by looking at it. It's not only the ENT part of it. In a radiology as a whole, the AI is going to play a major role.
It's going to play an important role. So another thing, sir. Another thing which I was watching this, there's another thing which we discussed is a diffusion-weighted MRI.
Yes.
And I would like to add to that. There is a particular type of surgery in Manchester which they started doing not more than 20 years now. That is called as software reconstructions. We
Okay.
had intact and over, now we are doing software reconstructions. And in which the protocol itself says that after 6 months after doing a mastectomy cover, with the software reconstruction cover, we should do that diffusion
imaging.
So, sir, can you tell about like how exactly the cholesterol would be seen on that diffusion-weighted MRI? Because there is a decision of choice for the any kind of recurrence we have to look for in a patient who is not presented to us, but it is for the follow-up of the patient.
See, the diffusion, the basic, the physics of diffusion imaging is we see the movement of the water molecules, the random movement of the water molecules, which is there in each and every patient, each and every cell, which is there. But there are certain tumors or wherein the movement of water molecules is restricted because of the tightly packed cells. Yeah. Similarly, in cholesteatoma, there are tightly packed cells, so there is limited water movement. So we pick up those things by lot of calculation and algorithms, and we come out with image. And as I said, there are two images, diffusion and ADC, and depending upon these two, how the signal are appearing on DWI and ADC, we also the measurement is there on the ADC. We come to a value that okay, this much diffusion restriction is there, and we can compare it. Like if the ADC value is 1.2 into 10 to power minus 3 in one particular scan, and after 6 months, if the value of ADC in that same area has increased, that means the movement of water molecule has also increased. It's like that.
It's now investigation of choice for the any recurrence of the residual.
Right. That's why we compare it with the previous, and we measure the ADC value previously and after, and we come up with whether the cells are more tightly packed or there is water movement. So if there is water movement, there is increase in ADC value, that means the tumor is responding or the lesion is responding to the treatment. Thank you.
Shalini ma'am, would you like to add something on this?
Yeah, first of all, I just want to thank Dr. Uma ma'am for inviting me for such a beautiful session. And I would just want to add on, as beautifully explained by Dr. Kulvinder, all the modality and all the recent advances, they are just adding on the what we have previous imaging modalities. Like we have basic CT and basic MRI anatomy that cannot be replaced, or basic tumor characterization that cannot be replaced by the newer or recent advances. That can just add on the what we have the previous results. We can add more sensitivity and specificity for the tumors, or we can just guide the clinicians that tumors are responding, tumors are not responding, or whether they are radio sensitive or chemotherapy sensitive, or whether they will take more cycles. In that, so we can just add on with the newer or recent advances, because those are the upcoming things and studies are being carried out. So just it will take some time to establish those things. So just we can add the confidence limit in the previous tumor characterization or tumor diagnosis. So and I would just want to add one more thing. Obviously, ultrasound guided or CT guided FNACs or biopsies, those are more precise ones. So those can add the results. Those can give better results for the what we have right now. So I just want to thank you all. Thank you all of you.
Very rightly said. Thank you very much. Thanks a lot, sir, for the talk full of knowledge and your expertise. I feel all the corners of ENT imaging have been explained very well, and you have enlightened us on the latest trends in ENT imaging. Now I hand over.
And request Dr. Neha Salaria to felicitate Dr. Kulvinder sir with the moment.
Now we are proceeding to the next session, and I hand over the mic to Dr. Naveen Sharma. Sir, please.
Mute है ना?
अभी नहीं mute है.
Deepak. Doctor.
If they are ready.
अरे ये ठीक हुआ ना, हमने इसको कवर कर लिया। म्यूट कर दो इसको, इधर 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 म्यूट कर दो इसको, म्यूट कर दो। देख लो कौन कौन।
Dr. Handa sir, Dr. KK Handa sir.
Yes, I am ready.
Sir, if you are ready, can we start 5 minutes earlier?
Yes, I have no problem. We can start 5 minutes early.
Okay, thank you, sir. Thank you, sir. Dr. Arun Goyal, sir, moderator for this session.
Yeah, I am here. Yeah.
Thank you, sir. Due to certain reasons, Dr. GB Singh is not with us.
That's all right.
I, Dr. Naveen Sharma, I will start with the proceedings, and then Dr. Arun Goyal, sir, please you moderate with the session. Good afternoon, all of you. First of all, I'd like to introduce our speaker for the session, Dr. KK Handa, sir. currently working as chairperson of the Department of ENT and HNS, Vedanta Medicity, Gurugram, since 2009. In fact, he established the department at Medanta. He had been associate professor in prestigious AIMS Delhi from 2003 to 2009. He had been Commonwealth Fellow at Glasgow Royal Infirmary in 2004. Sir passed his MS ENT from TGIM at Chandigarh with laurels of silver medal of first order. He has more than 105 publications to his credit in various international and national journals of repute. Sir guides DNBs in his institute and is heading a variety of research projects in his department. He is active member of various professional bodies. He had been president of Association of Phonosurgeons of India from 2010 to 2013. He was the founder secretary of the same association in 2003. Sir has been organizing chairman of World Phonocon in 2017. He has been member of governing body of AY. He has served as treasurer of NES. Sir has been a reviewer of journals of repute. He has been awarded many awards and fellowship. The list is exhaustive. I am looking at the list. I will just summarize. Z News, Times Media Research. The list is too exhaustive. I will not go into the full list. Sir is having areas of interest, phonosurgery, laryngology. In fact, Sir has been a part of various activities at our institute pertaining to the lasers and phonosurgery. It's our privilege that he has consented to be a speaker on the lasers. Dr. Arun Goyal sir, who is going to be the moderator for this session. He is professor at UCMS with special interest in lasers. Sir also has been a part of one live surgical workshop held in our institute. Sir, I invite you to kindly take over the proceedings of the session. Dr. Arun Goyal sir.
Yeah, thank you. Okay, so Dr. Handa has already been introduced and he's a well-known figure in laryngology and especially in use of lasers for laryngology. So I will invite Dr. Handa to start with his presentation.
Thank you, Dr. Goel. I hope I'm audible.
Yeah, you are audible, yeah.
And I thank Dr. Uma for this initiative. I think I was going through the program. There is a wide plethora of talks, and they are on recent advances, but very much PG oriented. So it's a very welcome program. Now, I've been asked to talk on lasers in laryngology. Now, this has there has been a lot of interest in this, especially in past 15 or 10 years. And as we have matured in the field, we have come to know more about lasers and more where the optimum indications are and where not to use them also. And as the experience has grown, we have realized the advantages. Now in ENT practice, there are two types of basic lasers. One are fiber systems and others are the rod delivery systems. Now, it is very difficult to say which is the best, but those of you who like to work the therapeutic indications and the general anesthesia when patient is lying, you are comfortable. We mostly work with the rod system, and we use the standard luminous laser. Though now luminous came with a machine which has a rod delivery and a fiber delivery also. But with some experiments, with some experience, we realized that there is a cost involved to the fiber and the amount of precision you can get with the rod system with your laser cutting beam touching around 100 microns. Any delivery laser cannot give you that. However, it is not that fiber lasers don't have a use in laryngology. They are useful for something which is below the cord, something in the trachea, papillomas going down, something even lower down where your rod system is difficult to reach, not impossible. We have a bronchoscopic attachment which we use to the machine, and times we do access that, but fiber laser is easier. Then if you have vascular lesions, then you can use an Nd:YAG laser. A rod system is a CO2 laser. And you can also use KTP. And the cheapest option is probably diode, but the thermal surrounding damage is quite high with that. So if you were to ask me which is the best laser, and if you can afford it, probably the best one is a CO2 rod delivery system. Now, why laser? Why not just use cold instruments? Why use this expensive gadget? The first is precision. You see all the lesions on the vocal cords. We use laser where you have a microscope which is coupled to the laser machine, and you get a precision of as high as 100 microns. And your both hands are free, and with just holding the joystick, you are removing these lesions with a lot of precision. Secondly, hemostasis. Yes, to a certain extent, it is a hemostat, but we must understand it is not a very good hemostat. So certain vascular lesions, bigger lesions going when we are excising CA larynx towards the lateral part, we need to keep a bovie cautery. Healing is better. I think what I feel as the biggest advantage of laser is if you see these laser MLSs after a couple of weeks, the healing is almost as good as natural. If you do it with a cautery, or if you apply cautery or radio frequency, there is fibrosis. So this is, I think, the biggest advantage. The healing is without fibrosis. And in larynx, I think it is a unanimous international opinion that laser scores over cold instruments, radio frequency, coblation, etc. Now, about a word about coblation also. Coblation is a good tool. It generates less heat than the normal cautery. There are other better indications of coblation. Say something in the oral cavity. Even people do tonsils, adenoids, that's fine. But coblation, the problem is it has a very broad contact surface. If you use even the laryngeal wand of the coblator, the contact surface is very broad. And with laser, if you have a micromanipulator and a scanner, you are going to get a beam which is very, very precise. So there, how laser scores over a coblator. Now, this is a statement which is very important. A larynx laser surgeon has to be a good phonosurgeon. Means if you are going to operate on the vocal cords, there is a functional element involved. Patient has come to you with a voice change. He wants his voice back normal. So vocal cord is a very, very functional and dynamic structure. It is a layered structure. If you don't understand the layers and you cut something wrong, something deeper, the patient will remain hoarse for voice for life. And as you know, you can see in the diagram also, there is a squamous epithelium. Then you have a basement membrane, there is superficial lamina propria. And then we come to the most important structure, which is the vocal ligament. It is formed by intermediate lamina propria and deep lamina propria. This should not be damaged. Most of your surgical work should be medial to vocal ligament. Unless you have malignancies which extend laterally, then we don't have a choice. We do different cordectomies. But for benign lesions, you should always stay medial to the vocal ligament. And with experience, once you start doing laser chordotomies, say superior chordotomy, you lift up the flap, we start identifying the vocal ligament. And once that you take, like facial nerve in ear surgery, you take that as a sacrosanct landmark, you will not go wrong. Your functional results, the voice results will be very good. Now I'll show you a small simulation video. This is the larynx, how laser works. Here, this is the micromanipulator and the scanner, which is attached to the microscope and the laser machine. And this is the interface between your laser machine and the microscope. And we have deflected laser beam. And it
Sir, we lost your voice.
Dr. Handa?
Hello. Okay. Hello, sir, we lost your voice.
Dr. Handa is not connected right now, I believe. He has lost the internet connection.
Sir, till then you can share your experience as.
No, but he will have to present.
Sir, we got message that it will take 2 minutes.
Okay. So we can wait for that time.
We are getting message, sir, that he will just connect in 2 minutes. There are certain power failure issues. We are waiting for sir to rejoin.
Uma ma'am, meanwhile you can share your experience with laryngology and laser.
I just want to share
Yes,
that
Dr.
we
Handa is
also have.
I am there. The light had gone off. I'll resume.
Okay, sir, you can continue.
Yes,
okay,
I'll
sir,
just
please
continue.
continue, sir. Please
Sorry for
continue, sir.
that. Just give me 1 minute.
Sir has rejoined us.
Are you getting my screen, please? Are you getting my screen?
Yeah. You are visible now.
Okay.
Yeah.
Yes. So I will start where I left.
Yeah.
It takes about 2 minutes for the generator to start. That is the problem. So you see, this is how precisely it is cutting a lesion at the free epithelial part of the vocal cord. And now, there are some lesions which need fulguration, means you don't need to go very deep, but like telangiectatic areas on superior surface of the cords, small dysplasia. So you can use it in the fulgurating mode with a ring. And this is not cutting, this is just fulguration. It is more hemostatic. And for surface lesions, it is very useful. Now, regarding the laser setup, you see this here we are using Steiner's endoscope. This is a distendable scope. Suppose you need to resect malignancies, which we do supraglottic sometimes base of tongue, or even say other lesions, you can distend the proximal part of the scope with these attachments and also the distal part. This is a bovie which is always kept with the extensive laser resections, because this is a bovie suction. So you need to at times use this. This is the console. I'm sure those of you who are familiar with the machine know it can do a lot of things. We like to work mostly in the super pulse mode. For ENT surgeries, you seldom require more than 21 watts. For laryngeal work, it is 10 watts is good enough. 21 watts we need to when we are doing stepidotomy. There we give a single shot with 21 watts, but larynx 10 watts is good enough. And then you can play with a lot of things. You can work in the super pulse mode, which is high delivery, energy delivery in a short time. You can work in the CW mode. You can work repeat shots or continuous. You can change the depth, and you can also the amount of the beam, the intensity of the beam, because with light, if you have very intense beam, then you don't see anything. So all these things you can play around. Then the micro manipulator. This is the interface between the laser machine and the microscope. Your laser must be compatible with the microscope. You must have a scanner. Today, buy a laser with a scanner, because you are able to modulate different types of cutting beams. If you have a rounded lesion, you can have a convex beam to one side or concave to the other side, straight beam. You can change the length, you can change the shape. So a lot of things you can do with the scanner. Now, our program in Vedanta started in November 2009. So this is the 12th year. Before that, the first our exposure to lasers was in PGI in 1991 when Professor Weinmera, he had bought the first laser machine in government sector in PGI. But those were very early days, and larynx hardly anything was being done. It was mainly for other issues. Then AIMS had a laser, but in Medanta, once Medanta started, this was one of the first few things to be bought. And average of, before the COVID times, about 20 to 25 cases are being done per month. This is a Equipulse, and there is a robotic scanner with the laser. Now, the laser safety is of paramount importance. Anybody who is starting a laser program, have your safety protocol in place, because of one accident can be a big problem. And you must, the issue is not why a laser fire occurred, issue is were you following the laser safety protocol. So there are guidelines. You must have a trained, obviously, surgeon, then the anesthetist is very important, and a technician and a nurse also, and a backup engineer. The laser sign, we do the eye protection of the patient and the personnel in the OT. And the important thing is the type of tube we use. Now, it is always desirable to have a laser protective tube, but now there are a lot of experienced people who use the normal tube, but that is with a caveat. You have to have that much experience, and there has to be something separating your tube and the laser beam. So advice is people who are starting, who are beginners and want to take no chances, use a laser protective tube. This tube can be reused, so the cost is not that much. Then the laryngoscope, I've already talked on this type of a laryngoscope, but this is required in where you need wider exposure. You can use a normal Klein-Sasser jet black scope so that there is no reflection. But most important thing is you must have a suction evacuation methodology. Here, most of these scopes, they have a evacuation cannula. You can attach your tubing to the cannula, and the smoke has to be regularly sucked off. We can't be left at the mercy of our assistant putting the tip again, because the area is very, very narrow, and you don't want too many instruments inside. Then the nitrous oxide is to be avoided, that we know, no nitrous oxide. The other important thing is FiO2 has to be always less than 31. This is a dictum which the anesthetist always learns and teaches. Now, we acquired a jet ventilator of Equatronics about 3 years back. So all our laryngeal work today, before COVID time, with COVID, there are issues with jet, which we have started again, but with certain caveats, is being done with the jet ventilator. Now, jet is a very, very useful thing. It gives the full airway to the surgeon. Otherwise, what used to happen, suppose you have papillomas, you are doing laryngeal work, you will, your posterior part, you have to remove the tube, work under apnea for 3-4 minutes, again insert back the tube. But with the jet, there is only a catheter in place of a tube, the whole airway is yours. But you need a trained anesthetist, and there is a learning curve and there is equipment. This is the jet ventilator. We have a electronics one, and this is the cannula, which this is the cannula. This is the jet cannula. You see how small it is. So it is hardly visible, and whole area is yours. Though during COVID times, in March, April, we again reverted back to MLS tubes. Again, say September, certain cases, there are complex airway cases, or wherever jet is of really help, there we are again shifting back to our jet machine. Now I will show you some lesions. This is a simple polyp, a broad-based polyp from the medial surface of the cord, slightly hemorrhagic or telangiectatic as we call it. So can be taken out with the laser. You will notice one thing, here my beam is not very sharp. I have kept it, even I am in the cutting mode, I've kept it slightly defocused. Because in a telangiectatic polyp, this is a hemostatic also. So some hemostasis I'm able to get with the cutting mode. And the final hemostasis is with this, say, fulguration with round beam. So you can combine both and get the desired results. Now, we get a lot of professional voice users. Now, this fellow is a Sufi singer. Now, you will hear his voice. He came to me with this polyp, which is shown in the chat below. You listen to his voice.
Dr. Handa, we are not able to hear the voice.
You are not hearing the voice?
No.
It should be on. Just let me check, sir. Just let me check for a second. Give me 1 minute. I think all my buttons are on. There is some, I think, problem at the transmission. There.
Can you please share the system sound?
Share the system sound. You are. How do I get to that? You are sharing screen. So where is system sound? It is here computer sound. Okay, I got it. Now you should be able to hear it. Can you hear now?
यहाँ दिल से मांगो ये हाजी अली है खुदा के वली है
So now your question will be, should we use laser in a professional voice user? Now my take is you can. There is no problem at all. It is better than any other way of removing these lesions, provided you understand the patient, his aspirations, his problem, and you are slow in advising any laryngeal surgery in a professional voice user. Now, this was a singer. He had developed this. First, he came to me. I understood him, called him for a second meeting, and then we decided to operate. And after surgery, his voice became all right. So they are a separate group, and they are a demanding group. There is no to surgery, but you should not jump doing surgery at the first look of the patient. Try to understand. I'll show you. There are, because surgery in a voice user, the important thing is what is his singing voice? What type of singing is he doing? Like Sufi music is different. We had another Bangla singer. We had a Rewani singer. So they have all different techniques, different, you can say, singing dialects and different aspirations. So we have to understand, and then we have to work in our mind what we can deliver. If I am not sure of any proper results, I will err on the side of waiting. Where I am sure the lesion merits, suppose a singer comes to me with a sulcus, I will not touch him. I will just give him voice therapy. Let him stabilize. Because I don't want to spoil his singing voice. He is not concerned with his speaking voice, it is his singing voice. So that is the take on these sort of patients. Now, this is a patient with papilloma. Again, a very common problem. You get these patients with juvenile papilloma. And laser is a very good tool. At times, I'll show you in the subsequent video, we use the divider to debulk the papillomas, and then we use laser for the final work near the cords so that we don't damage the vocal ligament. But comment about papillomas is papilloma, because of the biological nature, they will recur. So whenever you take up a papilloma patient, explain to the patient that they will recur, and don't be surprised if they recur. And be prepared for a long overhaul of these surgeries when you have to do debridement. The other, you have to remove the papillomas. You need not be very aggressive. It is not a crime to leave some papillomas, say near anterior curvature. You can always go back second time. But it is not desirable at all. Like if you damage the vocal ligament, and the first surgery of papilloma should not be done by senior resident in the emergency. It should be done by experienced surgeon in an elective OT setting with due respect to the functional part of the vocal cord. Papillomas you will remove, but the voice, the vocal cords which have been scarred, the voice of the child will remain hoarse all his life. So this is again a different field where laser is of immense value, but understanding what we are doing. Now this patient here, you will see it's a moderately large papilloma case, and we use first laser in a defocus mode to debulk. And as we come near the cords, we get less, we get slower. One problem with the jet is that you don't have a cuff with the jet tube. So whatever modality you are using, you have to learn to spill that much blood that it doesn't go down. With experience, we are able to do that. The small second problem with the jet is sometimes there is some movement of the vocal cords. So these are two things which we learn to work, but the in-turn advantages are immense. Otherwise, if you don't have jet, you can just use your MLS tube, which is longer length, and you can go down. So I will move forward slightly, and you see slowly. Be prepared for 45 minutes to 1 hour for papilloma work. It's no point trying to hurry. One more thing I'll show you. You see, this is a Lindholm cord retractor, useful in a lot of laryngeal surgeries. You are able to separate the vocal cords and then work. And even superiorly, you have papillomas. We are now using in the fulguration mode, and we are able to. I'll show you the final result if I am able to. Yeah, so not bad. This is the something, and we have a look down, so there is no tracheal or other papillomas. Now, divider I do use at times when there are very big papillomas to debulk, and you will see. Sorry, and as you come near the cords, we shift over to the normal laser. Now, we get very extensive cases at times. This girl was flown in with endotracheal tube from Nepal, airlifted, and she had papillomas even jutting out, lungs were involved. So first thing was, we did a tracheostomy. I will comment on tracheostomies and papillomas with this, but this patient had no choice. She was on endotracheal tube. We did a tracheostomy, and then we had to use this fiber laser. This was a thulium laser. I got hold of it from our urology colleagues. They used thulium. And then we did coring of the papillomas and trachea, which were up till the carina. And multiple sittings were done in this girl, and she did survive for a fairly long time. And this was you can see the chest picture also. So regarding tracheostomy, the classic teaching is correct. You avoid tracheostomy as far as possible in papillomas, but in life-saving situations, if you have to do, you have to do. Now, abductor cord paralysis is another fantastic indication for use of lasers in laryngology. Now, you see, this is a simple Kashima procedure I'm doing, bilateral abductor cord paralysis. We cut the vocal process and the cord junction linearly with a fine laser beam and go laterally. Laterally, we must go till we reach the thyroid cartilage. This is very important. The commonest mistake is to cut only this part of the vocal cord and then say, the patient comes back to you after 3 weeks. No, you have to go till the cartilage. Even there is a bleeder there. As you reach till the cartilage, you will have some bleeding coming. So be ready with the booby. Here, I think we are combining a partial arytenoidectomy also. So this is sometimes done. We combine a partial arytenoidectomy, the vocal process, and we do a laser cordotomy. Here we are doing on the other side also. And similar procedure. There is another tip. At times we give a cut on the false chord also. False chord, here we have given a cut on the false chord. This gives you a three-dimensional aperture. Now you see on one side, partial retinoidectomy with Kashima, other side just Kashima. Now the only slight problem, you may have some coughing because of mild aspiration. So be prepared for that. Do swallow therapy, and this sort of patient will not recur. But if you do one-sided chordotomy, they can recur. Now, these are another group of lesions called lesions of uncertain pathology. You get reports like dysplasia, hyperkeratosis, carcinoma in situ. So all of them are today grouped as lesions of uncertain pathology. And this is one group where laser is of immense importance, use. Previous days, you used to do, say, remove the epithelium and called cord stripping. Today, that procedure should be condemned. You use a laser. Laser may be used either in these lesions, you may do a biopsy, but what we end up doing is mostly excision biopsy using the laser. And if they are too diffuse, then we can switch over to the fulguration mode, like you see the first lesion. And this is another common use of laser, verrucous lesion. We don't know whether this is malignant or benign, so we'll do excision biopsy, send it for histopathology. But this procedure, this lesion can come out very well with the laser. I will just move it slightly forward, and you are getting a nice plane. So that is an indication, may not be malignant, but varicose lesions you cannot predict. You have to wait for the final histopathology. These are commonly known as Ackermann lesions, and you are cutting in a good defined plane, and you will see you are able to cut nicely and deliver the lesion. So the lesion is out, went for histopathology. This was a varicose hyperplasia. It was not a malignancy. So if it was malignancy, histopathology, then he will need further treatment. And today we know these varicose lesions are not radio resistant. They are not radio sensitive, but they are radio receptive. So it is considered okay to give adjunct radiotherapy in these lesions if required. Now, this is another case showing this sort of a lesion, and we will do transoral microsurgery with subepithelial chordotomy. And I'll try to show how well we can use the laser to do a superior chordotomy. We define the lateral limit of the lesion, go subepithelially, and then use this triangular forceps or Bushire forceps and go in the subepithelial plane, trying to separate it from the vocal ligament without damaging the vocal ligament, and do a subepithelial dissection and remove the lesion in toto. If it comes out to be a lesion of unknown etiology, this is the end of the treatment. But if it turns out to be malignancy, then you need a further total laser chordectomy or radiotherapy. Patient counseling is done, and whatever they decide, we go by that. So you see, also note the threaded patty we have kept. This is a laser MLS tube. It's an older patient before CHET, and this we always keep so that you are protecting this. I now use normal tubes. I said with the caveat in the beginning, but we protect it with this patty. The inflammable part is not mostly the tube, though literature says puts a lot of emphasis on tube. It is the char. If you work with a laser which produces a lot of char, that is most inflammable. Then the things like these threads or patties. Now early cancer, this is a different ball game. Here you will need to do a chordectomy. So you know the laryngology, European Laryngology Association's say definition of chordectomy. So we end up doing a chordectomy. So this was the lesion initially, and he was operated. After first biopsy, it came as common cell carcinoma. Though one looked, it appeared just to be a polyp, but it was not. And after the type 3 laser chordectomy, we do frozen sections on table. Frozen, you just on vocal cord, you just need a margin of 1 or 2 millimeters. It is not like your oral cavity where you need 1 centimeter or 1.5 centimeters. Frozen is desirable, even if your clinical feel is that you remove the lesion, because for medical legal purposes also. Because whatever you do, malignancy, even in T1 lesions, there is a 5% chance of recurrence. So if you've done frozen on table, you are safe and patient is reassured. Now, a lot of these patients where for early cancer, we are doing laser resections, we need to reconstruct the cord. Some of them demand even on-table reconstruction. They want the voice back as fast as possible. So we can offer that provided the frozen margins are negative. And at times I do use this autologous fat, take autologous fat, harvest it, mince it, and then use human insulin actrapid to make a fine emulsion and then inject using this syringe, Paratis injections, fat injection syringe, or you can use, if you don't have this gadget, you can use your 16 gauge, vein flow, take the needle, hold it with a crocodile, and you need a tubing to inject. But disadvantage with this technique is a lot of fat remains in that long tube. You can hear this patient's post-op voice. Acceptable, not very great, but acceptable after a type 3 cordectomy. So it depends on patient's aspiration, what he wants. If he's too exacting, then we do a fat injection. If he's all right, waiting for some time, then he's put on voice therapy, reassessed after 6 months, and then a secondary fat injection is offered. Now, as I said in the beginning, we must mature where not to use the laser. If you get this sort of a lesion, there is no place of laser. This lesion is going to anterior commissure, and this demands a CT scan. If it involves a cartilage, it's a T4 lesion. Even if it doesn't, it is involving anterior commissure, and it appears it is going in the false cord also. This is no. You just take a biopsy.
Dr. Handa, could we please know how many slides are left?
I just need 5 minutes. That's all. 4 minutes, about 6 or 7 slides. That's all. I'll cut it down to 3 minutes.
Yeah, please. Yes, please.
So you this sort of a lesion, no laser. They needs a CT, and then we decide on merit. Now see a laser cordectomy, preoperative lesion. This is the involving the full length of the vocal cord, excised, and post laser excision. Post laser excision, he's phonating with his false cords, and there is no reconstruction done, but it is an acceptable voice. So this is like voice of dysphonia plica ventricularis. Now, why not radiotherapy? There are a lot of issues with radiation. If you do salvage surgery, there is a huge chance of fistula formation, and literature supports the number of larynges preserved after initial laser cordectomy is more than if you do primary radiotherapy. Now, in stenosis, one comment: don't fire laser in every case of stenosis. There are defined indications if you have glottic pathology, if you are supraglottic. But for grade 3 and grade 4 subglottic or tracheal stenosis, there is no role of laser. You need open procedures. So a lot of disrepute to laser comes if you get a laser and you start firing without assessing these stenosis. There is a defined use. Now, if there is not much of time, but one indication I will emphasize is corrosive strictures. We get a lot of corrosive strictures. So you can do an initial release of the supraglottis with the laser and then follow up the patient. They tend to recur, but there is no harm. It may avoid a tracheostomy. We have done in a couple of cases laser release. So now COVID time, the last comment before I stop. COVID time, we stopped only for a month, and then we restarted our surgeries in end of April or first week of May. We were slow, patients were few, but now again it is picking up. All due precautions as regards PPE. The anesthetists have a protocol in anesthetizing the patient. Details you can read what they follow. Full precautions were being taken, but we never stopped. And these cases, the laser surgeries, laryngological cases are still being done. There is a pre-operative 1-week COVID test being done. If negative, these patients are taken up. And this is the textbook. There is a good chapter on laser contributed by one of the eminent authors. And thank you very much. Any questions? I'm very happy to answer.
Thank you, Dr. Handa, for a very wonderful presentation on lasers in laryngology. And now I'd like to request Dr. Arun to add to this lecture by sharing his experience for a minute.
Yeah. Nice presentation, Dr. Handa. You covered the whole gamut of laryngeal surgeries. I would like to make a few comments about the jet ventilation. The jet ventilation, it tends to entrain air into the trachea, so it at times can suck in the blood which is there in the larynx, or if small papillomas as you were dealing in that case, so that pieces can be sucked inside the airway. Otherwise, jet ventilation is a good technique. It provides for a wider airway with a very small tube inside. And then for doing all these CO2 laser surgeries for the larynx, we can always inject the submucosa using saline adrenaline. The advantage is that it acts as a heat sink, and at the same time it also provides us with hemostasis. So that is an advantage. We use a high concentration of adrenaline in a concentration of 1:10,000, so which provides us this hemostasis and works as a heat sink.
Yeah, both are very valid points. Both are very valid points. The first, you have to learn to work without this is so you have to secure hemostasis and prevent any blood from going down. And second is also very correct. Both are relevant points, and as you go do laser surgeries, you understand what Dr. Arun is saying.
Yeah. And now we are running short of time. I believe Dr. Uma was saying that they want to finish it early, so I will like to then thank Dr. Handa and close this session.
Yes, sir, we are running out of time, but it was a very good experience sharing with you the experiences, your experiences as, and now because the next speaker is waiting, so I again thank you both of you for a nice presentation.
Thank you very much.
Thank you. Thank you, Dr. Uma.
Thank you, sir.
Thank you, sir. Thank you. I, Amit, take this opportunity to invite Dr. Professor Alok Thakkar, Head of the Department, AIMS Delhi. Dr. Alok Thakkar had been a source of constant motivation for all the ENT fraternity people. Dr. Thakkar has more than 250 publications, more than 2,400 citations to his name. He has been a pioneer in trans-robotic oral surgeries and has got very special interest in TAUS, that is a transoral ultrasonic surgery. I would like my dear friend and Dr. Kapil Sikka, additional professor, AIMS Delhi, to moderate this session on TAUS. It's an honor for us to have Dr. Sikka with us. Next, we will be listening from Dr. Sikka and Dr. Thakkar in the talk. Thank you. Thank you, sir.
Thank you so much, Amit, and many thanks your team and Uma ma'am for giving us this opportunity. I think there is no better person to speak on this topic other than Professor Thakkar, who has been one of the pioneers on tooth surgery. And whatever experience we have gained, we have learned from him, and maybe we'll be wiser at end of this session by learning his experience. It's one of the recent advances in minimal invasive surgery or minimal access surgery to oropharyngeal and laryngeal tumors. So, sir, we have your slides and video. You may start, sir. Thank you.
So thank you, Kapil, and of course, thank you, Dr. Garg and Dr. Sharma, for having us both on the same session. So we do this together. As you know, we work together in the same unit. And you have asked us to speak about the transoral ultrasonic surgery. This certainly is something that we have been doing for the past 3 years now. And I'll take you through what it is. So transoral ultrasonic surgery is often seen as something which is a little bit at loggerheads with transoral robotic surgery. Not quite so. They are basically complementary. They are very much the same. We do the same operations with transoral ultrasonic surgery as we do with transoral robotic surgery, with very similar outcomes. And of course, the basic advantage of doing a transoral operation, whether you do it with a robot or whether you do it with ultrasound or whether you do it with the laser, is basically that you get the advantage of the transoral. So when you work transorally and you don't quite disrupt the muscles and the sensory nerves and the motor nerves that come and feed into the pharyngeal musculature and the pharyngeal mucosa, then your outcomes in terms of swallowing are far better, because the coordinated involuntary swallowing function remains. And this is the basic advantage of doing it. Of course, we learned this first with the laser. So these are the laser supraglottic laryngectomy and the laser partial laryngectomy, which we started doing with the laser. And very soon these operations phased out to a large extent the external operations, because the swallowing outcomes were better than we used to get with we used to get with open surgeries. And then the robot, we could transfer or translate the same for oropharyngeal cancers. Of course, we were using the laser for oropharyngeal cancers too, but it was not quite the right instrument, because the laser is a straight line of sight work, while the robot is a place where you have the benefit of using articulated arms, which can wristed arms, which you can use to do a resection. So again, transoral excisions, which came with the robot. And I know you have already had a lecture on transoral robotic surgery by Dr. Dabas, and so I'm not going to take you very much into it. You're very familiar. So these are branches of the lingual artery being ligated, and then of course the nerves coming through into the tumor, which are being cut, and the whole tumor being removed in toto with the robot. The basic advantage is that you get good swallowing outcomes, and that is the advantage of working transorally. And the transoral ultrasonic surgery basically is doing the same thing with a new instrument. And this is how we do transoral ultrasonic surgery. So here's a patient who's got a FK mouth gag inside the mouth to open the mouth up. And what you see out there is a flexible tip scope. So you can work with two scopes. There's a 5mm 2D scope and a 10mm 3D scope. And the 5mm 2D scope, which is being inserted inside to have a look as to what's happening in there. And as you can see, there's not very much mouth opening, but the advantage of TAUS is that you can work with very limited mouth opening. This is where it compares a little bit favorably with the robot, because the robot has thicker arms and thicker scopes. And here you have a smaller scope and smaller arms. And this was our first patient, which we did with the help of Dr. Maria Fernandez, who was with us then. So what you see in the inset is that the scope is now being fixed on a stand. And once the scope is fixed on a stand, then you have these two instruments that you can see in the inset being used. And one of them is a normal crocodile forceps, and the other is a Maryland forceps, which we are using. So one is a grasper, and one is the Maryland forceps with a. So this is the ultrasonic forceps. These instruments actually are really laparoscopic instruments, and they are designed for the laparoscope, but they come in handy quite well to be used with the transoral approach too, with the FK retractor. So you get the FK retractor in, you get your scope in and fix the scope as it's fixed here. And then you can get your two instruments in, and you can of course get an assistant to use the suction and go in and do the operation. This is another operation, oncology, a little bit more more challenging. So what you see out there, of course, is the epiglottis, the posterior pharyngeal wall, the base tongue, and the lateral pharyngeal wall, and you can see the you can So the advantage of the dose is that the machine also comes with an inbuilt NBI or narrowband imaging, and that allows you better appreciation of the surface epithelium. So dysplasia or hyperplasia in the surface is seen a little bit better. And now we're doing exactly the same operation that you have probably seen Dr. Dabas demonstrate, which is a radical tonsillectomy. Here you see the two teeth from the mandible on the left side. You can see the anterior tonsillar pillar, the posterior tonsillar pillar, and you see this superficial lesion which involves the tonsil, the anterior pillar a little bit, and then onto the base tongue. And what we are doing here is basically trying to find the plane between the superior constrictor muscle and the medial pterygoid muscle. So you work in this plane between the superior constrictor and the medial pterygoid, as you see in the diagram there. So basically working lateral to the pharynx, getting enough deep margin, and working in this parapharyngeal space, so to say, to do an en bloc intraoral transoral excision. So that is the lateral margin defined with the medial pterygoid muscle there. That is the tongue, the TL sulcus, and you can go around. What you notice with the ultrasonic equipment is that hemostasis is very, very good, even better than you get with the diathermy. So you can cut with great confidence, provided you know your anatomy, of course. And this essentially is the operation being undertaken: the lateral cut, the anterior cut, including the TL sulcus, the tongue margin, and let's skip forward a bit. So what you see now is you can see a little bit of the nerve coming through, the glossopharyngeal nerve. You can see a little bit of the glossopharyngeal nerve feeding into the base of tongue. And once you see the glossopharyngeal nerve, you know it will be in relation to the styloglossus muscle and the stylopharyngeus muscle. So you see the nerve there. I hope you can see my pointer. And you can see the styloglossus muscle being defined out there.
Yes, sir.
And basically, you can do a safe transoral excision with appropriate margin and preserving the transoral, the structures laterally, so that subsequent coordinated swallowing is easily preserved. This essentially is the operation. Our experience in the first year was on 22 patients, and I'll show you our results over a 18-month follow-up of these patients. These are mainly oropharyngeal lesions, some posterior oral cavity lesions, some supraglottis lesions. And they have had surgery as you would have for an appropriate oncologic dissection where you're doing an external operation. So they have had the neck dissection as appropriate. They've had reconstruction as appropriate, but we tend to use with our TAUs and TORs local regional flaps rather than distant flaps on most occasions. And they have had post-op RT and CRT as appropriate. So in terms of functional results, we have never needed to do a tracheostomy. We have always been able to have oral feeds without any issues with aspiration. And yes, we have had a couple of problems with secondary hemorrhage. When we got this equipment, we were told that hemostasis is very good. And we realized that hemostasis was very good while doing the operation. But in terms of secondary hemorrhage, wherein the wound heals, there really seems to be no difference between doing TORs or TAUs, and there is a reasonably high risk of secondary hemorrhage. We learned that as we get along. These are our survival figures. Short-term survival at the moment, because we are really looking at 20-24 months at the most in terms of follow-up, but good overall survival and good disease-free survival, considering that these are 9 T3, T4 patients and 9 T1, T2 patients, or stage 3, stage 4 patients. So how does TAUs compare with TORs? That is the question everybody wishes to know. How does TAUs compare with TORs? Certainly it's cheaper, or should I say less expensive. I can't say that it's very cheap. You still need the equipment, but yes, much of this equipment is already available in a lot of hospitals with surgeons or with departments of otolaryngology, head neck surgery. The advantage we find is not only with regard to economics, but more so with regard to scheduling, because when you own the machine, you can schedule the case as per your wishes, while if you have a timeshare with another department wherein you get the robot only occasionally, as we do, then with scheduling onco patients, it can be a challenge because you can't quite keep them waiting for very long. So scheduling is better. Access, as I showed you, you can have problems with access with the robot or with any transoral operation, and these are the expanding list of T's where you can have problems with transoral access. So certainly trismus, big upper teeth, big tongue, someone who can't extend the neck, these are problems. If the mandible is very narrow and there's a too little space between the two rami of the mandible, then that itself can be a problem. If somebody's had radiation, it can be a problem. But with TAUs, this is less of a problem because, as I said, you can work with a fairly little mouth opening. The equipment has been designed to be used through a laparoscope, through ports. So naturally, you can easily put them in through a transoral route, even if the access is limited. The other advantage is that because hemostasis is better, that also in many ways helps with access, because then you have the confidence that you won't run into problems, that you'll have severe bleeding which you won't be able to manage through a transoral limited access. So again, the great hemostasis is a great plus in terms of being able to work with minimal access, with minimal access. The robot scores over TAUs in terms of having better equipment, in terms of the arms being more versatile, having more wristed equipment. So as you know, now the robot is getting more and more sophisticated. And in the next generation robot, as you see in this patient who's having a retroauricular thyroidectomy, minimal access thyroidectomy or minimal. So what you see out here is instruments of the robot have now come to an advanced situation wherein you have two instruments in one. So what you see on your right is a scissor, which is also a monopolar. What you see on your left is a Maryland forceps to hold, which is also a bipolar. And then you also see a third instrument coming in, which is a pro grasp instrument. So with the robot, you can get a lot of instruments in, and you can't quite get all of this in with TAUs, and you don't have that level of sophistication. So with the robot, you can see that you have these instruments which are both bipolar and holding instruments, and you have these instruments which are both a scissor and a dissecting instrument and a monopolar. And this kind of sophistication you don't quite have with TAUs at the moment. But the TAUs does allow you to use the whole range of the mouse, so you can get a fair amount of range of motion. And of course, you have narrowband imaging, which I mentioned to you, which allows you to assess superficial tumors a little bit better. So complementary technologies, they all have their own advantages and disadvantages. And both have their uses, but both are really used to do the same operation. The problem with both is secondary hemorrhage. I talked about that. So secondary hemorrhage you can have if you have a large transoral wound. I mean, we know we can get secondary hemorrhage following a tonsillectomy. And if you have a large transoral wound, which involves a deep tonsillectomy, including the superior constrictor muscle and the tongue and the base tongue, then of course you're going to have some problems with secondary hemorrhage. So you have to be careful about that. And from that reason, our policy for a very long time, even with the laser, with the robot, with this, has always been to do a concurrent neck dissection when feasible or when indicated, and to ligate the feeding vessel. So we would ligate the lingual artery or the facial artery as appropriate in every situation. And if the concurrent neck dissection and the concurrent primary excision leads to an exposure of the neck contents through the transoral route, or a suspicion of this, basically risk of fistula, then we tend to generally use a sternomastoid muscle flap, which is superiorly based and which we just swing in and use it to plug that defect. On this occasion, we have used it medial to the carotid. We may place it medial to carotid, lateral to carotid, and plug the defect that you get in the tonsil base or in the lateral pharyngeal wall with this. And in our experience, it works quite well. We published this a few years ago. So of course, Dr. Kapil and I worked together with this. Now I'll show you a little bit more that we are doing with the TAUs, which is in terms of remote access thyroidectomy. And this, of course, is not transoral, but is using the same ultrasonic equipment. And here's a lady with a solitary thyroid nodule, fairly large, not tremendously large, involving one side of the thyroid. And this patient basically needs a diagnostic hemithyroidectomy. If a patient needs a diagnostic hemithyroidectomy, then this is a good way of getting involved, whether with the robot or with the ultrasonic instrument. So this is what we use the harmonic scalpel for the Thunderbeat, which we use, and a Maryland forceps. So here you see the patient with the head turned to the other side. There's a retroauricular incision. Flap is elevated right on till the sternum, and the diathermy flap is being elevated. And what you see down there now is a deep cavity which is taking us right inside. You see this 3D scope that we are using on this moment, which is a thicker scope. And you see that the neck flap is held up by a special retractor, which we use also for robotic thyroidectomy. Now what we see in there, the omohyoid is being pulled up, the omohyoid is cut, and you take entry under the strap muscles. You see the sternomastoid there, you see the thyroid, and you see that the sternohyoid and the straps have been retracted by the retractor. A little bit of muscle is still left. The sternothyroid muscle is still left adherent to the thyroid here, which is not a bad thing because it allows you a structure which you can hold to retract. And what we are doing now is cutting the strap or the sternothyroid muscle as it goes superiorly. And as you cut, you will gain access to the superior pole. Not yet. These are still fibers of the sternothyroid and some veins. So while we have now accumulated a fair degree of experience of doing a minimally invasive remote incision thyroidectomy with the robot, and while I would still say that it does offer you great advantages in terms of getting 3 instruments in rather than 2 and rather sophisticated instruments, we are also a training institution who have to sort of train our people to be able to work without the robot. And so from that end, we have developed this operation, which is using the ultrasonic instruments for remote access to thyroid for a diagnostic hemithyroidectomy. So the superior pole now being exposed and controlled with the same instrument. That is the advantage of this. You can be very sure about the hemostasis and the artery now. That was probably the vein we got. And now the artery, the superior pole being dissected and controlled. You can see that the straps have been retracted up. And I'll go forward a little. So you work downwards. Working along laterally to the nodule, some bleeding, probably from the inferior thyroid artery, structures around it. And then mobilizing the thyroid enough to see the isthmus and cut through the isthmus, and then you can, of course, remove your nodule. So because you have gained experience with doing this by the robot, it's possible to now also do this by these instruments. The robot had 3 arms. This has only 2. Nevertheless, a feasible operation. Working laterally. That's the isthmus being released. With the same instrument, yet one of the instruments has got great in terms of hemostasis. But obviously you're careful with using it laterally, which is why you get a little bit of bleeding, because laterally you're worried about the recurrent laryngeal nerve. That's the nerve stimulator checking that the nerve is working. And of course, cosmetically, it's a great operation to do. It's a good operation to do in terms of an incisionless thyroidectomy in selected situations. So I sort of conclude for you now, which is just really a primer to what we can do with TAUs. So as I said, with regard to transoral ultrasonic surgery, this is not very different from using it with the laser or the robot or now the ultrasonic surgery. You work on the transoral paradigm and improve functional results and get equivalent oncological results. And now we have started using this equipment to try and work in the neck, and we have developed this thing about remote access thyroid surgery with the same equipment. So thank you. Questions are
Sir.
welcome.
Yeah, sir. Sir, there have been few questions, sir. First is, sir, like comparable to compared to robots, the cost of consumables in houses, how much is the difference?
So the robot wasn't so expensive when we started out, but the robot is becoming increasingly expensive now.
Yes, sir.
When we started out, the robot was basically $200, which wasn't all that expensive per case, and
Yes,
we could
sir.
also reuse our equipment. But here we basically use only one disposable equipment, which is the Maryland faucet. That is the only disposable equipment,
Okay,
which
okay.
costs about 25,000, I think, currently. And you
25,000.
can reuse it, though they of course ask you not to reuse, but you can reuse it for a case or two or three.
Sir,
And
any specific reason that why don't they allow to reuse it for like for more cases, like in only one case? Why do this like?
so
What might be the
it sort
reason?
of loses potency as you use it more and more.
Okay, okay.
You use it too well, it doesn't cut and coagulate as well. It's like the micro debrider, and we know that they recommended you to use it once, but many of us can use it for three or
Yes, sir.
similarly. I mean, but after a while, it's not as easy to use. The robot has become very much more expensive because the new robotic instruments have become very much more expensive. And especially if you use three, you would end up having a disposable cost of about $1,000, I would say.
Yes, sir. It costs around that much in India itself. Like 80,000
Hmm.
rupees is the cost for the consumables.
Hmm.
Okay, sir. Another thing, going to the world literature on the cows, Professor Morales Fernandez, he had published few papers, and some papers probably from Ames Delhi are coming up. So, sir, what are the other institute in India who started doing cows?
Which are the other institutions which have started doing TAOs?
Cows other than Ames Delhi in India?
So not too many. Vellore is doing a bit. TMS has done a few, very few. And in Calcutta, I was told they've done a couple of cases. But beyond that, I don't know. Kapil, you would know?
I feel there are only three of them. So Calcutta, I think there was live demonstration. I think you had only done in an FHNO conference 2 years back. And early experience, I think TMH has published as a small case series or case report. So it's picking up. But yes, right now there are very few.
And it's about the only the company, like it is the Olympic that the brand is also only one brand is making it, or there are other players also, those who are going to make these instruments or make it available all across India.
So it is being promoted primarily by Olympus, and they have a special equipment that they call the Thunder Beat, which is not just ultrasonic, but ultrasonic plus bipolar.
Yes, sir.
But and that is what we use.
Yes, sir.
But I can imagine you could use it with any of the laparoscopic ultrasonic
Ultrasonic
equipment. I mean, really,
scalpels.
they are it's quite same to the very similar to, but the scope and the scope and the stand,
Yes, sir.
that I'm not so sure anybody else has other than Olympus.
Presently, only that
And the retractor,
FK1 is being used, no, sir?
FK retractor, that is sort of
Exclusive.
unique to Olympus. But
Yes,
other
sir.
things, the Thunderbeat and Johnson makes there is
Harmonic.
Ligashore by Covidian, and then there are some other companies also which make this, so they are more or less overlapping.
Okay. But the retractor is still is the FK1 is still the trademark one. They haven't come up, like any other company hasn't come up with their retractors yet.
So FK is the most favored retractor. You can do with other console retractors also, but you will not get the same access. FK is the most favored. If you want to get into challenging situations, then the FK is certainly better. For basic situations, even a tonsil retractor works quite okay. So, I mean, if you had a tonsil retractor and you wanted to use uh, a harmonic scalpel, that would be okay, but you would need some kind of scope and scope holder. And the Olympus has a scope which is a flexible tip scope, which is slightly different from the other exoscopes that is available with stores and companies of that sort. So this is a flexible tip scope. So that gives you the advantage of looking down at an angle, while you can't do that with a rigid scope that others have.
Yes, sir.
So probably
Sir, last
sensible to at
question,
least
sir.
look at the.
Hello.
Hello.
Yes, Dr. Ishwar.
Hello. Hello. Just one more suggestion. You can extend the use of these towels to the sleep apnea or base of the tongue, where you can have this lingual tonsil or debulking the posterior part of the tongue,
Yeah,
or
yeah.
in sleep apnea.
No, it's a good suggestion. We haven't done it yet, but we will now that you
Dr.
have.
Fernandez has got a paper on this also, on the use of the on the tongue base. He has published a paper on the tongue base uses also, sir. Okay, sir, last question, sir. With your, like you had experience with the retroauricular approach to the thyroid, and now this through the peroral thyroid, sir, which one you prefer would would stay for longer or would take that test of time?
So it does seem that the transoral thyroidectomy is gaining more and more traction,
Yes, sir.
at least in Korea. The advantage being that you can go to both sides of the neck. When we come from retroauricular, it's a bit of a challenge to go to the other side. And we have generally restricted ourselves to hemithyroidectomies with remote access thyroidectomy. The issue with the transoral is that you can't get involved with bigger thyroid. So they generally say less than 2 centimeter. Now in Korea, you see most of the patients are ultrasonic detected nodules because they have a screening program. While in our case, in our situation, it's very unusual to have a less than 2 centimeter nodule.
Yes, sir.
So both are good. Transoral will probably win over retroauricular, but transoral has limitations with larger size nodules.
I agree, sir.
So just one last question, ma'am has sent me. You have experience with both robots and tools. So which did you think has lesser steep learning curve, and which was easier to master?
So in our case, we came to TAOS after doing TORS for 7-8 years.
Yeah.
So obviously, all the lessons that we had learned with TORS came to TAOS, and it was quite straightforward. But I think TORS is easier. TORS is I mean, you have to learn new anatomy, and TORS allows you to take your time, go slow because the instruments are nice there and stable. And TAOS can be more fatiguing because obviously when you work with long instruments with your arms, then it can be a little bit more fatiguing. So you should know what you're going to do. TAOS is a little bit, and as I said, TORS, you have 3 instruments which you can use if you're using a remote access thyroid or something. So you have someone to retract. I mean, basically you have one instrument which can retract the thyroid and you can do that. So TORS is probably a little bit simpler, but then of course, as surgeons, we don't always do only simple things. And TAOS has other advantages in terms of allowing you to get inside with very limited access. TORS needs bigger mouth opening. TAOS you can work with lesser mouth opening. TORS is easier, but far more expensive, and I think it's becoming too expensive for our specialty. And the other issue that is happening with TORS is that they are no longer supporting our specialty because initially when we started, we had 5 millimeter instruments,
Yes, sir.
and now they are not available anymore. So you have to use bigger instruments with TORS, and it's not as easy to do TORS with the bigger instruments as it was with the smaller instruments.
So probably it's an
thank-
international maybe policy, a company decision or something that they are not getting that much cases or that much business, that they are not too supportive for minimal invasive otolaryngology as a specialty. They are investing in other things, maybe cardiac surgery and all.
True, sir. Sir, thank you very much.
Thank you.
Thank you.
And it is such a, actually, sir, our topic is like recent advances, and TAOS is probably one of those. It has like fulfilled to the core, sir. Thank you, sir. Thank you, sir. It was a
Hello,
pleasure having.
thank you both of you.
Thank you, sir. Thank you, Kapil,
Thank
sir.
you so much.
Thank you, Amit. Thank you, ma'am.
Look forward to
I would invite our young.
Dr. Mathur's talk. Yes.
Yes, sir. So I would invite our young and dynamic Dr. Deepak Verma, the gold medalist from Safdarjung, to take over the proceedings from here. Dr. Deepak.
Nt. Mathur, Director and Additional DHS, Lady Harding Medical College and Associated Hospital, New Delhi. Before joining Lady Harding, Sir was Principal BMMC and Safdarjung Hospital for 4 years, and he has been a guiding light and examiner for UG and PG students for more than 32 years in different universities. Sir has more than 90 publications in national and international reputed journals, and uh, Sir has been recipient of many reputed fellowships, including WHO fellowship at prestigious House Ear Institute and ICMR fellowship for pediatric otolaryngology at Cincinnati Hospital, USA. Sir has special interest in pediatric otolaryngology and that too specifically in pediatric airway surgeries. And today he will share his experience in pediatric airway surgeries. And to moderate this session, I would like to invite Dr. Shashidhar, who is heading the Department of ENT at Artemis Hospital, Delhi. And Sir is also doing a pioneer work in pediatric airway surgery. I welcome you both. Sir, Dr. Shashi, are you there?
Thank you, Dr. Deepak.
Welcome, sir. Welcome.
To have me here for such a wonderful session. Dr. Alok's talk was mesmerizing.
Yes, sir.
And he has set the benchmark really high. So the pediatric people have to defend it right now. So I leave it on to my mentor, Dr. Mathur, to do that. Right, sir. We continue with it. Dr. Mathur needs no introduction. He is the most sought out person for pediatric ENT in the country.
Yes, sir. Mathur, sir, are you there?
Hello.
Hello. Sir,
Yeah,
we welcome you all.
Uh, are, are you able to see my slide, please?
Yes, sir. Yeah, we are.
Okay. Thank you, Dr. Deepak and Dr. Shashi, both of whom I know very well. And Shashi had been there with me for a long time, long back at Lady Harding as a student and then as a trainee. And Deepak, I've seen him grow when he came to us and what he is now. It's a real pleasure
Thank you, sir.
seeing
Thank
you
you.
both here.
Thank you,
And
sir.
thank you, Dr. Uma Garg, for having invited me for this wonderful webinar, which I had been watching since morning off and on. I had kept my laptop open all throughout, but I was attending in between. And this is the beauty of webinar, you know, that now earlier days you used to work 20 maximum 9 hours, 10 hours, then it came to 16 hours, 18 hours a day. But now you work 72 hours a day.
Right, sir.
So at one point of time, I was attending three meetings or the conferences or something. And this is the usual routine for last 8 or 9 months. So I do not know when this corona will go because corona has increased the number of hours that you put in professionally. Anyway, thank you very much. And I've been given entrusted with the task of talking about the pediatric airway. It is not possible to talk about pediatric airway in half an hour. So what I'll do is I'll just go through some important practical aspects of pediatric airway as I see. So like if this is a child and this is the strider, then it is very difficult to make out whether this is subglottic stenosis or it is laryngomalacia. Each one of us can have a guess. Yes, there are features of a stridor as and it can be labeled into one or the other, but nobody can be certain on this earth as to what sort of a stridor and what sort of a diagnosis it will be unless we peep in. So the answer especially in the pediatric stridor will come only with the scopy, because the stridor is of the low volume. Usually there is a high respiratory rate in children, may not follow the commands. These children will not listen to you, or they were so small that they will not understand, and there will be excessive cry. And therefore, it is not possible for certainly, with certainty, you can't say that this pediatric stridor has got what diagnosis. So, although there are characteristic sounds and little diagnostic use in isolation, but still, the stridor may be characteristic of the particular pathology, but it is not diagnostic, and therefore the answer will come only with the endoscopy. Now the question comes, which will have to be answered is, would you like to endoscope, do the scopy in every child? So so the answer is yes, but the problem is that most of the stridors will be laryngomalacia in children. So if you start doing scopy of every laryngomalacic child, then you will be doing nothing but just doing the scopy of a laryngomalacic child. And so it will take away so much of time, and you will be putting most of the children into unnecessary discomfort, and the parents and the families into unnecessary discomfort. And at the end of the day, finding the laryngomalacia. So that is not practical. And therefore, there has to be some answer to this question as to who should be scoped. Knowing fully well that most of the laryngomalacia in children will be, small children will be, most of the stridor in small children will be laryngomalacia. So who should be endoscoped? And therefore, the answer will come, how much you want to examine. It will depend on how close we are to a particular case of in the diagnosis based on the history and the examination. And the question will still remain how much to investigate, and it will depend on how close we are in a particular case to the diagnosis based on history and the clinical examination. So all the patients, all the children, small children who are with the stridor need not undergo endoscopy. And when you have to do endoscopy in your OPD, the flexible endoscopy under sedation in an endoscopy suite is quite a useful tool to have. And best way will be with the less than 2 millimeter diameter endoscope. And minimum aim of such an endoscopy, especially when you are looking at the febrile child, will be at least to see the epiglottis. Just see the epiglottis and come out. If the epiglottis is swollen and the child is febrile, diagnosis is made. If the epiglottis is not swollen, child is febrile and the stridor is there, almost the diagnosis is made. If you can go in further, fine. If you can't go, just come out. So in the febrile child, the diagnosis will go in 2 arms, and you will know whether it is epiglottitis or it is LTB. But in a non-febrile child, and the stridor, the question will still be there, and how to diagnose and how to manage will be a question, and that will be, you will be ruling out the subglottic stenosis, and other things will come into your diagnosis, whether it's obstructive cord palsy or it's a subglottic stenosis. So the history taking is important, and history taking and examination in the stridor cases go side by side, especially when you are dealing with the acute stridor. Don't go from one thing to another, like the whole history taking and then the examination. No, whenever you get any stridor case, even in adult, the history taking and the examination go side by side, even the investigations. So in severe cases, immediate management takes precedence That is, you have to stabilize the child before, and you have to ask two histories. Rather, one history is very important. That is history of foreign body. If there is a history of foreign body, it takes you to the other arm, and the whole management is entirely different, and it becomes easier to diagnose and to take it into one arm, and not much of investigations will be required. But if that foreign body history is not there, then of course you have to look into various things. So the presentation can be acute or gradually progressive. If it is acute, then and presenting just at birth, then it can be subglottic stenosis or laryngeal stenosis. If it is immediately after extubation following a prolonged intubation, then also the diagnosis is almost certain, and then it goes towards the stenosis. But if it is gradually progressive from mild to moderate with the added respiratory infection causing the respiratory distress, then that, or if it is gradual, then you may most of the time maybe treating it with the your pediatric colleague could be treating it as an asthma, but ultimately it turned out to be subglottic stenosis. So what should be there with you in your emergency room as well as in your OPD suite where you are seeing these children are these things, and all of these things are very important when you are managing any small child with the stridor, or in fact any stridor. So the pitfalls in the immediate management of acute severe stridor are that the cyanosis occurs late in children. While the child is waiting to be seen, the pulse oximeter and nebulization should be done, and that is often missed. We do not start nebulizing the child, especially a stridorless child who is febrile, should be immediately put on the ADR nebulization, so that by the time you are arranging for the things, ADR nebulization will not harm any child. So ADR nebulization is a life-saving thing, especially in a febrile child who has come with some infection. What to do, where to do, and who to do will always be a question. It will depend on how much you are trained, how comfortable you are, where you are practicing, and what sort of a facility you have. So you are the best judge, being the doctor in charge at that particular place, to answer all these three things. And each hospital, therefore, and each doctor working in that hospital should have his own protocol formulated to deal with these children with the stridor. Now, we know very well that if the diameter decreases by half, the distance increases by 16. And this is a Poisson's law. And I need not go in further in that. And these are the grades of obstruction. And we know about it from the Cincinnati Children's Hospital. Now, the volume of the stridor doesn't correlate very well with the amount of obstruction, and this we should know. If the stridor is small, you should not be complacent that the obstruction is less. If the stridor is more, you need not be taking it as if the obstruction is more. In fact, if the stridor was there and the volume goes down and of the obstruction, then that it's not a good sign. It just means that probably the conscious level of that child is going down, and he's putting in less effort, and probably going to collapse very soon. So extremely severe obstruction, of course, not only because of the exhaustion, but extremely severe obstruction will have no stridor at all. So if there is no lumen left, then how do you expect the stridor to be there? So if there is a foreign body, so to say, and it is completely obstructing the larynx, no stridor, just choking. So you must always assess the child with the position like this and the scopes like this. Of course, this is the patient who has got the trachea there. Otherwise, this is the usual position, and the usual draping on the child. And this is the photograph which I had taken, and it's there of David Albert and Scott Brown. And this is the acute severe stridor in a child, and with all these things, diagnosis and the history, and not in an acute child, and the chronic cases, the various line diagram. I had given it in the form of a template. Now, assessment with the endoscopy. There are few things that you can do. One is the microlaryngobronchoscopy. The other is microlaryngoscopy. The third is the flexible fibroscopy. MLB in general anesthesia with the endotracheal tube intubation, endotracheal tube reaching till the tip of the epiglottis, and with the Hopkins rod going in and out, with the video attachment, is the usual thing that you will do, and that was what was there in the photograph before. And this is the usual way that you assist the child, and this works very well. You must have ET tubes for the assessment, and I always carry in my bag whenever I go for the MLB, all the sizes of endotracheal tube, non-cup ones, so that I can assess and grade the stenosis. Microlaryngoscopy using the operating microscope is also a tool which should be there with you, many times it is very useful, but it doesn't replace the microlaryngobronchoscopy. The flexible fibroscopy endoscopy to assess the dynamics of the cords is the gold standard thing. Awake transnasal flexible laryngoscopy. That is the gold standard for diagnosing the vocal cord palsy, and that should be always there in your clinic whenever you want to diagnose the case of vocal cord palsy, because otherwise diagnosing a vocal cord palsy with the MLB, where the patient has gone into GA, it maybe sometimes you may be misdiagnosing it, because the window that you get for seeing the movement of the cord is so small. You have to wait for if you do the MLB for half an hour, that window comes only for 30 seconds. And if you have missed that window, then either there will be spasm beyond that, or there will be no movement of the cord before that, and you have to wait for 30 seconds period, that 30 second in your half an hour procedure to really assess on MLB, which is done in GA, the vocal cord movement. And that becomes a real challenging task. Now, if you have to do endoscopic assessment in subglottic stenosis, then it should be done. It can be done under general anesthesia, and the best way to do is that what you can do is that under GA, with the spontaneous respiration after larynx is well sprayed. So well sprayed larynx is the key. And I have seen one anesthetist in Great Ormond Street giving the patient so well to the surgeon that the surgeon could go in for good 20 minutes in and out with no tube inside, and the tube being placed at the tip of the epiglottis, but the larynx so well sprayed and kept at the level of the tip of the epiglottis, resting on the posterior pharyngeal wall after its withdrawal from the trachea, and with maintenance with the halothane or the sevoflurane and oxygen. And it is very much possible to do, even in the stridulous children, the MLBs prolonged for such a long time without a trachea. So not all the cases, but yes, many of the cases. So it's an art, and your anesthetist should be trained to give you patients like that. And a great team of a surgeon and anesthetist can can make your the scopies very good and going in for a longer time. And this is the tube, and these are the outer diameter and the inner diameter, and you should look for that audible leak which comes with a 10 to 25 centimeter of water of pressure. And that is the correct size of endotracheal tube, not this, when it is not leaking at all. So the correct size is when you give the pressure of 10 to 25 centimeter, that water, that some audible leak is there. And that tube size, if you have with you, that will give you the correct diameter of what is happening inside. And you can put it on the graph and plot it on the graph and know how much is the obstruction. And these diagrams are there till 6 years of age. Nobody has drawn the diagram beyond 6 years of age. And although we have tried to make a template beyond 6 years also, but usual diagrams are till the 6 years. So the subglottic stenosis in children, the aim of assessment is the degree, the length. Degree is not that important. In fact, length is more important, because if you are surgically correcting it, then the length will be more of a problem than the degree. The child's trachea or the subglottis, whatever resection is required or the dilatation is required, the challenge is the length, not the degree. Degree is no problem. You can dilate it, or once you cut it, the degree is gone. But the length is a problem, that how much you will resect or how much you will dilate, how long it will be, how long graft will it be, and the outcome of the surgery will ultimately depend on how long the length, how lengthy that subglottic stenosis was, not which degree it was. So long-term outcomes are only dependent on the length and not on the degree. The movement of the cord you have to see, and sometimes you will find that the movement is gone along with the subglottic stenosis. So that there are few cases where both the movement will not be there and the subglottic stenosis will also be there. So you have to pick up those also. The needle used for the assessment is very important, because you want to know the length of the cord, length of the obstruction, and therefore that needle, where you will pass in the needle from the neck above the stenosis, and if you can see, then below the stenosis also, and see where exactly the stenosis is. Radiology is never a surgeon's choice. In fact, I hardly do radiology in subglottic stenosis. It is of no use. It doesn't lead me anywhere. So I want to see it with my eyes. Where is the stenosis? How much is the stenosis? And that's it. So the surgeon wants reconstruction without further losing the airway. So the assessment is very important as to how long the stenosis is. Common mistakes we have already addressed in the endoscopic assessment. One more mistake which is done is passing the anterior glottic web, which is an anterior glottic shelf as an anterior glottic web. So anterior glottic shelf is a normal thing, and if you put your scope in at such an angle that anterior glottic shelf is in front of you, you may mistake it as a subglottic stenosis grade 1, or we may call it an anterior glottic web if you are doing the endoscopy for the first time. And therefore, that is the most common mistake made by the beginners. Passing grade 1 subglottic stenosis as normal or vice versa, therefore, is the most common mistake. And interpreting any movement of the at the level of the cord or the arytenoid or seen on FOL as a preclude the diagnosis of vocal cord palsy is also a mistake. So the most commonly done surgery, the procedure for the vocal cord palsy will be awake TNFL, and this is how you will do it. Our preferred treatment options are for grade 1, wait and watch, endoscopic dilatation or the laser for grade 1 and 2, open techniques, anterior cricoid split for grade 2 or grade 1, and LTR and the PCTR. So these are the commonly done surgeries, laryngotracheal reconstruction, partial precotracheal resection, tracheal resection, anastomosis for the airway surgeries whenever there is an stenosis. The medians, we do use the balloons and for the small stenosis, and the median size that we always we use, if although you have to have all the balloons with you. You can't have some few balloons and not have other sizes when you start. So median size used is 8 millimeter. Median pressure usually is 10 atmosphere. Mean inflation time is about a minute. Most cases are 4 to 5 years. Balloon diameter in millimeter equal to outer diameter of the age appropriate endotracheal tube +1, or for the subglottic stenosis, and +2 for the trachea. And well, we should all know how does the gum elastic bougie size correlate with the size of the tube. So we all know the gum elastic bougies are always the circumference. We are measuring when we are saying 26. That means that is the circumference. So it is pi d, 2 pi r. So pi d. So divided by 3 approximately, and you get the size of the balloon or the size of the tube that would be appropriate for that particular case, or vice versa. So these are the balloon sizes and the saline that you would like to inject into the balloon, inflate with the saline which you would like to inflate in the balloon. It is around 6 to 8 to 12 to 16 cc, and the maximum pressure that you will get with these balloons, you will get it written on the balloons which you will be using. Good thing is that the bad thing is that the balloons which we are using for the laryngeal dilatation, which were backed by the Acclarent, were available for a few years. Then they were completely withdrawn, and everything came to standstill. I do not know why it happened, but the good thing is that we have now our own balloons made in Gujarat by Merrill, and they are very good, and they have 1/10 of the cost, and they can be used. So, any use of mitomycin? Yes, there can be some use of mitomycin when you do it, though controversial. And I'll straight away go on to this slide, which the residents would be very much interested in knowing, that this is the position. Whenever you do any surgery onto the larynx or onto the subglottic stenosis, this is how the patient can be draped or positioned. First positioned and then draped. So we always make three compartments for the drape. One for the above, do endoscopy, one middle one for doing the surgery, and third one for the chest to take a graft. So 3 compartments, 3 drapes, and this is the position. And position can be best made with a plaster like this. We make our own stents even today. Though I have used all the stents, but still I prefer my own homemade stent with endotracheal tube, hermetically sealed from above, and it works very well. And this is how you should fix in a tube. After having done the tracheostomy or the surgery, if the double stage, your tube should be fixed. Tracheostomy tube should be fixed like this. Now, single stage, double stage, and hybrid. I just will go. This is my last. I'll take it as my last slide. When do you call it single stage? When do you call it double stage? Single stage is when the patient is going out of your theater with no tracheostomy tube. That is single stage. So the requirement will be the patient will go out of the theater with endotracheal tube. Whatever you have done, whether you have done tracheal resection, or you have done subglottic stenosis repair, or you have done the LTR or PCTR, whatever, if the patient is going without a tracheostomy, it is single stage. If the patient is going with the trache, it is double stage. So no confusion. Now, there is one more thing which is called 1.5 stage LTR. That is a hybrid. And that is what we have started doing. And this is a very good thing that has happened, I tell you. This is a miracle. And this has answered most of the problems that I faced as a single stage surgeon for a long time. At one, you will get a call at 4 o'clock in the night or 3 o'clock at the night. You'll travel 7 kilometers, 6 kilometers from your home with a speed of 160 kilometers per hour to reach the ICU where you find the child has been extubated who had been operated a day before. And we have lost a case like that. And this is the worst thing. And this will happen. Don't think that the patient will get extubated in the post-operative period sometimes. It will be the regular routine. Every case you will operate has the potential of getting accidentally extubated at night. It will not be, sometimes it will happen. It will happen more often than not. So be prepared for it. And therefore, there had always been the confusion that whether we should at all do single stage or it is better to do double stage and not have these sleepless nights. In spite of everything, we kept on doing single stage. Till the time that now we have a hybrid. And the hybrid is a very good sort of a answer to this single stage, double stage. And this is how it is. Though it came in 2013, this. So this is a small tube. This can be there along the side with the endotracheal tube from above. If the endotracheal tube by chance gets blocked or comes out, this will take care. And we have started doing this, and it works very well. It takes away my fear of driving at a highest speed night. I get some time before I reach. This tube will take care, and by the time you get enough time to put your tube from above, this acts as a additional sort of a gadget to tide over the time when the child could be just apneic. So thank you very much.
Thank
Over
you, sir.
to you.
Thank you, sir. That was a very good talk, and it kind of laid the foundations at what we should do and what we should not. One of the very common reasons why the flexible fiber optic is not done is simply because of the availability of this, mostly in peripheral institutes or even in good institutes. It would be locked up somewhere in the OT or some place and not available in the OPD settings. Now, there's a huge literature on using ultrasound as a preliminary diagnostic tool for screening for stridor patients. Do you recommend people who do not have fiber optic laryngoscopy, they can get accustomed to them using ultrasound for vocal cord or subglottic or other pathologies?
Yeah, ultrasound is a good technique, and many people are using it. And in fact, ultrasound is being used for seeing the vocal cord paralysis. And so I'm sure there will be some, but it is to be done by the surgeon himself. So, but it's a very good tool. These days, in some of the countries, you will find that the ultrasound comes added to the examination, the OPD examination thing. So both for cases like this but you require a smaller probe, and it is very useful for the airway as well as for the thyroid. So ultrasound is the gadget which, and nowadays ultrasound, not only for the ENT, but you find ultrasound in every field as a method of examination. So the surgeons are carrying that. The anesthetist has got it. The ENTs should also have it. Everyone has. It's just like a stethoscope. It's no more an investigation anymore. So ultrasound should be there.
We could use your experience on foreign bodies, and being in Harding, we saw a huge series of foreign bodies removed by you, and you have trained all over the country several surgeons in removal of the foreign body. Now we see more and more the flexible pediatric pulmonologist or the regular pulmonologist trying to take the foreign bodies, and ENT per se, because of the risk aversion, have sort of giving it in their hands. Can you just give us a quick tips on how to deal with a serious ultrasound foreign body of the child with a severe stridor? What are the big no's which the ENT professional should not do? With all your experience, can you just give us few words of pearls of wisdom?
So the wisdom is that if you are dealing with the foreign bodies, you have to be the surgeon in charge. You have to be on the site. It cannot be done remotely. If this is acceptable to you as a surgeon, that on the day of your duty, you are available when this foreign body comes, because you have to do it. You can train people, but you have to be there. There is no time that this child will not give you time, that you are that some junior person is doing it, and he is not able to take out, then he will call you. It will not happen that way. So you have to be there. So the pearl of wisdom is that if you can't be available, don't do it. Don't pass it on to others to do it, because it will only bring bad name to you. So it is in your interest that don't ever say that you are a foreign body removal surgeon if you are unavailable.
Sir, am I audible?
Yeah.
Yeah.
Sir, so I just would add to that, sir. Actually, foreign body retrieval in a like as an ENT surgeon who is working far off from the metros, I think they should also take up this speciality, because sir, by the time patient reaches the metro, the chance of losing the child is high.
Absolutely.
And a good anesthetic, and I personally feel a good anesthetist is the only requirement with a reasonably skilled surgeon.
Absolutely. Yes, absolutely. Plus, I would like to add something to it, that if you are in a periphery and you want to refer the child with the foreign body to a center which is away from you, the slide which I showed you in the first OPD thing, at least send it after the nebulization. Give some nebulization with the ADR and then send, then transport the child. It will give it will give some, you will buy some time by the time the child reaches the place.
Yes, sir. Yes, sir. Yes, sir. Dr. Deepak.
मैम
डॉक्टर माथुर सर,
ये एकदम ऐसे जैसे रस्सी होती है वैसे बने हुए हैं ना मैम?
हेलो sir, how to decide whether the child requires single stage reconstruction or double stage? That is that decision is taken on table, or that is a pre-operative decision?
That is usually the policy decision. See, there are always there are definite advantages of single stage. That one window surgery, the trachea is not there, so you can have more, the airway with you as a surgeon, so to say, and so single stage otherwise is preferred, except for the fear that it may get blocked. And also, if it is if the stenosis had been very marked stenosis and a long stenosis, and the length of the stenosis was long and it was, say, grade 4, I would go in for the double stage.
Okay.
But if it is not, if the length is less, manageable till grade 3, I'll prefer single stage. But then logistics have to be worked out. These days, I have started doing hybrid.
Okay, sir. And so, like after reconstruction, the child is shifted to ICU with endotracheal tube in situ. And sir, how to decide this child requires decannulation? How after how many days we can remove the endotracheal tube? And
Sorry, I'll missed your voice.
sir, after doing reconstruction, when the child is shifted to ICU,
Yeah.
after how many days we can remove the endotracheal?
So yeah, so we in the single stage we are now. Earlier days we were removing the tube. You know, when the single stage was started world over, the children were paralyzed for about a week or more. 7 days to 10 days was the time for which they were paralyzed, and then the tube was removed. That was when we started doing, and during that period only I was at Great Ormond Street. So all children were paralyzed for about 7 days. Nowadays, it has gone down. The average period is 3 days.
Okay, sir. Thank you, sir. Dr. Shashi, what kind of stenting you are using in your institute?
So we have tried everything. Now we are lucky to get Rutter stent from as a donation from the Cincinnati people. But what works, like Dr. Mathur has said, McEnroe's ET tube works well. We fashion it into Alboca. The softest material available is a North Pole or a South Pole tube, which is bluish in color. That makes a softer stent. Also, you have to decide how long you want to keep the stent. If you're planning to keep it for a mellitic segment, then you don't need a softer tube. You need actually a hard tube. Whereas the stent is just to give ventilation, then T tubes are probably the best material because they just do the job and help you in suction cleaning and everything. So it will always depend on how long you want to keep the stent, and if it's near the subglottis, silicone is the preferred material. But if it's in the trachea, anything will do. Typically, there's a good literature now which says for complex lesions, keeping the stent longer wins. The success rate is higher, which is the longer is like 3 months. For that, the material really matters. But most of the time in practical field, when you're not doing very complex cases and your intubation time is less than 2 weeks for a stent or other things, even if you put a posterior graft, any stent works all right. But if your duration is less, longer, you would want to really have a good material.
And what is your experience with laser in, as a treatment modality in subglottic stenosis?
Absolute no. Absolute no.
The lasers are usually not preferred in children, though lasers will be useful. Like just last week we had one child. Lasers will be useful in stenosis or repair of the stenosis when you have done the repair and then there is, say, a suprastomal granulation, some collapse which you want to laserize. The secondary effect of your surgery. Lasers will be useful.
And sir, what about the coblation, sir? Coblation in the
Both
glottic
coblation
stenosis,
as laser.
stenosis?
Yeah, coblation will be good enough. Good enough.
Because there has been a lot of work which has been worked up. Probably PGI people are doing it. SMS they have started doing coblation and found reasonable work with.
Yes, sir. See, advantage with the coblation will be that these days coblation are coming up with good long probes.
Yes, sir, they've got the. they've got the laryngeal ones also, sir.
So yeah, so it reaches there and it works very well. But then these days, earlier days, CO2 laser was not with the fiber.
Now they have
It's
got
a very
fibrolase.
yes. It is a but it is a discovery which was which happened about only 2 years back.
Yes, sir.
Or
Yes,
3
only
years
3 years
back, and it is
Yes, sir.
world over. You get the fiber CO2, the fiber.
Yes, it has taken over the world of laser, sir. Yes, sir.
Yes. So now it's very easy. Now it's very easy. The CO2 fiber, we used. I mean, it reaches wherever you want, and it just laserizes. So, but still, coablation and laser would do equally good for tackling this problem of suprastomal some granulations here and there, but not as a primary surgery of completely laserizing and dilating, and you think that it will happen, that the airway will be okay. It will never be. It will be okay on the table. It will be the same after 3 weeks.
Certainly, sir. Certainly.
Sir,
So for the benefit of others, can you tell us the difference between a hybrid LTR and a double stage LTR? You had one slide there, but
Yeah. So the hybrid LTR is a good compromise, step down from double stage, going to the advantages of all double stage as well as single stage.
The difference between the hybrid LTR and a double stage LTR.
2 tubes.
Okay.
One from the single stage tube, endotracheal tube from above, and small tube from trachea side from below.
Okay.
Sir, what is the follow-up period for these patients after doing surgery? For how many days these patients should be kept in follow-up?
Sorry?
Sir, what is the follow-up period for these patients? For how many days?
It varies. It varies. Usually, single stage, there had been instances that the single stage went home and never came and is doing fine. But there will be instances when usually the single stage will not require much of a follow-up if the repair had been good. Rather hardly a follow-up. Double stage will definitely require follow-ups because there will be issues like granulations, suprastomal collapse, things like that, which have to be tackled. Which can be tackled, but yes, they will require more MLBs to an extent that double stage LTR or CTR will require 3 or 4 scopies after the surgery.
Thank you so much, sir, for sparing your time for this webinar.
Yeah.
Thank you, Dr.
Sir,
Shashidhar.
I'm so busy.
Thank you.
Yeah. Thank you,
Now, I would
Shashidhar.
like to invite Dr. Amit for vote of thanks to the audience, speakers, and all the delegates.
Thank you, Dr. Deepak. Thank you. I humbly thank everyone who was involved with us, starting from our director, worthy director, sir, APS Batra, sir, our HOD, Dr. Uma ma'am, my whole department, all our residents, senior residents, Manish, Ranveer, specifically, they really worked very hard for this. Our staff, and I sincerely thanks all the patients who gave us such an experience so that we could discuss all this. I thank everyone, and I wish everyone to have a great weekend. Thank you. Thank you, everyone. Thank you.
Thank you. Thank you so much.
Thank you, sir. Thank you.